ideas, and experiences here will enhance our skills and ultimately improve patient outcomes. On behalf of the organizing committee, I extend my sincere gratitude to all our respected speakers and participants for your presence and contribution. Wishing everyone a meaningful, engaging, and academically enriching conference. With immense pride and profound honor that I rise to extend a grand and powerful welcome to our esteemed head of the Department of Emergency Medicine, Dr. Sai Surender, a true lion of our institution, whose presence commands respect and whose leadership inspires excellence. Our respected HOD stands as a symbol of uncaring determination, fearless decision making, unmatched clinical brilliance. Like a lion, calm in composure, fierce in action, and protective of the team. You lead with authority, resilience, and heart. Under your dynamic leadership, the department has not only grown but has grown to prominence, setting benchmarks in patient care, academic excellence, and emergency preparedness. Your vision has shaped not just a department but a generation of confident and capable emergency physicians. Let us welcome Dr. Sai Surender sir, head of Emergency Medicine, Dr. Kamakshi Memorial.
Good morning. சத்தியமா நான் இந்த இன்ட்ரோலாம் கொடுக்க சொல்லல. தேசிய மக்கள் யாரும் தப்பா நினைக்க வேணாம். அனைவருக்கும் வணக்கம். Good morning to all the distinguished guests, respected faculty members, dear colleagues, and our always enthusiastic delegates. It gives me immense pleasure, pride, and honor to represent Kamakshi Memorial Hospital in KEMCON. KEMCON is not just an emergency medicine conference, it's our hospital's annual conference. Why do I say that? Because emergency, we want to prove this, that emergency medicine is a mixture of all specialties. So every faculty or every consultant from all specialties in our hospital have this platform to present, to interact with the ever enthusiastic delegates who are going to be the future of tomorrow's healthcare. Emergency medicine stands as the backbone of acute care in any healthcare system. It is the front door of any hospital. And emergency medicine is a hospital by itself, the emergency department. We see patients, we treat them, we admit them, and we also discharge them. The entire success of emergency medicine depends on first the team, the ground force, starting from the security personnel of the emergency room to the emergency staff nurse, the paramedic, the emergency doctor, and definitely all our supporting consultants, and of course the management of our hospital, without which we will not be able to practice such good emergency medicine practices. Every minute matters in the emergency department, and decisions taken there often determine the outcome of a patient. Conferences like KEMCON provide an excellent platform for clinician researchers and students to come together, share knowledge, exchange ideas, and learn the latest developments in emergency care. We started this conference as a very small CME, but today it has become one of the most sought after and anticipated conferences in Chennai for emergency medicine. And we take extreme pride in that. Yesterday we had a workshop with more than 12 to 14 workstations, which had a platform for 150 to 200 delegates who attended this workshop for the first time, and we were able to run this conference at a very shoestring budget because of the support from our management. So it covered from ABG, ECG to ventilators to all types of emergency procedures like echo. All these workshops individually will span for a day, but our faculties were made it into a tailor-made content which had every workstation shortened into 45 minutes. So hope we were able to give you a very good knowledge on all the workstations yesterday. With that feeling, we would like to start the KEMCON today. So today we have all talks lined up, all faculties have come. So with this small introductory note, I welcome you all once again to KEMCON 2026. Thank you.
Good morning, delegates. So, with no further delay, let's move on to the session. I welcome the Master of Medicine, Clinical Commander, Diagnostic Genius, Lifeline Physician, Dr. Priya, Head of General Medicine, to deliver a talk on diagnostic dilemmas in emergency medicine. Welcome, ma'am.
Next has it. Okay. Good morning. Is it audible? Mic work avaleeda? Good morning. It's a warm welcome as a part of Kamakshi Memorial Hospital. Why I have choose the topic spot the diagnosis. You are the first people who are entering most of the patients. It's whatever the cases I am posting here is what we have seen in our emergency medicine over the period of 6 months. First, First case is a fever with myalgia for more than 4 days. This is what we are commonly seeing perennially, and sometimes we are having the outbreaks also. This is the classical presentation of the patients with a fever with myalgia for more than 4 days. Patient is having exanthematous rashes, and we can able to see the finger sign. This is the classical petite what we are seeing. So the diagnosis is, what is the diagnosis? Fever, myalgia, exanthematous, erythematous rashes, dengue. What we are seeing is the dengue. So these are the patient's clinical finding. Patient's supine BP is 100/70, standing BP is 80/60, and HB is 16.4, PCV is 52, platelet is 120, and SGOT is 700 SGOT-PT, and creatinine is 1.2. Any other thing can be able to make out with this lab investigations? Patient is going for the dengue hemorrhagic shock. The patient's having the wide difference in the BP with supine and standing BP. There is the narrowing of the pulse pressure, and the patient is having the hemo concentration, and creatinine is also the rising trend, and SGOT-PT is nearing 1000. So we should know whenever you are approaching the dengue, whether we are seeing the stable patients, or where patient needs ICU care, or patient how much fluid management the patient should have. This is commonly what we are seeing in our emergency department, which investigations we have to send in the dengue. If the patient comes under which phase of illness, based on that only you have to send the investigation. If it is a primary dengue, initially the initial 5 to 7 days, the NS1 may be positive. The IgM appear later, 5th day onwards, and IgG will appear still later. But if it is a secondary dengue, the NS1 will be little faster, and IgG will appear even before the IgM. So which phase of illness the patient is presenting, you have to send the investigation. Don't send dengue complete profile from day 1 onwards. If the patient is presenting within 5 days, if you are strongly suspecting the secondary dengue, you do the IgG also. Otherwise, dengue NS1 alone will do. Later, you have to follow up with the IgM and IgG. Then only you will get the proper diagnosis. So this is the severe criteria for the dengue. The patient presenting with any vitals hemodynamically unstable. Patient is having maybe tachycardia, BP, patient may have hypotension. And one most important thing is the standing BP. Even in ward rounds, if the patient you feel good, but if you look into the standing BP, there is a narrowing of the pulse pressure or the fall in the BP, you have to keep the patients very carefully. The patient may go for any time endothelial leak. So, and whenever you are seeing the SGOT-PT elevation more than 1000, there is a high chances of the severe dengue. So next case is the fever with for more than 6 days, and patient presented with a sudden onset of worsening dyspnea and reduced urine output. Always you have to search for the sign. What is this sign? Eschar. So it is a classical scrub typhus. Scrub typhus, one thing you have to look for the eschar. Patient won't tell because it's a painless condition. Unless if you look and if you ask, then only you can able to get the eschar. And another important thing, you have to know the epidemiology. In and around Chennai, from which place the patient is come from. In our Chennai, urban areas, most of the cases from the Kuduvanjeri. If the patient is telling they are from the Kuduvanjeri, there is a high chances of scrub is there. You have to search for the eschar. And Madipakam and Rajakelpakam area also, we are having the more scrub cases here. So you should know the background of the patient, where they are coming from. And another thing, some cases the the eschar may not be visible as like this. So you have to look for the regional lymphadenopathy. Sometimes from lymphadenopathy may be easily picked up rather than the eschar. So always you have to search for the regional lymphadenopathy, especially if the patient is having eschar behind the nape of the neck or the groin area or the skin covered area. You may not be able to pick up the eschar very clearly. That case you have to go with the regional lymph nodes, then you have to search for the eschar. So this is the classical ARDS picture. If you are not addressing the scrub initially, which was easily treatable with the simple doxycycline, you may land up the patient with ARDS. So for a scrub also, you have to look for the warning signs. Patient can present with multi-organ dysfunction. Any form of complication, head to foot, you can encounter in the scrub. So yearly diagnosis is mandatory, and at the onset, yearly treatment is also mandatory. So this also we have seen in the last 3 months period in our casualty only. Elderly female with uncontrolled DM, classically they have presented with skin lesion over the forehead, only involve the left side of the forehead, and there is the eye involvement is also there. There is a congestion of the eye, and if you look into carefully, there will be the involvement of the cornea, keratitis also. What is this case? Herpes zoster ophthalmicus. So this also the emergency. If you are not diagnosed at the earliest, we may lose the vision also. Whenever the patient is immunocompromised, uncontrolled DM, you have to strongly see and suspect. And it's the classical involvement of the ophthalmic division of the trigeminal nerve. Hutchinson sign, you have to look for if the nose tip is involved, there is increased risk of ophthalmic complication. You have to get the ophthal opinion at the earliest. Patient need topical as well as the systemic antiviral along with steroids, topical steroids. So, and we have to stress the importance of diabetic control along with the proper vaccination to prevent the further recurrence. This also we have seen for past 6 months so many cases, classical presentation of fever, throat pain for more than 2 weeks, and they will present with only dry cough. They won't have the proper protective sputum. They will have only dry cough. Posterior cervical node involvement, and this is the bilateral tonsillar involvement. You can able to see the bilateral tonsillitis with this small membrane. It's more likely look like follicular tonsillitis, and this is after the treatment. I am giving further clue. This is the clinical examination: fever, throat pain, cervical lymphadenopathy, and moderate splenomegaly. If you look into the TC, it's all around 11,000, and they will have lymphocyte predominance. Lymphocyte is 56%, and atypical lymphocytes is almost 14%, and there is a mild SGOT-PT elevation. Diagnosis: infectious mononucleosis. We used to have the tendency to start the antibiotic once we start the bilateral tonsillitis, but always you have to look into the blood picture. If they are having the atypical lymphocytes, lymphocyte predominance, SGOT-PT elevation, that to young groups, college going students, school age group, you have to definitely think of the infectious mononucleosis. It's a easily picked up condition and treatable condition. If you are not picked up properly, they will end up in massive splenomegaly and splenic rupture. So this is our duty to find it at the earliest phase. This is classical infectious mononucleosis caused by the Epstein-Barr virus. They will have a long incubation period, fever, throat road lymphadenopathy, splenomegaly. Always if the patient is having high lymphocyte with this bilateral tonsillitis background, you have to think of infectious mononucleosis, and you have to send for the nuclear antigen and viral capsid antigen IgM to label the diagnosis. Mainly supportive treatment. If the patient is having significant lymphadenopathy, persistent cough, patient will respond with oral steroid. Next case, what we are doing, seeing day by day practice in your ear, sudden skin itchy lesions after having the seafood, especially the prawn. What is this? Acute urticarial reaction following the seafood, anaphylactic reaction. So this is the day by day. That also you have to address it very early phase to prevent the patient to land up in angioedema and anaphylactic shock. It's mostly it will be acute. The patient may have the underlying background of the past history. The drug of choice for anaphylaxis is the adrenaline. 0.3 to 0.5 ml is enough. If you can repeat, still the patient is getting the recovery along with the steroid. If the patient is still not responding, patient is already on beta blocker, glucagon also having the role to cover the anaphylactic shock. This also the important case, patient developed rapid skin lesion after 10 days of initiation of the new drug, especially you can consider it as the ATT or the anti-epileptic drug. These are the various skin manifestation of the Stevens-Johnson syndrome. There will be the definite mucosal involvement and the extensive skin involvement. Usually they will have the drug triggered environment, sulfonamides, anticonvulsants, anything like that. Less commonly even you can get in the mycoplasma infection also. If less than 10% of the body surface area involved, we'll call it as the SJS. If it is more than 30%, toxic epidermal necrolysis, there will be the overlap in 10 to 30%. They will classically present with high fever, sore throat, myalgia and abrupt skin eruption. It's a rapidly progressive skin lesion. They will have the tender, painful erythematous macules and often atypical targetoid. Target lesion, you will have the triple layers, triple marker. When atypical targetoid, you will have the only double and there will be no papillary, only macular lesion they will have. Flaccid bulla also will be there. So they will have the universal mucosal involvement, including oral conjunctivitis and genital ulcer. Always you have to think of SJS, and Nichols's sign will be also positive. Steroid is the mainstay of treatment and withdrawing the offending drug. This case, it's a 17-year-old male boy with a fever for 2 weeks and moderate to high grade, sometimes touching the baseline. He presented with the pain abdomen and generalized rashes with itching and yellowish discoloration of the eye, skin and urine. And history of multiple antibiotics over 2 weeks. And he was treated for with the dapsone for lower limb eczema. He presented with the fever, fever, rashes and liver involvement. His preliminary workup showed the leukocytosis and there is the elevated almost total bilirubin is 8, SGOTBT is around 600. There is a raised inflammatory marker also. He had the hepatomegaly with splenomegaly. This is the classical skin presentation of that patient. He is even having icterus skin also. That's why there is a yellowish discoloration, non-involved area. There is the rashes along with icterus is there. This is the classical DRUS syndrome after starting the dapsone for the eczema. Whenever you are seeing the DRUS syndrome, you have to put the Registrar score, whether he is fitting under the DRUS or not. This is the score, we involve the fever, lymph node, atypical lymphocytes, eosinophilia, skin rashes, how much extent it's having, more than 50% of the body or not. And biopsy, if still you are not able to get the diagnosis, and internal organ involvement and how it resolves, and other diagnosis has excluded. We have to exclude, in this case he presented with a fever, so we have to exclude the lepto also as a tropical disease. It's a classical presentation of lepto also. So after excluding the other diagnosis, you have to label the DRUS. Patient was managed with the IV steroid and gradually he has improved over a period of 1 month. The LFT has settled over a period of 1 month. So especially in dapsone, you won't get the proper eosinophilia. You will have some clues for the DRUS. The eosinophil level will be high. If the serum eosinophil is also not high, you can check for the urinary eosinophil. Urinary eosinophil also may be high. Some cases you may not have the proper hypereosinophilia in the blood. That's one of the most common is the dapsone. Dapsone won't present with the classical eosinophilia, and lamotrigine also maybe without eosinophil it can present with the DRUS syndrome. So always the past history, what are the drugs patient is on, and even what are the alternate medicine patient is on. Some cases it can be due to the patient may have taken for some Ayurveda treatment for the jaundice. They will have the worsening of the acute skin reaction also. So always the drug history is most important whenever you are seeing the case. Next case is the 40-year-old with nil comorbidities. He presented with a pain abdomen, loose stools, and he had given the history of melena also, and there is the painful lesion in the bilateral lower limb. This is the classical presentation of the bilateral lower limb painful vasculitis lesion. We can call it as the classical vasculitis lesion. On further evaluation, all the ANA, CANCA, PANCA came negative. We have done the biopsy, skin biopsy, turned out to be the leukocytoclastic vasculitis. So any patient with bilateral lower limb skin involvement, you have to suspect the HSP also. It can present with only acute abdomen also. You have to search for the skin lesion. If the patient correlating with the skin and the acute abdomen and melena, there is a high chances of any leukocytoclastic vasculitis. If it is the younger age group, HSP, Henox condyline purpura, is the one of the important diagnosis. So this patient usually well respond to the steroid, and 1 month later the same patient presented with a severe, because he has stopped the medication, he presented with a severe acute abdomen and bleeding PR, and this is the endoscopy finding of the same patient. What the lesion in the skin, you can have the same lesion in the GI mucosa, whole GI mucosa also. So this time the patient was treated with pulse steroid and he was discharged with the oral steroid. So this is the group of vasculitis. It can present with acute emergency also. Even Wegener's also can present with acute emergency. They will have the cavitary consolidation, bilateral waxing and waning type of the lung involvement. So you have to rule out. Even bitches also present with acute emergency with severe oral ulcers. You have to think of all the DDs whenever you are seeing the classical manifestation. Next case is the elderly female with a skin lesion for 10 days, no prodromal symptoms, known case of DM on Ayurvedic supplement. This is the classical presentation of the diagnosis. Elderly female on Ayurvedic supplement with a classical bulla. This is the bullous pemphigoid. So bullous pemphigoid is also the extensive skin involvement. They will present very badly upfront. So you have to be able to differentiate bullous pemphigoid, pemphigus and dermatitis herpetiformis. Pemphigus, there will be the definite oral mucosal involvement will be there. In bullous, oral mucosa and the genital mucosa won't get involved. And you will have the tense bulla in the bullous pemphigoid. In pemphigus vulgaris, there is the flaccid bulla. That's why the Nicolsi sign is positive there. And treatment is more or less same. You are going to treat with the steroid. This is the first one is the bullous pemphigoid. What our case? This is the example for the pemphigus. There will be the definite mucosal involvement will be there. And this is the dermatitis herpetiformis. They will have only the extensor involvement. Gluten-free diet is enough for the dermatitis herpetiformis. This is also a very interesting case. Elderly diabetic male presented with a fever for 2 weeks with the skin lesions associated with the swelling of the limbs. You can able to see the whole dorsal aspect of the hand swelling, and there is the classical erythematous lesion in the fingers. What is the diagnosis? The classical presentation of the erysipelas. So this is the male, elderly male, diabetic male presented with the classical skin involvement, most common caused by the Streptococcus biagens, easily treatable with a simple first generation, second generation cephalosporins. If it is MRSA risk is there, then only they need vancomycin or linezolid. This is another case which is present. It's a known case of vitiligo, 57-year-old male. He presented with a 2 weeks history of infected wound over the right middle toe, followed by there is a pustular, painful pustular lash all over the, it started from the lower limb, it ascended till the whole body, and he had painful oral ulcers also. There is no involvement of the genital or ocular symptoms or arthritis. This is the presentation of the that patient's full papular lesion, and he had severe oral mucosal ulcer also. And this is the primary wound. From where this middle toe he is having the some local wound, he left untreated. the primary lesion has gone the diffuse systemic involvement. Even he presented with the neutropenia, and initially we thought we are dealing with some blood malignancies. Finally, it turned out to be the MRSA infection. He had MRSA infection of the local wound. It ascended into the systemic. It has manifested with the diffuse skin involvement and pancytopenia. And we have done the extensive workup to rule out all other immunocompromised status also. Finally, he responded with teicoplanin. He was treated with IV teicoplanin for 5 days, and he was discharged with the oral telisolid for 6 days. This is on follow-up. Here the oral lesions has getting cleared. So these are all these cases what we have presented here, or we have seen in the emergency department. Then we have worked up the case. So there is a definite role for the emergency physicians to label that you are the index. You are the index people. The whole history and everything. You are the primary who are addressing all the issue. It's your duty to take to guide us properly. So you should aware of all the basic things, and you have to approach the patients. Thanks for the year management for organizing the great talk.
Thank you, ma'am, for the wonderful talk. Next, I call upon Dr. R.K. R.S. sir to felicitate Dr. Priya, ma'am.
Thank you, sir. Thank you.
Thank you, sir. Thank you, ma'am. For the next session, I would like to call upon the guardian of ventilator, master of resuscitation, death challenger, pulse reviver, the code blue king, Dr. Devachandran, to give a talk on ICU without walls, extending critical care to the ED and vice versa.
So, good morning all. Thanks to Dr. Sai and his ED team for inviting us and giving us this opportunity. Just a quick show of hands, how many of you are practicing ED physicians? Not trainees, non-trainees in this room. Okay, all are trainees, okay, all right. Because this is more of an administrative kind of topic. Even if you are trainees, when you become practicing ED physicians, you need to know about this. So this is the overview of my talk. Why this topic? What is ICU without walls? How can this be delivered specific for emergency department? From ED, what can you contribute to critical care? Benefits and advantages of critical care without walls. Okay. So critical illness, it's a dynamic continuum. It is not like I have fever today and then I have critical illness for a few days and then I get better. It's not like that. Quite often critical illness starts at home, and then by the time they reach you, they are sick. You revive them, you put them in intensive care, they get better, they go home or they go to rehab or they die. The three outcomes happen. So depending upon how we pick them up, how soon we pick the critical illness, how good we resuscitate, and how good we care for them when they come to intensive care, the outcome varies. This is a kind of a nice graph that tells us, supposing a patient comes to the emergency department, you assess them, and if you pick the critical illness, you put them in the intensive care unit. In case if that is missed and if they go to the ward, let's say they go to the ward, you see the graph going up from the ward-based care. The green line is what you need to see. So there is a a blue horizontal area up and a yellow horizontal area down, and there's a border, clear border between the two. When the patient goes to the ward, instead of coming to intensive care, they worsen in the ward. It is picked up by outreach service if you have one in the ward, and eventually if they worsen, outreach picks up, comes to intensive care. Again, when the patient gets better, they go back to the ward. Again, they are followed up by outreach service, followed up by critical care team. Patient makes a recovery and goes home. This is what we call the critical care dynamic continuum. So this is ICU without walls is not new. It's not a new terminology at all. It's very, very old. A few years, this was mentioned by Peter Safar a couple of years before I was born. Okay. And who is going to tell me who this gentleman is? Trainees? Who was Peter Safar? Anybody? Yo. Nobody knows him? Well, he was the one that brought about cardiopulmonary resuscitation. The father of CPR. He's the father of CPR. Okay? So he survived the Holocaust, went to the US, taught CPR. Well, he practically invented ways of doing CPR, and he invented the Safar airway. And when you do BLS, you are taught head tilt, chin lift, correct? So this guy modified the original head tilt, chin lift, and that is whatever he modified is what we are using even today, 52 years after, correct? He lost his daughter, and he thought his daughter should have received better cardiopulmonary resuscitation. That is how he changed the CPR, and ACLS evolved after Peter Safar. Okay. And he mentioned this. You can read the sentences there. The most sophisticated intensive care, 1974, okay, became unnecessarily expensive terminal care when your pre-ICU system is uncoordinated or undeveloped. When I say pre-ICU system, that is my emergency department and my ward-based care. So if my emergency department, ward-based care, or not, if we don't coordinate ER and ICU, if there is no coordination between the two departments, ward and ICU, if there is no coordination, what happens to the ICU care? Becomes unnecessarily expensive and terminal. You're not going to do any good to those patients. Only if the care is continuum and coordinated, your patients are going to benefit. Okay, so ICU without walls was already mentioned by Peter Safar more than 50 years ago. So what does the data say? So you put a patient in the ward instead of putting the patient in the ICU. They should be coming to step down high dependency. Instead, they go to the ward. What happens to them? Why should we really identify the critical illness and put them in the ICU? What if you put them in the ward? If they end up going to the ward, their mortality increases by 1.5% per hour of delay in managing critical illness. Okay? If they are quite unwell, they go to the ward, and if it's not picked up by the ward, every hour of delay in pickup leads to an increase in mortality of 1.5%. Okay? If you pick it up by 12 hours, you've already increased the mortality by 20%. Okay, so that's the importance. You need to pick up critical illness as soon as you can and put them in the right place so they get the right care. That's the importance of this. And so who does the ICU? So this is not inside ICU, this is outside ICU. And who functions as the critical care physician? You. Correct? In picking up the critical illness, you function as the critical care physician. There's a general thought that ICU has 4 walls, it's more expensive, lots of lights, lots of monitors, lots of machines, lots of noise, very ill patients, crying families outside. So that's a general perception. No, that is not true. It is not a ward, it is actually the care that we deliver. Okay? Care that is delivered. You need not necessarily be a critical care physician to deliver the care. You just need to have an idea of what critical illness is all about. Okay? So if you are a trainee, you would have known if you diagnose the patient with sepsis, their mortality is 10%. If you miss the sepsis and wait till they develop septic shock and then diagnose the septic shock, the mortality of that is, anybody? I mean, nobody raised their hands when I asked who is a practicing ED physician. That means practically many of the people in this room are trainees. What's the mortality of septic shock? Ballpark figure? 40%. So if you pick sepsis, so I come in with cough, cold, fever, and you pick up sepsis, and you start treating me when you diagnose me with sepsis before I develop shock, my mortality is 10%. You miss that instance to treat me, you wait till I develop septic shock, wherein I develop hemodynamic disturbance, my blood pressure drops even after fluid resuscitation, my lactate goes up, and you pick it up at that time, my mortality becomes 4-fold. So if you are the patient, when would you want your doctor to pick the illness? When it is sepsis, not when it becomes septic shock. Correct? Yeah. If they present with septic shock, that's a different issue. If they present with fever, cough, cold, breathing difficulty, they're hypoxic, or they're not passing that much urine, etc., that is the time you pick up the problem. And that is the time they need invasive or better monitoring, I shouldn't say invasive, but better monitoring, better care. Not when they develop septic shock. So what about after critical illness? So this is before critical illness, I said. So if you put somebody in the ward by mistake, their mortality increases. So what about after? So I've treated a patient, I've moved them to the ward. If I give my input for another day or two, the outcomes are better. Even the patient is cared by somebody else. If I continue to give my input for a day or two till the transition happens, their chance of going back to ICU gets reduced. The readmission gets reduced if I continue to give my care. So, yes, we care for patients inside ICU. We extend an arm to help the ED. We extend an arm to help the ward as well. That's kind of summary of critical care without walls and how it is delivered. In our hospital, there is an EWS system, a news system, which many of the ED physicians also use across the world. So when a patient comes in, you score the physiological parameters, heart rate, blood pressure, saturation, how much oxygen they are needing, their temperature, their respiratory rate, and their conscious level. By using all these parameters, you come up with a score. If the score is beyond a particular number, they should not be going to the ward. If the score is beyond a particular number, they cannot be discharged from ED. If the score is beyond a particular number, they should go to intensive care. Okay? So if you categorize them correctly and if you put them in the right place for care, then the patient's chances of them deteriorating, it becomes very less. So that's EWS, the first one, EWS. And then in case if the patient in the ward worsens, then you should have a system to catch them, and that is called the medical emergency team. So that's the second. The third one, so early diagnosis, intervention, and management. And then they get moved to intensive care, they get ICU management, they go to the ward where they continue to where we continue to offer support, and then they go. This is the continuum. This is how we deliver care outside intensive care. I mentioned all of this. EWS has been shown to improve care and lower mortality, used by emergency as well to decide when to admit, when not to admit, when to move patients to the ward, when to move patients to ICU. Higher number of med calls. If you have med calls, a lot of med calls from the ward, that means the med system is working very well, and that has been shown to reduce the number of cardiac arrests in the wards, and as a result, the mortality is less. What is specific for ED? So I said, what is ICU without walls, which is basically extending the expertise to the emergency department, extending the expertise to the wards, and how you as ED physician can pick up patients that really need critical care, better monitoring, etc. So what is specific for you? So things that you need to remember. Critical illness is a time-sensitive condition. I mentioned sepsis, septic shock. Sepsis, you pick up at sepsis, mortality is 10%. You pick up, you miss to pick up sepsis, they develop septic shock, and then you pick up septic shock, mortality becomes 40%. So that is one example that I can give you. So it's a time-sensitive condition. It is potentially, many of the critical illnesses are potentially reversible if you pick them up early. And I mentioned this as well, starts before admission in most cases, and you all know the delays increase morbidity, mortality. So the last one is the one that I already mentioned. That's something, even if you forget whatever I've spoken in the last 10 minutes or so, last thing is, it's a common expectation, belief and practice that critical care is confined to ICU. Critical care is confined to those four walls. No, that's not true. It's delivered by you, by me, by other consultants in the ward. So it is a care that we deliver. It need not necessarily be within four walls. It's our expertise that gets delivered to the patient wherever they are. So first one, sepsis in the ED, and your patient comes in with suspected sepsis. If their care, if their stay in the emergency department is prolonged, for example, it takes time for you to evaluate them, takes time for you to get the imaging done. Billing is a problem, so they end up staying in the ED for longer. Patient has not decided whether to get the patient admitted, or the family has not decided whether the patient needs to get admitted or not. So if they end up staying in the emergency department for longer, what happens to them? So supposing I come with urosepsis and you start treating me for urosepsis, my family hasn't consented for admission yet, so you end up keeping me in the emergency department till my family makes a decision. What happens to me? If the care, the length of stay in the emergency department is under 4 hours, within 4 hours, if they make a decision, you treat me, you put me in the right spot, my mortality is lower. So the first line, okay? If the length of stay goes beyond 6 hours, you keep somebody in the emergency department for more than 6 hours, clearly the mortality increases. Okay? So as emergency physicians, what you can do is you can A, pick up critical illness early, B, move the patient as soon as possible after evaluation and initial management to the right ward, whether it is ward or ICU, to the right place in the hospital. What if you have a ventilated patient in the emergency department? That's first one is sepsis, non-ventilated. Second, so you've intubated somebody comes in with pneumonia, you intubated them, same thing happens, the family has not decided, you have to do many investigations, they go to CT, come back, you're waiting for all the forms that need to come from common practice, right, from the front office before you can move the patient out to the ICU or to the ward. What if that is the case? So clearly there is a cutoff, you can see the rock curve on the right. Up until 7 hours, so mortality, you see, if you are able to move the patient to a ward that manages ventilator, till about 7 hours, the mortality is 29%. If it extends beyond 7 hours, the death rate is 45%. There is a 16% spike in mortality if you keep ventilating a patient in the emergency department itself. Why is that? Can anyone tell me? Ventilator-associated conditions? Not this early. Yes, you can. Okay, so if you say ventilator-associated infection or conditions? infection, not this early. Conditions may be. Why is that? Better monitoring, yes. So monitoring, you have monitors, you have invasive monitoring in your emergency department. Your emergency resource base has, as good as a critical care bed space, right? So you have invasive monitors, you have ventilators, you have everything to hand. Then why does this happen? When you say monitoring, do you mean equipment or expertise? Yeah? When you say expertise, do you mean clinician expertise or nursing expertise? Yeah, both. Yeah, depending upon where you are. So in the intensive care, a patient is cared by a nurse. In the ED, you're running around, you're triaging, you have a patient in red, you have a patient in orange, you have a patient in green, you have a family screaming outside, somebody is in CT, somebody is in MRI, and you have to sort out a whole load of other things, right? So that is not the case in the ICU. There is a dedicated nurse for 1 or 2 patients, and their job is to monitor. It's the exact same monitor, exact same ventilator. The only thing is you have a specific person assigned for that particular patient. And if there is a change, they're going to intervene. That is going to lead to better outcomes. Now, when he said ventilator-associated condition, that is true. So if the patient bucks, the patient develops a pneumothorax, tube down the right side, there's a secretion blocking the tube. Those things are picked up quite easily if you have one-to-one monitoring. That is the only reason. Okay. So 7 hours is the cutoff. Now you know why you have, the 4 to 6 hours cutoff. You probably would have heard the ED waiting time should be kept below 6 hours. NHS follows 4 hours. Some other countries, it's 6 hours. Now you know why. So what about interventions in the ED? What are the things that emergency department does really well, and what are the things where they have to improve on? Emergency department very good at intubating patients at the right time. This is what the evidence says. If somebody comes in with airway problem, breathing problem, shock, low GCS and all, you're very good at securing the airway. Really good, okay? And you're very good at securing central lines. Number 2. When it comes to other interventions that are required in some situations, for example, arterial lines, what the study shows, as soon as the patient gets moved to intensive care, a step-down unit from the emergency department, they receive an arterial line in the intensive care. So emergency department physicians don't often utilize the invasive arterial monitoring. That's number 1. Number 2, lung protective ventilation. Although you have the knowledge of lung protective ventilation, how you should deliver lung protective ventilation, you cannot be there with the patient because you have so many other things to do in the ED, right? You cannot be there with the red patient all the time unless you are assigned to. So as a result, patients cannot get lung protective ventilation early. PEEP titration or optimizing. If patient is hypoxic, you cannot prone the patient in the ED. You end up keeping them supine on the ventilator for longer periods, and that leads to increased mortality. And infection control practices, unfortunately, cannot be practiced well in ED because of the situation. It's emergency. You just have to glove up and do things on many occasions, and infection control goes out of the window when you are dealing with an actual life-threatening emergency, and that can actually lead to worse outcomes. So that's kind of extending critical care to ED. So faster care, efficiency gains by reduced ICU usage, smarter ICU usage, and better outcomes. So if you follow, the sepsis protocols, number 1, ventilatory protocols, detecting critical illness early, moving patients to the right spot quite early, definitely that will help the critical care. So this is what kind of critical care in the ED is. And how can ED contribute? The critical care contributes to ED like this. And how can ED contribute to critical care? The opposite, vice versa, was the topic given to me. You are all extremely good at retrieving patients, correct? So if you get an ambulance call, you just go, assess. You are the ones that identify the critical illness at home. You are the ones that identify how good the patient is, can they be transferred or not. The good assessment gets done in the other hospital, clinic, home, etc. So at the time of retrieval, you decide what's the best care that should be given for the patient. Okay? Unless you do the best care there, they will not reach ED, they may not reach the hospital. So retrieval medicine is actually an extension of critical care done by the emergency physicians, whether it is land, air, whichever the way you retrieve. So you identify critical illness, you stabilize them before you move. Pre-hospital critical care. So it's kind of not exactly retrieval medicine. It's part of retrieval medicine. So supposing you have a head trauma. So whether you or your really trained paramedic guided by you goes and reaches the patient. If they secure the airway, give them fluid, make sure the patient does not drop blood pressure en route to the emergency department, that actually reduces the mortality of such patients. Okay? So that's kind of ED contribution to critical care. Trauma is something that is your domain. So you're all very good at managing trauma. So if you know your ATLS principles, if you do a fantastic primary survey, you do your ABCD very well, and you stabilize the patient, you activate MTP, resuscitate, give the tranexamic acid early for head injuries and trauma that is kind of coming in early within 3 hours, then that is a contribution to critical care. So ED contribution to critical care. Following some of the bundles, it may not be possible to follow all the bundles in the emergency department. Some of the bundles, like sepsis bundles, when they come in, the first 3 hours resuscitation. Following the sepsis bundle, the new sepsis guidelines is out last week. It was published. I know there's a kind of American College of Emergency Physicians are not happy with the new sepsis guidelines. They want to form their own guidelines, so you might get the emergency physician sepsis guidelines separately. But still, it doesn't matter. The colleges are fighting. We don't necessarily need to fight. We should work towards improving patients. Lung protective ventilation, that's why you had the workshops yesterday, to learn about what lung protective ventilation is, how can you optimize oxygenation, how can you optimize PEEP in the emergency department while you're waiting for that bed in the ICU. Finally, there are ED ICU models. If there are no ICU beds, you park the patient in the ED for some more time till you get an ICU bed. Till that time, you continue the ICU care in the emergency department itself. That's kind of ED ICU model. And these are the ways ED can contribute to critical care. So in summary, critical illness is a continuum. And this is not a new terminology at all. It's as old as I am. Many decades ago, Peter Safar talked about this, and it is all about identifying critical illness early in the emergency ward, moving the patient to intensive care early, resuscitating the patients early, knowing your bundles, avoiding unnecessary delays, and thinking of the little things like lung protective ventilation, infection control practices, etc. Okay. Any questions?
Thank you so much, sir. I request Dr. Sendil, sir, to felicitate Dr. Deva, sir.
Malaya. Thank you, sir. Thank you, sir. Thank you, sir.
Thank you so much, sir. I request the Lady of Sedation, the Silent Stabilizer, the Pain Eraser, Dr. Chitra, anesthetist, to give a talk on sedation savvy and airway alchemy, anesthesia pearls for emergency doctors. Welcome, ma'am.
Oh, sorry. Thank you.
No.
The live stream mic opening.
Sorry. Click பண்ணிக்கணும். Good morning, everyone. Thank you for having me here. I don't think that description does a lot of justice. I mean, pain, eraser, and all of it seems an overkill. So today I'm not here to teach anything. Rather, I'm just here to give you a perspective from an anesthesiologist's viewpoint as to how airway and sedation can be managed in the ER. So when it comes to us, we trust the ER as well as the ICU, to intubate really well, to take care of the patients, stabilize and get them to us in case of a trauma or a surgical need. So what would you all say is a good airway, or an airway that you find easy to intubate or secure? All of you have intubated, no? All of you intubate routinely. So what airway is the easiest airway? Do you find trauma airway the easiest, or burns airway, or any thoughts? Which airway have you personally found it to be easy to intubate in the ER? Stroke cases. Okay. Any other options, any other answers or any other thoughts? This is not a question answer session. I'm just getting your thoughts across so that I can articulate mine better. Any other thoughts? Any other airways that you found easy to secure in the ER? So personally, what I would say is any airway that is secured before it becomes a difficult airway is an easy airway. So you anticipate, secure the airway, and then it becomes an easy airway. Anything you do not anticipate, you are not prepared for, you do not secure, it has the potential to evolve into a disastrous situation right in front of you. And in ER, that takes just seconds to happen. So what am I going to talk about today? Just a few points on how to better secure the airway, or rather organize your thoughts. What are the gadgets that I would personally use, and a few points on sedation. Please feel free to interrupt me anytime in case you have any questions or you want to clarify something. So why do we need to focus on the airway? So I believe as an anesthesiologist, I would always say airway, airway, airway. No matter what anybody else says, airway is primarily most important to us. So airway management is the cornerstone of resuscitation, and it is a defining skill for the ER physician. So always we have the dilemma, when do I intubate? When do I not intubate? So we don't have that question hovering over our head. All the cases that come to us, by virtue of providing anesthesia, we do intubate. So for us, the query comes when to extubate. But for you all, the question that hangs over your head always is, when do I intubate? And also preparedness for airway handling, and what are the pointers to a difficult airway. So according to me, when to intubate? Whenever there is a failure to maintain the airway, whenever there is a failure to protect the airway, as someone said, stroke or any head injury where there is a risk of aspiration, trauma, also failure of ventilation and oxygenation, as you would see in case of type 1 failures or type 2 failures. Early anticipation of the clinical course. You have a patient with polytrauma who does not have definitive airway involvement, but you're sure that he's going to go in for multiple surgeries, he needs massive resuscitation, or septic shock, where you know that this patient would do better with controlled ventilation. So these are a few pointers as to when to intubate. So again, I'm sure you all have protocols, different protocols in your ER that you follow as to when to intubate. So A is for airway protection, that is in case of airway aspiration or obstruction. B stands for breathing, that is failure to oxygenate or failure to ventilate. C, circulation or shock. D, any disability or neurological disability where the GCS is dropping. And E is expected clinical course. When would you intubate early? That is, the patient is not in any apparent airway distress, respiratory distress, but you still would like to go ahead and intubate. One of which is burns as well as airway trauma. So airway trauma, burns, as well as anaphylaxis angioedema, these have the potential to evolve very rapidly. The patient comes in walking, talking is fine, breathing well, saturating well, but before your eyes, this can deteriorate quickly, and then it becomes a truly difficult airway where you do not have space to negotiate even a small bougie. So these, especially when you have facial trauma, extensive facial trauma, which involves bony deformities also, degloving injuries or injuries with significant loss of facial mass, as well as burns. So burns, we also have one more reason to intubate, even if there are no facial burns. Does anybody know? Yes, you are right, sir. Please. Yes. So as he said, there can be inhalation injuries also, which can later on lead to a catastrophic scenario. So in case of smokes where you're doubtful that the patient has inhaled smoke and you're worried about inhalation injuries also, please go ahead and take a call on intubating early. So all of you have your airway assessment also in your primary survey, right? So few things that I can suggest or offer from my perspective. Again, look for bruising. So look for facial bruising, look for edema, look for deformities, burns, whether the patient's on a cervical collar, any active secretions, whether the patient is bringing out a lot of secretions, which is again a potential for obstruction, choking or aspiration. Listen, again look for any stridor, any gurgling, or if the breathing is stridorous or any different patterns of breathing are present. And anticipate. So anticipation is the one skill that defines ER physicians, or for that matter any person who is involved in emergencies, you know, that you anticipate that this is going to snowball into a bigger thing. This patient does not seem the way he is. So that skill is one that we pick up by observing and participating in lot of critical situations. So we use a scoring called Lemons. So we use this primarily to assess for a difficult airway. So in anesthesia, we classify difficult airways into difficult mask ventilation, a difficult laryngoscopy, or a difficult intubation. So when I say difficult mask ventilation, I find that the patient has a bed, is edentulous, or patient has a lot of prominent teeth which come out. Patient has a lot of fat, the buccal pad of fat is big, or patient has a big face, maybe patient has a lipoma on the face or a swelling on the face. In ER, that would again translate to a patient who has facial deformities where you're not able to hold the mask and form a good seal over the patient. A patient who has injuries where again you're not able to provide a tight seal over the face, or edema, again where ventilation becomes a challenge. So we also evaluate. We evaluate using the 3-3-2 rule. So we see if the patient is able to open his mouth, we see if there is neck extension, and there is a minimum of 3 fingers length breadth between the chin and the neck. So I don't know if Malampati score would be useful in an ER scenario where you're not really going to evaluate and do a calm intubation most of the times. The other thing is look for an obstructed airway and look for neck mobility. So you can of course condense this into a very quick, maybe a 2-second evaluation. So we have something in anesthesia called KISS, that is keep it simple and safe. So what happens every time you start planning, you plan, you overplan, you start overestimating, and then finally it does not go as predicted. But when we keep things simple, keep it simple, go by the basics, always the outcome is something that you can predict and it is quite easy. So which skill do you think is more important? Intubation, ventilation, CPR, which is the most important skill an ER physician should have? Anybody? Mask ventilation. Anybody else? So this is something that was told to me when I was training for anesthesia initially. So I was told that, you know, anybody can intubate, but a person who can ventilate can save the life of the patient till help arrives. When we attempt intubation, when we start attempting intubation, it becomes a difficult intubation. Often what happens, we forget to call for help, we forget the protocols, we are focused only on securing the airway. That leads to a truly difficult airway where we are neither able to intubate nor ventilate. But when we are able to ventilate, we prolong the oxygenation of the patient and we are able to gain time for us to think and form a plan B. So according to me, ventilation is the most critical skill that anybody can acquire. Not to say that intubation does not require skills, but ventilation would be the defining skill. So what do you start with when you're planning to intubate or when you're planning to support the airway of a patient? You give external oxygen. You have different forms to give it. You may start with nasal prongs, face mask. You may use a rebreathing mask. You may use a venturi mask. All of these you may do, or you may do mask ventilation using a Baines circuit or an ambu bag. So like Dr. Deva said, the head tilt and jaw thrust, these are two of the most critical maneuvers that all of you require to learn. Why is this so important? Does anybody know? What does this actually do? Very good. So one, it aligns the oropharyngeal axis with the laryngeal axis, ensuring passage of air remains patent. That is, the obstructions are removed. Sometimes it may be a tongue fall, it may be a foreign body, it may be secretions, it may be vomitus. So all of these get cleared. There is a chance for air to pass inside. Anything else? This also helps us to mask ventilate, providing a tight seal. Otherwise, what happens? You do not do this and you mask ventilate, then what happens? Anybody? Yes, it does not reach. Do you do anything else which may potentially cause harm to the patient? Very good. So you end up inflating the stomach to such an extent that in trauma, we know that there is delayed gastric emptying. So the patient is as such prone to aspiration. So you are actually inflating the stomach and creating a conduit for the aspiration to occur. So what airway adjuncts do you use? In your ER, what do you generally use? Do you intubate first, or do you use an LMA? Do you use any other airway devices? Anybody? How many of you intubate regularly in your ER? Yes. So what do you use, madam? Do you use straight away, do you intubate, or do you have any other adjuncts that you would use? Intubate. Okay. All right, ma'am. So, like I said, if you can ventilate, you're achieving control of the situation. Once you have control of the situation, it helps you plan better. So the manual airway maneuvers are the head tilt and chin lift as well as the jaw thrust. So how do you achieve the head tilt? You keep a palm on the forehead of the patient, tilt one hand on the chin and give a chin lift. How do you do the jaw thrust? You advance the jaw manually forward, relieving obstruction. Any situation where you do not do this or straight away go for jaw thrust? Very good. Cervical spine injuries where you want to protect the C-spine. So one of my favorite devices to use is the oral airway, oropharyngeal airway as well as a nasopharyngeal airway. Anytime I have a patient who I think is a difficult intubation or a difficult ventilation, I put in an airway ahead. That is once the patient is able to tolerate the airway. So the oropharyngeal airway comes in different sizes, and this is how you measure the size. You take it from the angle of the mouth to the angle of the mandible. And the nasopharyngeal airway, you measure it from the tragus to the nasal ala or the philtrum. So I'm sure all of you know this, how to insert an oral airway, how to insert a nasal airway, what are the contraindications and indications for each. So I prefer the nasal airway generally because the patient sometimes tolerates it better. The gag reflex is not activated. Even if the patient is mildly sedated or mildly uptended, they tend to tolerate the nasal airway pretty well and it stays there. But one of the problems with the nasal airway is it can be retained. You may forget about it, the patient goes home with it sometimes. The other thing is the nasal airway is contraindicated in patients where you suspect facial trauma, especially anterior cranial trauma, and that is a source of introducing infections. The oral airway is actually used only in unconscious patients and it is contraindicated if the gag reflex is present. Patient starts gagging and pushing it out. So, and the easier of this to insert is the oropharyngeal airway. So, when you are trainees, when you are starting with, the oropharyngeal airway is easier for you to introduce. It helps you maintain the airway better. So, coming to the star of the day, that is bag mask ventilation. So what techniques do you use? I prefer to use the double-handed technique. So where I ensure a good seal, especially for people with small hands, who do not have big hands to reach the whole of the face. The double-handed technique is quite easy. You're able to maintain a good seal. You need to have an assistant to ventilate. So what communication should you give the assistant? So I'm sure ER like OR is a lot about communication, especially closed loop communication. No, otherwise we hold mask. The person who is ventilating end up overinflating the stomach or does not ventilate properly or does not get back to us and say that it is not filling, the bag is not filling. So make sure you inform what you're going to do. I'm going to hold mask. Please ventilate. Let me know if the bag is not filling. Also mention the oxygen flows. If you have a valve, mention what setting you would like the valve to be closed at. Else what happens? Somebody closes in case of a Baines, they close the valve completely and end up overinflating. So how many breaths do you give as per the ACLS if you're ventilating somebody? Anybody? So I'm just going, asking these questions so that all of you are involved, that's all. Not like an exam or anything. So in the bag mask ventilation, the first thing that is taught to us is we maintain the E-C clamp. So E and C. C comes over the face, and the E is where you lift the chin. So you give a chin lift using E. That is the last 3 fingers of your hand. When you're using a double-handed technique, you are using both of your hands to create a good seal and somebody else is ventilating. There are of course other improvisations where you may give only a jaw thrust and hold the mask, seal the mask. That also works pretty well. So coming to LMAs, how many of you routinely use LMAs in your setup? Do you use laryngeal mask airways? If so, what LMAs do you have? So in case of a difficult airway, always remember to have an LMA backup. I'm sure you will intubate. However, having an LMA can help you continue the ventilation till help arrives. So I would suggest to have a second generation LMA, that is an iGel or a Pro Seal readily available in different sizes. So in the case of adults, we normally use sizes 3, 4, 5. In case of extremely obese individuals, you can use size 5. You can also have an ambu LMA because it's just by the ease of its insertion. It's already preformed, it is rigid, it sits in beautifully. So you can also have an ambu LMA as a backup. So we have something called a difficult airway algorithm that we routinely use. So just to deviate a little bit, we all have our own protocols, we have our own ways in which we approach a patient, anticipate an airway, prepare for intubation. Having a standard protocol or a standard mechanism across your hospital really elevates things, because not only is everybody aware of the protocol, deviations from the protocol are easily accounted for, and it's easier for you to backtrack and find what went wrong. Suppose an intubation became difficult, an unanticipated intubation, or an intubation became difficult where you were not able to secure the airway, it helps you find out why this happened. Why did this happen? So do you all have a regular airway cart for emergencies? You do? So in my opinion, when you have an airway cart, like a crash cart, you should have different sizes of masks, face masks, oral airways, nasal airways, have an ambu bag readily available. That is in case your first source of ventilation fails. Have an ambu bag, an alternative oxygen supply also. Have a readily working suction in case of trauma or where you think the patient is full stomach. Have 2 full working suctions ready. Have different sizes of LMAs available. Have a regular laryngoscope. Have a laryngoscope with a McCoy blade. Have a video laryngoscope readily available if you have one, if you have access to one. Have a ventilating bougie, an airway exchange catheter available. Cuffed oral endotracheal tubes in various sizes. So this would actually help you intubate pretty well. And of course, we cannot forget the cricothyrotomy kit as well. This is in cases of CICV situations. So finally, when you come to intubation, what do you do generally? Do you do a rapid sequence intubation or a delayed sequence intubation? So in OR, we generally tend to do a delayed sequence intubation where it is kind of controlled, calm. We reserve rapid sequence intubation only for very few scenarios, maybe an obstruction, intestinal obstruction, a full stomach patient, a true emergency. But in ER, most of all, you'll be doing a rapid sequence intubation. What drug do you use as relaxant? We tend to use a lot of rocuronium. Do you also use rocuronium? What do you use, or do you use choline? Nobody uses anything? You do not use relaxants? You do. What do you use? Scoline. Scoline, very good. So I too prefer to use scoline a lot because scoline gives you that complete relaxation and it is quite fast and you're able to intubate pretty quickly. Now with the advent of rocuronium, and if you have Sugamadex available, I would urge you to consider using rocuronium. Apart from the cost factor, it gives you a very smooth and intense relaxation and you're able to reverse it with Sugamadex also. So what is rapid sequence intubation? That is when you administer a simultaneous sedative and a neuromuscular blocker to achieve quick securement of a definitive airway. The problems that it may raise would be bronchospasm, a raised ICP, and pretty massive sympathetic stimulation. So I've just put that the choice of neuromuscular blocker is rocuronium. This is based on my personal experience. But choline is a very good alternative, and except in cases of, like you all rightly said, specific contraindications, choline can be continued to be used. So RSI is not without preparation. Even though you do it fast, the preparation should be done in a controlled manner. So there is something called the 7 P's of RSI. One is preparation. The other is pre-oxygenation, pre-treatment, paralysis along with induction, protection and positioning, placement and proof of intubation, post-intubation management. So preparation includes making sure that everything is in place. You have a working monitor, you have an assistant to give drugs flush, you have an assistant to handle the airway equipment, you have 2 working suctions which are large bore, you have a table or a cot which can be tilted. You can make it head down if required. That is if the patient starts vomiting or secretions start coming out. You have adequate airway equipment, you have a working laryngoscope, you have an alternative laryngoscope if the first one fails. So pre-oxygenation is very, very, very important in the terms of RSI because you're not going to be ventilating the patient at all. There is something called as modified RSI where you may ventilate the patient with pressures less than the esophageal sphincter opening pressure. However, in the ER, the standard RSI would continue to be the best of all. So pre-oxygenate, if you have an FiO2 monitor, you may pre-oxygenate till the end tidal oxygen comes above 92%, or else pre-oxygenate for 3 vital capacity breaths. Induce and paralyze simultaneously. Intubate. Before intubation, protection and positioning. So this is a controversial area where some people continue to use Sellick's maneuver, some do not. So Sellick's is where an assistant applies cricoid pressure. This is to prevent aspiration. However, this is not without its risks. Sometimes there can be esophageal rupture. It worsens your intubation view as well. So right now the consensus is that Sellick's is not absolutely mandatory. It is up to you to decide whether to have a Sellick's maneuver or not. But there is another maneuver which I prefer using, that is called burp. Has anybody heard of burp? Anybody? No one? So burp is an external laryngeal maneuver where the assistant places their hands on the thyroid cartilage, applies backward, upwards and rightwards pressure. So this actually brings the cords into your vision and it is easier for you to intubate. In terms of positioning, as all of us know, we are dealing with obesity. We get a lot of patients who are really obese and intubation becomes a challenge. So we have something called the head elevation position where the aim or the end point is the tragus of the patient is in line with the sternal notch. So you position the patient in such a way and this actually helps your intubation. And then you intubate and proof of intubation and post-intubation management. So pre-oxygenation is for 100% oxygen for 3 minutes or 8 deep breaths in 60 seconds. This is if it's urgent. If you're using Saxa, it is in a dose of 2 milligrams per kg, that is rapid onset. Rocuronium, I would use it in a dose of 1 to 1.2 mg per kg. And induction agent, so this is actually given by mistake, I'm sorry. So what induction agents do you routinely use in your ER? When we were in ER rotation, we would routinely use Midas and fentanyl. What do you all use? The same, based on the condition. So etomidate is something that offers hemodynamic stability. Basically, the vitals will not change. It will be the same. However, this has the risk of adrenal suppression. But now there are studies which is actually coming out that etomidate may be used much more than it was in the past. Ketamine is a wonderful drug again that gives good analgesia, good sedation, bronchodilation. If you bar the secretions part and if you pre-treat it with glyco, it works wonderfully. Propofol is our favorite, but we use it in controlled situations. So our patients are not septic, they're not in shock, they don't hypotense as badly when you give propofol. So if you're using propofol, I would urge you to use it with caution. And of course, midazolam. So supposing you have intubated, you have secured the airway also, always remember, do not forget the post-intubation sedation. This is something where all of us, we secure the airway and we are in a high, there is an adrenaline rush that we've done it successfully, and then we forget about the poor patient who is awake with a tube in his mouth, in his or her mouth. So do not forget about the post-intubation sedation. So if at all you're using fentanyl, this provides good analgesia, but combine it with a sedative, either midazolam, dexmedetomidine or propofol. So why do we require sedation in the ER? Apart from your intubation, there may be procedures which require sedation. Small procedures, for example, reduction, shoulder dislocation, where you want to reduce the shoulder, closed reduction in a pediatric population, a patient who requires a painful dressing, a patient who requires assessment but the patient is in severe pain. So all of these require sedation. And sedation facilitates airway control as well as procedures. It reduces the patient's distress, prevents a sympathetic surge, as well as improves your intubation conditions. So sedation, in terms of sedative, I would just like to tell you that there is no safe sedative. There is only safe sedation. You cannot say that propofol is the best, ketamine is the best. It is only as safe as you use it. So sedation is a controlled reduction in consciousness, preferably with the airway reflexes intact. We have something called as conscious sedation, where the patient responds to verbal commands and stimuli. So this is a continuum or a spectrum. So it does not take much for it to progress into general anesthesia. You keep sedating, keep giving midazolam, keep giving fentanyl. There is a point where the patient's airway reflexes are going to get uptended. The patient is going to go into respiratory depression. So post-intubation confirmation. Do you all use EtCO2 in your ERs for post-intubation confirmation? We do. What about the rest? Do you have end-tidal capnography in your ERs? So EtCO2 is the gold standard. It is the gold standard for you to confirm intubation. The other methods include bilateral chest rise, 5-point auscultation, absence of gastric sounds, as well as a chest X-ray confirmation. So to sum it up, in case of an airway, treat all airways as difficult airways in the ER. Plan A would be a direct or a video laryngoscopy. If you have access to video laryngoscopy, please train yourselves in it, because that is evolving into a cornerstone of airway securement. Plan B would be a supraglottic airway or an LMA. Plan C would be just bag mask ventilation with airway adjuncts. Plan D would be a surgical airway. In all of these situations, remember to call for help early on. So the help that arrives is helpful only if it arrives early. There is no point of help arriving once it becomes CACV. So you anticipate, like I said earlier, observation and anticipation of a difficult airway is the one that is going to truly help us plan. And all of this is not without planning or preparation. So unless you have prepared, unless you have a working suction, unless you have an alternative source of oxygen, you have all the airway equipments available to you, none of these will help you once things start going wrong. So my references are standard anesthesia and emergency medicine textbooks, as well as the latest guidelines of American Society of Anesthesiologists and the Difficult Airway Society. Any questions or any clarifications, any inputs from anyone? I hope this presentation was at least slightly useful to all of you. So wishing you all the best. Thank you.
Thank you so much, ma'am, for the wonderful talk. Now I request Dr. RKRS sir to felicitate Dr. Chitra, ma'am. Next, I call upon the abdominal architect, gastro genius, gut guardian, Dr. Rajkumar Ratnasamy, surgical gastroenterologist, to deliver a talk on unveiling the doors of Pandora box, Chitty 2.0 tales from D.A. Vinci.
esteemed guest, respected faculties, esteemed guest, my dear colleagues and my dear delegates, my dear postgraduates, a very good morning to one and all. First of all, I would like to thank for the opportunity to my friend and moreover a brother-like man, Dr. Sai, for this opportunity to talk about unveiling the doors of Pandora's box, Chitti 2.0. See, every one of you would have handled an emergency situation in a personal way, occasionally, and quite often. So dealing a personal emergency situation successfully is an art. But dealing an emergency situation quite often requires a skill. So in that sense, every one of you are very much skilled. But dealing an emergency situation in a day-to-day basis, on a daily routine, 24/7, requires a tremendous courage, a dedicated passion, and a compassion, commitment, and dedication. Working in an ER room is like a war front. It needs a lot of emotional stability as well as professional maturity. So after a gripping session of a critical care physician's talk, you all know about the ABCDE of critical care. I would like to invite you to the next letter, that is F, that is fun and joy. Before going to my presentation, I got the permission from my friend Dr. Sai for adding some memes. So the emergency department is the face of the hospital as well as the backbone of the hospital, because the work done in emergency department is almost makes our job much easier. Half of the work is done in emergency room itself, makes our job very much easier. So this is the daily duty of emergency physician. Sound.
பேஷண்ட்ஸ்லாம் வெயிட் பண்ணுறாங்க, சீக்கிரம் வாங்க சார்.
The next scene is purposefully censored because you would all imagine that every patient in the ER will be like Kataturai. So what amount of stress the ER physician undergoes, it's for your imagination. And I must congratulate Dr. Sai sir for consecutively conducting this conference for the 4th time amidst his tight schedule and stressful situation. So this is during the preparation of KEMCON 3 or 4 weeks earlier.
நீ என்ன பண்ணுறன்னா டாக்டர்ஸோட ஸ்லைட்ஸ் எல்லாம் போய் வாங்கிட்டு வா. நீ என்ன பண்ணு, டாக்டர்ஸ்க்கு வந்து இன்விடேஷன்லாம் போய் ரீச் ஆகிடுச்சான்றதை செக் பண்ணு. நீ வந்து ஃபுட்டெல்லாம் எல்லாம் அரேஞ்ச் பண்ணிட்டாங்களா அப்படின்றத செக் பண்ணிட்டு வா.
So this much of stressful situation for conducting in a conference. So apart from jokes, I will take you to my presentation. So the robot is not an exemption from attending an ER duty. Whether all the abdominal surgeries can be done in robotic, it is not so. So robotic surgeries still can be performed in emergency abdominal surgeries provided some criteria are fulfilled. So emergency surgeries nowadays being undertaken with robotics also. So what are the advantages of robotics? The robotics gives a better 3-dimensional vision with the wristed instruments, and it has been increasingly adapted in the acute care surgeries. So why robotics are invited in doing emergency surgeries? So it gives a three-dimensional visualization, which gives a better picture with 10 times magnification as compared to laparoscopy. And it gives a very good improved suturing capabilities, and almost it filters all the tremor in our hands. So the tremor filtration is a tremendous task, and it gives a better ergonomics for a surgeon to work in a very cool and comfortable and relaxed manner without any undue strain during the time of surgery. So what are the common emergency conditions that you may encounter which is apt for the robotic surgery? So one is the acute appendicitis, next is acute cholecystitis or biliary sepsis, and sometimes intestinal obstruction, whether it's a small bowel obstruction or large bowel obstruction. It might be in the form of any obstructed hernias or strangulated hernias, or tumor causing obstruction, or some adhesions causing obstructions. And sometimes, of course, the perforated peptic ulcer in a very early stage, not in an advanced stage. So these are all the common emergency procedures being done with the robotics, that is robotic appendicectomy, cholecystectomy, intestinal resections, either small bowel, large bowel, and perforation if it is early sepsis, not with too much of contaminations. Comfortably with the pillow on the backside, relaxed mode, and this is the inflamed appendix, using with the monopolar scissors on one side. So the mesoappendix is cleared, the inflamed appendix can be removed with robotics with more precision and accuracy. So this is the robotic arms. So the movement is like a feather touch. So this is a case of biliary sepsis. So you would able to see that the gangrenous gallbladder with perforations, a lot of fluids in and around the hepatorenal pouch, subhepatic and so this is the gangrene. Because of the sloughed out gallbladder, the gallbladder is opened. You would able to see that opened gallbladder, and then a lot of stones are inside. So this is a robotic surgery. So this is another case of empyema of the gallbladder with a lot of pus. So these patients would present with the sepsis. So a lot of pus from the gallbladder. And this is a case of cholangitis with the bile duct obstructions. Stone. So this is a Dormia basket used for the CBD exploration. So this is a robotic CBD exploration. So CBD stones are cleared. These stones are not amenable for the ERCP clearance because the stones are fairly bigger in size. So these are all the cholecystitis. So why I am stressing about the robo is the comfort and the angulations what we get during the time of surgery. See here, the surgeon is sitting very comfortably. See, look at the angulation. This angulation is almost 90 degree. And then this rotation of the wristed movements. So it's comfortably rotates. See, normally a human hand can rotate, this is 0 degree, it can rotate up to 90, it can rotate up to 180, it can go up to 270 degrees. With this 270 degrees, it is difficult to accomplish any task. But in robotics, this rotation can be one more times, that is goes up to 540 degrees. So this much of rotation and angulation is possible. That is why the robo reaches the deepest structures without injuring the adjacent structures. So the nerve sparing surgeries and then vessel preserving surgeries are highly possible in robotics. So coming to the obstructions, obstructed hernias. So here you would able to see that the small bowel as well as the omentum got herniated, causing irreducibility. So it's an emergency surgery by robot. So the contents are reduced. So that is a inguinal hernia defect here, both right side and left side, and as well as an femoral hernia. So this obstructed omentum being released with the help of knife, scissors. So that is a Da Vinci system. Look at the angulations. So that is a defect. So the defect would be sutured, and then a mesh would be placed. That is a femoral hernia down. It's an inguinal hernia. So the mesh has been placed and the peritoneal flap is being sutured. The suturing is like very simple procedures as like a child's play. It's very easy and comfort. And this is a case of ventral hernia where the irreducible momentum is being reduced. Is irreducible hernia. So the hernias with obstructed and irreducibility can be done. Sometimes even strangulation also can be dealt depending upon the prerequisites to be fulfilled for the selection of cases for robotics. Not all cases. So this is a case of obstructed bowel. So here in robotics, we can use the indocyanine green. So that is a technology that we can use this ICG to look for the vascularity of the bowel. Once the bowel is resected, we may be able to see the distant vascularity and proximal vascularity. So before doing an anastomosis, say here you would be able to see that there is a demarcation between the vascularized and devascularized segments. So though darkish green is the highly vascular. So this is an intraoperative picture of a hemicolectomy. So before doing this, see this is a rectal transaction for bowel surgery. It's a suture form stapler used in robotics. So this is the small incision, specimen is being delivered out, and then look for the vascularity. And then with the good vascularity, we do anastomosis. So this is a case of right hemicolectomy done in robotics. So as I said earlier, the advantages over laparoscopy for a Da Vinci robotic system, it gives it's not 570, sorry, it is 540 degrees of raised movements and gives a better precision and dissections and superior suturing capacities, and of course the surgeon is less fatigued. So what are the limitations? So the limitation is it takes some more time to dock the robo. But nowadays faster docking systems have been available in the markets, and of course cost is little higher as compared to laparoscopy, but it is worth spending that cost because it gives the accuracy and pain factors relief and then quick recovery as compared to laparoscopy. And the availability of robotic platform is not available everywhere. Only in certain centers it is available. And of course it needs a surgical team training, not only the surgeon to get trained, but the entire team, staff nurses and then technicians to handle the robots in case of emergencies. So the entire team also needs to be trained. So how do we select the patients for robotics? As I said earlier, not all patients of abdominal surgeries are chosen for robotics. The patient should be very, very hemodynamically stable. Unstable patients, especially in ongoing bleeds and trauma, are not the candidates for robotic surgeries where you have to do immediate surgery either by laparoscopy or open surgeries. And the pathology must be confined to localized, like appendicitis with a particular abscess, confined to RIF, or sepsis in cholecystitis confined. These are all the better chosen for the robotic surgery, not a case of massive trauma, and unstable patients are not suited for robotic surgeries. So there is a transition for surgeons to learn the robotics. It needs a learning curve. And the one disadvantage of robotic system is the lack of tactile feedback. You will not be able to feel how much of pressure you are exerting on the tissues. But nowadays, the newer Da Vinci system, that is Da Vinci 5 system, has got a tactile feedback also. So soon it will be coming to India. And then the improved ergonomics at console gives the comfortable to the surgeon and high precisions. So these are all the advantages of robotics. What would be the future? The future robotic system is AI integrated. So with this AI integration, as I said, the ICG clearance, ICG usage for the vascularity and all those things, the AI itself maps the structures. So this is the ureter, this is the nerve where you want to dissect or don't want to dissect. That gives a roadmap for the anatomy when we do the dissections, so that we can avoid unnecessary injuries, especially in vascular anomalies where you have a multiple vessels or unexpected vessels, new vessels, altered vascular arrangements. We would use that AI integration to do a precise surgery much more better way. And faster docking systems is also available. And sometimes the remote surgery is still possible. So we can opt. Recently in China and India also, surgery is being performed about 2,500 kilometers apart with a difference of 0.6 microseconds. So the remotest possible situations also we can do a robotic surgery. So what is the talk of town now?
என்ன வேணும்? எனக்கு ஹெர்னியா இருக்கு. ஐ எம் வெரி சாரி பா. ஐ எம் வெரி சாரி. நீ இங்கே உட்காரு, நான் உன்னை பார்க்கறேன். சாரி சார், என்னால உட்கார முடியாது. ஏன்? எனக்கு பைல்ஸ் இருக்கு. கையை கொடு, பல்சாவது பார்க்கறேன். சாரி சார், என்னால கையெல்லாம் கொடுக்க முடியாது. நீங்களே பிடிச்சு பார்க்கங்க. அது ஏன்? கேல் பிளாடர் ப்ராப்ளம் இருக்கு. அட பாவி. இப்ப நான் உனக்கு என்னடா பண்ணணும்? எனக்கு எல்லா பிரச்சனையும் உடனே சரியாகணும்பா. என்ன பண்றதுன்னே தெரியல. எடுத்துக்கடை, இதை நானே டீல் பண்ணிக்கிறேன். அப்படியா? எல்லா பிரச்சனையும் சரியாகணும்னா காமர்ஸ் ஹாஸ்பிட்டல் எமர்ஜென்சி டிபார்ட்மெண்ட்டுக்கு போ. அங்க டாக்டர் சாய் சுரேந்தர் சார் இருப்பாரு. அவர் உன்னை கரெக்டான டாக்டர் கிட்ட அனுப்புவார்.
Thank you. So to conclude, robotic emergency surgery is still feasible in selected patients. It gives a technical advantages, needs a training and infrastructure. Future of surgery is still evolving. Questions are welcomed. Any questions about robotic surgeries? All of you well aware about robotics? Any one of you must ask one question at least. ஏதாவது ஒரு கொஸ்டின் கேளுங்க. ரோபோ தான் பண்ணுதா இல்ல சர்ஜன் பண்றாரா? Yes sir.
Only elective cases, or you can do it in emergency appendix?
That's what emergency situations. So when the patient is suited for stable patients in a very early sepsis, we can opt on robotic surgeries also, like appendicectomy, cholecystectomy, intestinal obstructions. Not in a sepsis patient or shock patient, not in a hypovolemic shock or hemorrhagic shock or septic shock. There is a time that we have to rush immediately. When there is an ongoing bleed, do not wait for the robo. Just it's the life of the patient to be saved. So that this is not the technique, it is an emergency situation to handle that. In that situations, we can opt open surgeries or laparoscopy. So only in selected situations, but still we can opt robotics in emergency situations also.
Thank you, sir.
Sir, growing with you from ER, how do you make patients convinced for robotic surgery? So people know your surgical skills, non-robotic surgically, but what amount of pressure or what amount of words you use, how you make the patient convince for robotic surgery? This will be eye-opener for many of us to convince as emergency patients.
It's a good question. It's very practical because people, many of the people do not aware that robotic system, how the robot would do the surgery. They have some fear that whether the surgeon does the surgery or robot does the surgery. But of course, if you don't adapt to that technology, you are lost. I would ask my patients that what mobile phone you are using and what network you are using. They say that it is 3G or 5G. If you happen to use a 7G or 10G, what would you prefer? Definitely they would prefer 7G or 10G. So if it is available, utilize that. So it is a technology. So definitely it is a technological supremacy. It gives surgeons easy, makes the jobs easy, as well as the patient's recovery is also much faster and much quicker. So that is why I convinced. Initially it was little difficult, but nowadays as the days goes and the people are aware about the robotic surgery, sometimes people, they come forward to do a robotic surgeries because some of the centers are not offering robotic surgery outside. They come, they select us and then they get done in our robotic system. Thank you.
Thank you. Thank you so much, sir, for the wonderful talk. Now I call upon Dr. Sai Surinder, sir, to felicitate Dr. RKRS, sir.
Thank you, sir. Thank you, sir.
Next, I call upon the heartbeat hero, rhythm specialist, cardiac commander, Dr. Sendilraj, cardiologist, to deliver a talk on cardiac emergencies in structural heart diseases.
Okay. Good morning. Good morning, dear faculties and dear colleagues. I'm excited to be a part of KEMCON 2026. I thank Dr. Sachs for this opportunity. So after a great show by Dr. Rajkumar sir, and with many funny illustrations, I'm here to be in a core cardiology topic. And again, I'm contradicting Rajkumar sir in this, where humans beat robot is PCI. So the robotic PCI is always inferior to PCIs done by humans. So many of the centers which had robotic PCI is removed, and still we do PCS more. So my topic is emergencies in structural heart disease. So when we come to structural heart disease, it's mainly about the structural deterioration of cardiac valves and myocardium. So it can be due to acute deterioration of a stable lesion or a development of a new critical lesion. So it can lead to acute heart failure or cardiogenic shock. Most of the cases not respond to standard medical therapy, and it might necessitate a surgical or a percutaneous interventions. And most of these patients are very critically ill, and they are not suitable to be stable enough to be in a surgical ready for preparedness for surgery, and they may require a PCI or some bridge therapy to be stabilized to be a candidate for surgery. So most of the structural heart diseases include acute AS, severe AS, acute AR, or severe MS, or severe MR. And most common condition which we see in ER is cardiogenic shock secondary to MI, or mechanical complications like ventricular septal rupture, or severe MR secondary to MI. So these are the most common structural heart emergencies we see in emergency. But the other common causes include this valvular conditions. So acute decompensated heart failure and cardiogenic shock resulting from valvular heart disease and myocardial disruption are called as structural heart disease emergencies. So usually these lesions present gradually over time. So there will be a chronic valvular condition which over a period of time it gets worsened, or sometimes they can get acute worsening due to the presence of a hemodynamic stress or from a superimposed systemic illness. So acute decompensation of a chronic lesion due to an intercurrent illness is the more common. And acute valvular emergencies comprise about 8% of the coronary care unit admissions. So the usual presentations are, we should see them as a regurgitating lesions and stenotic lesions. Regurgitation lesions are usually volume overloaded lesions. They present with dyspnea, cardiogenic shock, and they develop these due to the sudden elevation in LV end diastolic pressure. In stenotic lesions, most of them are secondary to volume underfilled LVs and low flow states. So native mitral or aortic valve stenosis do not occur acutely, but they can present with acute decompensated heart failure, cardiogenic shock. Most of them have symptoms of cardiogenic shock like tachypnea, inspiratory crackles, hypoxemia, altered mental status, hypotension, cold extremities, and some specific symptoms signs include fever due to infective endocarditis, or sometimes chest pain secondary to acute aortic dissection. So the most common causes include of all acute valvular heart disease include mitral or aortic regurgitation. The common causes are infective endocarditis, acute rheumatic fever, and procedure-related injury, such as like a cardiac catheterization-related acute AR or acute MR, and spontaneous process rupture, blunt trauma. AR can also be caused by a type A aortic dissection, or in acute MR can occur in acute coronary symptoms due to the papillary muscle rupture, or VSTs can occur due to a secondary to myocardial infarction. So these are the common causes of acute valvular disruption or acute leading to heart failure. Acute stenosis is rare. Most common causes of acute stenosis include a prosthetic valve stenosis by a thrombus. So as I earlier said, the most common cause of acute valvular lesion is a worsening of a previous chronic lesion. So there can be some clear triggers. There can be infection, there can be fever, or sometimes pregnancy can increase the symptoms, hypertensive urgency, emergency, pulmonary embolism, or some acute stress. So these are all the reasons which can be a trigger to a already present chronic lesion. So these are the pathophysiology of acute structural heart disease emergencies. Aortic stenosis, there is a fixed obstruction to the outflow. So there is a increased LV after load and eventual systolic dysfunction. So the most common etiology is the calcific degeneration. The other etiologies include rheumatic heart disease. Congenital heart disease include bicuspid aortic valve, but they present later in their life. And aortic regurgitation, there is a ejection of blood. There is a backflow of ejected blood back into the LV during diastole. The most common causes include infective endocarditis, aortic dissection, degenerative, bicuspid aortic valve, and postoperative. So mitral stenosis, as we know that in India, the most common cause of mitral stenosis is rheumatic heart disease. There is obstruction to the LV filling. So there is a increased LA pressure and decreased LV preload. So the most common causes include rheumatic heart disease and calcific MS. And LVOT obstruction, there can be dynamic obstruction to the LV outflow due to the thickening of the interventricular septum, or it can also occur in acute conditions like Takotsubo cardiomyopathy, where we get apical ballooning and dysfunction of the apex and hypercontractility of the base. So it can occur in Takotsubo cardiomyopathy. And ventricular septal defect, it's the most commonly occurs in MI. It can occur as a biphasic way. It can occur in the earlier of in a massive MI at the first within 24 hours, or it can occur after 5th and 7th day if there is a late revascularization or anything. So in ED, we should follow a 3-step approach when we suspect a structural heart disease. So first step is a clinical suspicion of valvular heart disease in the ED. So we should look for signs and symptoms of valvular heart disease. And second step is the other test which we need to confirm or suspect a valvular heart disease. And we have to see the other tests which include ECG, echo, chest radiography, focus, CT and echocardiogram to find out whether it's an acute or a chronic lesion, which would help to further prognosticate and help in the management of the disease. And third step is the diagnosis and treatment of valvular heart related cardiovascular emergencies. And then management include heart failure management, identification of trigger and treating thrombotic events, and acute rheumatic fever, infective endocarditis prophylaxis. Everything should be in the management steps. So diagnosis, it's always a difficult part to clinically examine a patient in ED with a very rough environment in the emergency department. It's always difficult to identify the signs and signs of cardiac diseases in ER. So most of the times acute valvulopathies do not have murmurs, as we see in chronic valvular heart diseases. So the clinical findings can be subtle. And the most important investigation in ER should be the transthoracic echocardiogram. The transthoracic echocardiogram with a Doppler examination will clearly show most of the valvular lesions, and review of the previous echocardiogram should be always be done so that we can identify whether it is a chronic lesion that has worsened or it's an acute lesion that has newly occurred. So this is much important, and sometimes the transthoracic echo cannot be much reliable because of the presence of a respiratory distress, poor views, and intubated patients. Most of them cannot be positionally varied, and so there will be difficulty in performing a transthoracic echo. So transesophageal echo can be always helpful, and in giving beautiful views and confirming the diagnosis. And then chest X-ray. Chest X-ray is a simple investigation which can give us a lot of information in cardiac conditions. We can see the cardiomegaly. When there is acute lesion, most of the times we see acute pulmonary edema, but the cardiac shadows could have a normal silhouette, which when it is a chronic condition, we can see that the cardiac silhouette can be changed or altered. We can see the cardiomegaly. And ECG gives a lot of information that whether we can see acute coronary syndromes, we can identify any arrhythmias, atrial fibrillation, which can be easily picked up by ECG. We can see chamber enlargements. So always we should have a ECG, and point of care ultrasound can be very helpful in ER, and most of the ER physicians are very well trained in point of care ultrasound. They can easily pick up three B lines, and they can also look for calcification of the valves and identify that whether it could be a chronic problem can be identified through that. And CT imaging in certain conditions, like when we suspect a sudden onset chest pain radiating to the back, and in predisposed individuals with hypertension or kidney disease, we can always should rule out with a CT aortogram to look for acute aortic dissections. And then further investigations can be coronary angiography to rule out acute coronary syndromes. BNP can be very helpful to identify the chronic heart failure, even though in acute heart failure it may not be much reliable and need to be have repeated samples. And further management of acute valvulopathies need a pulmonary artery catheterization, and cine angiograms will be helpful in identifying the calcium and everything. So clinical examination, we can get lot of signs. I think many of them would be aware of the signs which we used to see in chronic valvular lesions. Acute lesions, there will be not much signs, but in chronic lesions, if there is a chronic AR, we would have lot of signs which we already are familiar from the UG days, like Landolfi sign, Demusset sign, Corrigan's pulse, and everything will be we can appreciate, and but it's not a must that we should do everything in a ED. So these are the things which can point to a chronic AR. Acute AR do not usually show much signs, and so echo, we have a lot of criteria to differentiate between severe and non-severe. So for acute aortic stenosis, usually we see mainly the gradients. So the mean AV gradient more than 40 millimeter of mercury is a severe aortic stenosis, and the maximum velocity more than 4 millimeter seconds. These images shows that there is a in the images in aortic regurgitation, you can see the fly aortic leaflets here. This is a so this is a aortic dissection, acute ascending aortic dissection. We can see that, and this is the AR-PHT. We measure the AR-PHT to see the acute aortic regurgitations. So we can see a diffuse central jet of aortic regurgitation in these images. So aortic regurgitations, we usually for chronic lesions, we usually see the vena contracta, regurgitant volume, and regurgitant fraction. But in acute aortic regurgitations, these may not be very reliable because the jet can be eccentric and also be severe. So, and then so for mitral regurgitation also the same thing, we assess the central jet area and the vena contracta and the regurgitant volume. For mitral stenosis, anything less than mitral valve area less than 1.5 centimeters considered severe MS, and dilated left atrium. These all the information we can get from echocardiogram. So this is images of mitral stenosis. You can see that there is a hockey stick appearance of the atrial AML, and you can see the fish mouth appearance. And this is the mitral valve gradients, which we can see that it's a mean gradient is about 33 millimeter of mercury. So these are the things which can easily be identified in a echocardiogram. So this is the aortic stenosis. We can see that the peak, the mean gradient is around 57 millimeter of mercury. So you can see that the velocities are uniform. With we can even differentiate the aortic stenosis gradients from LVO2 gradients by the shape also. So when there is a dagger shape, it is usually LVO2 obstruction, and this tongue shape is usually in the aortic stenosis. So what are the hemodynamic changes we get in each of the lesions? So in mitral regurgitation, so usually the regurgitation lesions are all volume overloaded lesions. So the LV remodeling, in chronic lesions there will be LV remodeling followed by chamber enlargement. This chronic remodeling allows the maintenance of overall cardiac output without much elevation in LVDP, while in acute mitral and aortic valve regurgitations, the LV volumes leads to rapid elevations in LVDP, and that's the reason why the patients develops acute pulmonary edema in acute mitral and valvular regurgitations. You can see that in the mitral regurgitation and aortic regurgitation both have a backflow, and so these patients have poor cardiac output. The LVDP is high, and it also increases the pulmonary capillary wedge pressure. You can see that due to the large regurgitation jet in the LA, we can get the V waves, and in aortic regurgitation, we get a narrow pulse pressure in acute and wide pulse pressure in chronic AR. In mitral stenosis, we get giant A waves, and in aortic stenosis, we get a anacrotic pulse or a delayed pulses. Usually see as pulses parvus etatus. So in management, so this is the important point. So it's not that we can start any medication in for valvulopathies. There are certain medications which should be avoided in valvulopathies. So, so for example, in patients who have aggressive volume overload, so we can regurgitation usually have aggressive we can manage by afterload reduction and inotropic support. And in stenotic lesions, usually we require beta blocker and vasoconstrictors. These stenotic lesions all are forward fold dependent. So when we aggressively treat them with vasodilators or diuresis, the patients can develop hypotension and worsening of these conditions. So usually the stenotic lesions, they just require beta blocker and vasoconstrictors, while in regurgitation lesions, they are volume overload conditions, need afterload reduction and inotropic support. So identifying intercurrent, so most of the structural heart disease emergencies require a definite treatment, including a percutaneous intervention or sometimes a surgical intervention. So when there are some intercurrent illness or there is a triggering factor, just treating the triggering factor can buy us time, maintain them in after treating the trigger, we can make the patient stable and give a definitive treatment option. So identification of intercurrent illness is very important, and most of the time the patients requiring emergency cardiac surgery carries a high mortality risk. So when MCSS, mechanical circulatory support, is indicated, yearly initiation offers a good major benefit for these patients, and invasive hemodynamic assessment by using a pulmonary artery catheterization can help in deciding the treatment and attaining the goals easily. We can our usual target should be the central venous pressure should be maintained between 5 and 10, and the pulmonary capillary wedge pressure should be maintained less than 15, and with the other parameters which we usually follow in ICU with the good urine output and lactates and mental status should be assessed properly. So the positive pressure ventilation can have individual effects on each of the lesions. So when it is the positive pressure ventilation reduces LV afterload and preload, so it acts differently in stenotic lesions and regurgitation lesions, so it should be managed accordingly. So compared to patients with valvular heart disease, patients without valvular heart disease, patients with valvular heart disease have a profound cardiogenic shock and higher in-hospital mortality. So when it comes to regurgitant lesions or highly afterload sensitive, as I said, they can be treated well with vasodilators and target lower blood pressure to improve the forward flow. And stenotic lesions, we should be aware that they do better with the beta blockade and to increase the cardiac output and decrease the use of vasodilators and inotropes. So when a patient comes with acute pulmonary edema and cardiogenic shock, the first thing is to rule out ACS. So we should look for ECG and other echo and everything, rule out acute myocardial infarction. We can do echocardiography to look for cardiomyopathy, which can be very often. We can see that the dilated chambers and everything can be seen by echocardiography. If it is a structural heart disease emergency, the patient should be put on a pulmonary artery catheterization and PAC, pulmonary artery catheter, and then you can, if there's a atrial fibrillation trigger, we can just cardiovert. And if it is a regurgitated lesions, we can treat them with diuretics. And if it is a stenotic lesion, and if requires volume support, so it has to be treated with fluids. and we can use vasodilators and inotropes in regurgitant lesions. In stenotic lesions, mainly it's the vasoconstrictors and beta blockers. And IABP can help in some lesions, and it's contraindicated in acute aortic regurgitation. So this is about the mechanical support devices and the medications. So for aortic stenosis, the preferred drugs include norepinephrine, inotropic agents, and nitroprusside. So the nitroprusside can improve the forward flow, and norepinephrine as inotrope, it can help in aortic stenosis. So mechanical support, we can use IABP, ECMO, and other LVADs. Catheter-based therapy for in patients with acute aortic stenosis, we should always try to avoid hypotension, as hypotension can decrease the coronary perfusion pressure, and if a patient gets cardiac arrest, they won't survive, the survival rate gets poor. So for in emergency conditions, we can perform a balloon atrial valvotomy to save the patient as a bridge to definitive therapy, and we can proceed with the definitive therapy like a TAVR or a SAVR. So in aortic regurgitation, most of the times aortic regurgitation are chronic lesions. The acute lesions always require a surgical treatment. For example, in infective endocarditis or in a patient, infective endocarditis can be managed medically, but in severe aortic regurgitation secondary to aortic infective endocarditis always need a surgical treatment. And after aortic dissection, they need a surgical treatment. So the drugs which we can use are inotropic agents and norepinephrine, and the possibility of TAVR, if the valve is not infected, we can use TAVR, but TAVR in AR is still in early stages. So there are few specific valves which are in the pipeline for aortic regurgitation, but most of the valves which we use for AR are the valves which we use in AS. So the chances that of complication rates are higher. And mitral stenosis, we can use norepinephrine and inotropic agents. ECMO can be used, and BMV can be a definitive therapy. And in certain cases where if the valve is not pliable and the valve is suitable with a good calcium and everything, we can do a transcatheter mitral valve implantation. And if there is a secondary mitral stenosis secondary to a prosthetic valve degeneration, we can again plan a transcatheter mitral valve in valve with the use of aortic valve in mitral valve position. And mitral regurgitation, we can use drugs like nitroprusside, inotropic agents, and mechanical support can be used with IABP or ECMO. In certain acute mitral regurgitations, transcatheter H2H repair can be very helpful, and it's still in process. So when it comes to mechanical circulatory support, so in stenosis, IABP helps much, but in aortic regurgitation, it is contraindicated. It increases the aortic regurgitation and it increases the LV afterload. So IABP should not be preferred in treatment of aortic regurgitation. In mitral stenosis, it is less efficient because the LV is empty, so it should not. It's due to pre-ventricular etiology, and so when mitral stenosis is not very much useful. In mitral regurgitations, used commonly, and it's with good efficacy. And microaxial flow pump. This is the Impella. It's the shortest. It's the smallest pump, heart pump. So it's an Impella. So it is relatively contraindicated in severe AS. If it is a severe AS, the passing of a Impella can cause further stenosis. So it can be a relative contraindication, but always the Impella can be useful in aortic stenosis because it can pump the blood out of the LV, and it can outflow in the aorta. So it is always helpful in aortic stenosis in most of the conditions. It's only a relative contraindication, and in aortic regurgitation, it is a relative contraindication because of the increased afterload. And in mitral stenosis, it's less efficient due to the pre-ventricular etiology. ECMO is helpful in aortic stenosis and aortic regurgitation. In all afterload increasing conditions, ECMO can increase the afterload and worsen the conditions. So it has to be done with the help of venting. So we have to decrease the afterload by another modes. So, so ECMO is also helpful in certain valvulopathies. So this is about positive pressure ventilation. Those conditions which decrease the, so positive pressure ventilation usually decreases the LV preload and afterload. So in conditions where there is a low preload, so it will worsen it. And in conditions where it can decrease the LV preload and afterload, in regurgitant conditions, it generally helps the lesion. So aortic stenosis, it's the treatment. Usually, if the patient is a hypotensive, we can consider fluids and try to maintain a MAP of around 65 millimeter of mercury. So we can use inodrops, can be epinephrine or dobutamine, whichever, and based upon the situation of the patient. And we can consider IABP or Impella, ECMO, and consider the patient for a TAVI. So in normotensive patients, we can initiate diuresis, and usage of vasodilators should be used with caution, because these are all poor forward flow conditions. So we should not deplete the patient of volume and make the patient more hypertensive. So the usage of vasodilators should be at caution. So all AS patients need a definitive valve interventions. These are the valves, these are the surgical valves which we do through aortic valve replacement, and these are the TAVI valves. So previously, historically, surgical aortic valve replacement was the gold standard. Now TAVI is considered the gold standard for even in patients with, but it has to be individualized. So in patients younger than 65 years, most of the times it can always be a surgical aortic valve replacement, and 65 to 74 it can be a TAVI or a SAVR depending upon the suitability of the TAVI or and clinical conditions of the patient. And more than 75, if the patient is feasible for a TAVI, the patient should go for a TAVI. In acute AR, the goal of medical therapy is usually to reduce the congestion and minimize the LV afterload. So in patients without shock, vasodilators reduce the LV afterload and improve the forward flow. In patients with AR, one of the important thing is that in chronic AR we usually use beta blockers and to decrease the dP by dt. In acute AR, as the aortic regurgitation is more during the diastole, so we should not use much beta blockers and prolong the diastole. So beta blockers should be reduced when there is acute AR. And in patients with cardiogenic shock due to AR, we can consider pacing or a beta agonist therapy to shorten the diastole. So as I earlier said, all current MCS devices are contraindicated in acute AR because it can increase the LV afterload and it can be detrimental to the patient. And the positive pressure ventilation always helps patients in volume overload states, and it can be beneficial by decreasing the LV preload and afterload. So as I earlier said, that acute CVAR due to aortic regurgitation, aortic dissection or infective endocarditis requires a definite surgical treatment. And in patients with bioprosthetic valve failure, if there is some paraprosthetic valve regurgitation, we can do just a percutaneous intervention by closing the leak, paravalvular leak. And we can also consider doing a valve-in-valve intervention in valvular degeneration conditions. So acute MR is always highly afterload sensitive, and it can tolerate, the patients will not tolerate hypertension. So the vasodilators are the important therapy in patients with acute MR. So we can use dobutamine or milrinone whenever necessary. Pure vasoconstrictors can increase the blood pressure and can be detrimental, so should not consider pure vasopressors like phenylephrine or vasopressin. IABP is classically helpful in acute MR. And mitral valve repair is the ideal definitive approach. In patients who are very sick or can be, we can always consider transcatheter H2H repair. In mitral stenosis, there is inadequate diastolic filling, and atrial fibrillation or increased heart rate can predispose to a acute heart failure. Diuresis is useful to treat pulmonary edema, and MCS devices are typically ineffective because this is a preventricular condition. So vasopressors such as which do not elicit tachycardia, like pure vasopressors like phenylephrine and vasopressin can vasopressin can help. So LVOTO, as I already said, that LVOTO is a different condition where there is a dynamic outflow obstruction. So these can occur in a fixed outflow. It can occur in HOCM where you get there is a systolic anterior motion of the mitral valve which can cause a dynamic LVOT obstruction, and in stress cardiomyopathy the apex gets ballooned out so that the base gets hyper contraction, leading to a outflow obstruction. So this is what is called as a LVOT obstruction. So it can cause a dynamic LVOT gradient. So in this condition, it is similar to a stenotic lesion. So we should not deplete the patient of volume. So we can use vasopressors like phenylephrine and vasopressin, and avoid vasodilators, and overzealous diuresis should be avoided in these patients. And VSD after MI, so acute myocardial infarction associated VSD and free wall rupture has a high mortality. So with acute VSD, the LV offloads into the right ventricle. So diuretics, vasodilators, inotropes and vasopressors may be effective. So IABP is typically recommended, and it is a surgical patch closure is the definitive approach to myocardial infarction associated VSD. But in certain cases, if the patient is too sick and if it is feasible, we can try a percutaneous device closure of ventricular septal rupture. And prosthetic valve thrombosis, you can see that there is a mechanical prosthetic valve and there is a thrombus sitting in the prosthetic valve. So this can cause a acute hemodynamic crisis by obstructing the outflow. So LV inflow, obstructing the LV inflow. So the medical therapy may be definitive in thrombosis of a native or prosthetic valve. We can start anticoagulation, or sometimes we can try with a low dose thrombolytic therapy. So if the patient is hemodynamic gradients are not improving after 3 days of thrombolytic therapy, generally the response may not be very adequate, and the patient may need a surgical treatment to remove the thrombus. So this is the center which I worked in China for China. So usually in developed countries, the ED emergency department has a cardiologist associated with the emergency department. They have a separate cath lab in the hospital associated with attached to the ED, and in certain severe cardiogenic shock and acute decompensated heart failure, the ECMO team, everything will be attached to the ED, and they start in the ED. So this is a patient where it's a 61-year male. He came with a moderate chest pain to his back and left upper limb and neck. So he was diagnosed with the posterior wall MI. So the patient was immediately taken for angiogram, and it showed that the left circumflex was completely occluded. So, and it was revascularized, but the patient developed breathlessness, and he was having acute pulmonary edema. So we did a transesophageal echo which showed that there was a severe MR. You can see that there is a severe MR, and secondary to a posteromedial papillary muscle rupture. So usually these are the conditions which in India we usually go for a surgical valve replacement, but most of the times the patient needs stabilization and then they go for a surgical replacement, but during the course of the illness they usually succumb. So what they did was already the patient was on IABP during the procedure. Then they started with a ECMO, and they proceeded with a mitral clip. So you can see that there is a mitral clip, 2 clips are positioned, and literally there is no MR. So you can see that there is no MR. There is a reduction of MR, and the patient was discharged after 7 days. So these are the ways which we should improve in the future, that in acute emergency conditions always trying percutaneous methods can be little safer. So in ED, emergency department, it's a clinically focused diagnostic and therapeutic approach is essential for to handle structural heart disease emergencies. Doppler echocardiography is a mainstay of diagnosis, and these patients can have decompensated heart failure and cardiogenic shock in spite of a good LV function. Definitive surgical and percutaneous intervention is required, but these critically ill patients should be stabilized with medications and to reduce the risk of procedural complications. Thank you.
Thank you so much, sir, for the wonderful talk. Now I call upon Dr. Venkateswar, sir, to felicitate Dr. Sendilraj, sir. Thank you for the engaging session. Now we will have a short tea break and reassemble in the hall within next 10 to 15 minutes. Thank you.
மைக் ஆஃப் பண்ணிட்டா கொஞ்சம் ஆஃப் பண்ணுங்க பேட்டரி இதாகும்
Audible? Audible? Okay, this one. A very pleasant good morning to one and all present here. So my topic of the day is vascular vortex navigating life-threatening emergencies. So I'm Dr. Venkatesha, consultant intravascular interventional vascular surgeon at Kamakshi Memorial Hospital. So I see many emergency vision people here. So you are the first shield of our medical department, right? You should be answerable to 3 questions that when you see a patient, right? So first, what is the condition, what you are going to do, and what is the next step with a consultant, right? These 3 steps that you would be very much answerable. So among all emergencies, vascular emergency is very much life-threatening because that is visible. First of all, you can see the patient in very great panic with heavy bleeding or limb perfusion rate, limb ischemia like that. So patient will be very panic in that situation. So you should be able to first diagnose, then initially stabilize, then answerable to the people also. So in my coming slides, I will be showing the this common vascular emergencies and what all you should do initially, and then stabilization, and then the treatment. Okay. So, வர மாட்டேங்குது இது ஒர்க் இது ஒர்க் ஆகல பாயிண்டர் இருக்குது, இது அடுத்தது ஸ்லைடு வர மாட்டேங்குது. ஸ்லைட் வீடியோவில் இல்லை, அனிமேஷனில் இல்லை. ஓகே 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 இதுவா? ஓகே ஓகே இது மட்டுமா? மைக்கு ஒர்க் ஆகல, மைக்கு ஒர்க் ஆகல. இது ஒர்க் ஆகல. So time is tissue. Every minute counts in vascular emergencies. Vascular emergencies are hyperacute emergency conditions with high mortality and morbidity. Requires prompt diagnosis and decisive management. Delay leads to irreversible ischemia. So it's not a single man show, it's a multidisciplinary approach. So what are the common vascular emergencies that you people face? Let us be interactive in this session, because many more common you face vascular emergencies, I know. Trauma, dissection, aneurysms, bleedings, everything you are facing. So what is the most common vascular emergency you are faced with, and what is the problem that you faced with? Can anyone please? Most common vascular emergency, anything? Aortic dissection. Oh, aortic dissection. What is aortic dissection? It's a tear in the aorta. I'll discuss about the aortic dissection in the next few slides. Next, aortic dissection, then acute limb ischemia. Very good. Acute limb ischemia, then bleeding, right? You'll be facing with trauma and bleedings. Okay. So we'll discuss each and everything in detail, right? So vascular emergencies. The entire vascular emergencies I narrow down to 2 problems. Either no flow, so either artery or venous, there will be no flow, or uncontrolled flow, right? There will be heavy bleeding, such as vascular trauma, blunt and penetrating injuries, or iatrogenic also. So these are 2 emergency conditions in vascular. Narrow down to 2 simple things. The one is no flow or a uncontrolled flow. So again, I categorize these things into 3 types. One is arterial, one is ruptured aortic aneurysm, dissection, acute limb ischemia, mesenteric ischemia, and iatrogenic access sites. Next is trauma, and next thing is the venous, where the most common thing you deal with is DVT and pulmonary embolism. So many emergencies are deal with these two very common, DVT and pulmonary embolism, because patient comes within hours with the difficulty in breathing and suddenly collapse. So we have to be very prompt in the treatment in these two conditions. So what is aneurysm? So aneurysm by definition is 50% more than the size of the reference diameter of the artery is called as aneurysm. So there may be a fusiform aneurysm, saccular aneurysm. So fusiform, the rupture rate is very low, whereas the saccular aneurysms, which comes like a button column like thing, so the rupture rate is very more in the saccular type of aneurysms. So what presentation the patient will have is, there will be a previous history of aortic aneurysm, and he suddenly presents with a sudden onset of severe abdominal pain with hypotension. So this is not common. I'm saying that it's not common. You will be having many patients with abdominal pain and hypertension, but keep in mind, as a differential diagnosis of ruptured aortic aneurysm in old age people also. That's what I want to emphasize in this symptomatology. So if you suspect a ruptured aortic aneurysm, within 30 minutes the patient should be in theatre. That is the dictum. Otherwise, we lose the patient. For example, when I was doing my postgraduate, a patient was admitted with saccular aneurysm. He was posted tomorrow morning, 8 o'clock. Night, he was well prepared. He was very much stable. He went for a washroom and he died in the washroom itself. So you should be very careful with such aortic patients, because it's more prone for rupture and the death is very immediate. But we can save the patient if you act promptly in the emergency room. So what you have to do is that first, your basic things, ABC, airway, breathing and circulation, arrange immediate blood and fluid management. Then there is a term called here, I have to emphasize a term here, that is called as permissive hypotension. What is permissive hypotension? The word permissive hypotension indicates that your vital organs are getting perfused and your other non-vital organs are getting less perfusion. That is, so you keep your mental status alive and your kidney alive and your heart alive. Other things are secondary to these three, so that for that permissive hypotension of value between the 70 to 80 or 90 is enough. So don't worry about hypotension in the case of rupture aortic. Don't keep on pushing fluids or blood. In that, you maintain a BP around 70, that's enough, because your mental perfusion, heart perfusion and kidney perfusion is important in such cases. So maintain a BP of around 70 to 80. Don't get panic or start inotropes or nothing. So it's a volume loss condition. So you have to perfuse either with fluids or blood. Okay. So if you have an in-house vascular surgeon consult, you can immediately call him, and immediately you have to, when you suspect, do a imaging, rapid imaging, and shift the patient to OT, and we will take care of the patient. So this is the basic thing that has to be done in the emergency room. Okay. So what we do? So this is called EVAR. What is EVAR? Endovascular aneurysm repair. So it's a in case of ruptured aortic aneurysm, it helps in a bridging therapy to save the patient life, because just a covered stent placement will seal the bleeding artery and we can save the patient immediately. And this is called TVAR. What is TVAR? TVAR is thoracoendovascular, where the any rupture in the thoracic aortic aneurysm, we can go for TVAR. So if a patient is not affordable, then so these are very costly procedures, both about 10 lakh rupees. So if they are not affordable, we can go for straightly open procedure, where we go for aortoileo bypass. So we can see the aorta, the thing that is opened is the sac, aneurysm sac that is open, and we have placed the graft inside the connecting the aorta to bilateral common iliac arteries. This procedure is called as endoaneurysmography with aortodistal bypass. So next is the another question. So dissection. What is dissection? So dissection is a tear in the inner wall of the aorta, allowing the blood flow between the two the aorta itself divides into two parts, one true lumen, another is a false lumen. So this tear in the blood flow goes both into the true lumen and also false lumen. So what symptom? So there will be a sudden severe chest pain radiating to the back. Mostly he will complain of back pain, severe back pain, and there will be a asymmetric pulse in the both arms, and BP difference also will be more than 20 mm mercury. And signs of malperfusion syndrome. What is malperfusion syndrome? If the dissection is extend till the visceral arteries of SMA, celiac, or into the iliacs, the limb or the bowel gets less perfusion and it goes for ischemia. That is called malperfusion syndrome. So we categorize the aortic dissection into two types, known as type A or type B. Type A is proximal to the brachiocephalic innominate artery, and type B is distal to the subclavian artery and between the subclavian and the carotids. So we categorize these two. Type A is hyperacute emergency that has to be dealt with cardiac surgeons, and type B, when we operate, is a question mark. So type B initial management, it's there in the ER. What you do? So patient presents with severe hypertension. So hypertension is one of the reason for type B aortic dissection, and patient complains of severe chest pain also. So in that case, you have to control the BP to 140 less, 140 below. Then you have to manage the pain with any opioids. Opioid we can use, and we should control the pain and hypertension initially. That is the acute stage. Acute stage in type B dissection, there is no role for surgical intervention. Only the medical management comes, unless until only three conditions where there is a rapid expansion of false lumen, or patient presents with severe chest pain in spite of maximum opioids, or patient presents with malperfusion syndrome. In these three conditions only we go for emergency surgery in case of type B aortic dissection. Otherwise, we can manage initially with medications in acute emergency, then make the patient go into subacute stage or chronic stage, then we go for intervention. Because intervening in acute stage, that even if you intervene, the dissection may progress into type A. Okay, so that's why we have to stabilize the patient in initial acute stage. Patient should be turned into a chronic stage, then only we will go for intervention in case of type B dissection. So initial management is in our emergency department. So this is a classification, classical TBK, and stand for type A and type B, or type 1, 2, 3. So management algorithm is same what I said. So in type of dissection, just CT chest or X-ray, chest X-ray itself indicates the shows the diagnosis. Just widening of mediastinum will be there in case of chest X-ray, and you can go for a transesophageal echo, where in ED itself they go for transesophageal echo and diagnose the dissection. Which type of dissection? Type A or type B? Type A means immediately call the cardiac surgeon. Type B you can manage by yourself, where control the BP, control the pain, and stabilize the patient, keep him in observation for 48 hours. Then assess for malperfusion syndrome. If the malperfusion syndrome is there, then call for a vascular surgeon and go for intervention. Okay. So these are some of cases that I did at our Kamakshi Memorial Hospital. We can see the type B dissection there. So why I intervene in such case? Because this patient was an ankylosing spondylitis patient with refractory hypertension with 4 to 5 antihypertensives. So the patient is a CKD patient on HD. Then he had ankylosing spondylitis. The ankylosing spondylitis will be a connective tissue disorder type, where the tear keep on extending. So one more thing, the third thing is refractory hypertension, where the patient was in 4 to 5 antihypertensives, and he was planned for renal transplant also. That's why we intervene in this case. You can see the dissection there, and what we did is that we did a carotid to subclavian bypass. So we can see the carotid to subclavian bypass and put a covered stent here. This is a TVAR stent that we placed. Why this carotid to subclavian? Because this is a covered stent, so the perfusion to the subclavian will be occluded. So that's why we direct the blood from the carotid to the subclavian, so that there is no limb ischemia risk. So this is the one of the case that we did at our Kamakshi. And one more, this So we can see the aneurysm here, and it was an impending rupture. This is a saccular aneurysm. It was posteriorly, very impending to rupture. This patient also a critical with multiple comorbidities. He had presented with cholelithiasis with biliary sepsis. So first what we did is we controlled the sepsis. We took out the gallbladder. Then we went for this ER procedure. So you can see the ER graft that is covering the entire aneurysm, and the patient was saved and is stable now. Next, common. This one, acute limb ischemia. What is acute limb ischemia? This is sudden deterioration to the arterial supply of the limbs. What are the causes? So a patient with rheumatic heart disease, you should be very careful when he presents with the limb symptoms, because most of them they won't be adherent to any that acetylene diet or acetylene protocol. They will be skipping their acetylene. They multiple emboling will be present. They will have multiple emboli that will be showering to the distal to the limbs. So thrombosis, trauma, iatrogenic are some of the causes for acute limb ischemia. These are 6 P's that you know. There should be very much thorough with these 6 P's when you look a patient with any symptoms related to limbs. Very much important at a emergency level, because all pulse should be examined when a patient comes with any limb symptoms or any paraplegia, any coldness of limbs. You should examine all pulse from superficial temporal artery till dorsalis pedis, because you can clinch the diagnosis there, you can save the patient there, you can save the limb also to the patient. So it's a classification, classical Rutherford classification, where we categorize the acute limb ischemia into 4 types. Type 1 is limb is viable and not immediately threatened. This is why where the pulse is very important, and you have to assess the sensory and muscle motor. You should look for his sensation, look for his motor movement, and if you have a hand, you should have a hand Doppler at your ER, where you should look for arterial blood flow, arterial signs at the various levels, and also venous signs. So in class 1, there won't be no pulse. Pulse won't be there, but there will be signs of artery audible in the Doppler, hand Doppler. Whereas in 2, there will be no pulse. There will be minimal loss of sensory loss, and there will be a absent arterial blood flow and arterial signs in the hand Doppler. In stage 2B, here and all, it should be very much careful, because patient go for acute limb ischemia with reperfusion injury when you go for reperfusion, and we will lose the patient in reperfusion injury. That's why it's very much important when you deal with these class 2A and class 2B and class 3, because even if you revascularize, we will lose the patient. We have lost 2 to 3 patients due to reperfusion injury. Reperfusion injury should be managed at the prevention of reperfusion injury should be managed at the ED level. You should give him adequate blood products, adequate hydration, and one more thing we suggest is that allopurinol tablet. We give 4 tablets on spot when you diagnose acute limb ischemia in class 2B, because these are free radical scavengers that reduces the toxicity of the reperfusion injury when the patient goes for reperfusion. Okay. Then class 3 is nothing can be done in such patients, because entire thing is damaged. If you reperfuse, we will lose the patient 100%. That's why we go for directly amputation in case of class 3 ischemia. So again, the algorithm, we can wait for class 2A with the image, but class 2B and all, we should be directly taken to cath lab, go for on-table angiography, and decide on the type of management, either endovascular or surgical or hybrid therapy. Then and again after surgery, confirm the intraoperative angiography, then go for medical management. So you can wait up to class 2A, not in class 2B. Class 3 is irreversible, that goes for amputation only. So class 2B is very much important. That you should be able to pick up the patient at this level, otherwise we lose the patient or limb, both. What we do? So we go for either acute limb ischemia with embolus, we go for embolectomy, or go for surgical bypass in case of long segment thrombosis. So other modalities of endovascular treatment is that we can go for catheter directed thrombolysis, where we keep the catheter inside the clot and start the lyse with any altiplase or retiplase. The clot get lysed. See, this is have added advantage, because in case of embolectomy or thrombectomy, the reperfusion injury is very sudden, because the reperfusion injury starts immediately when you perfuse the ischemia limb. But in the case of CDT, there will be slow, controlled reperfusion, and there will be an advantage over the open thrombectomy. And these are highly advanced technology that has been introduced for all kinds of embolus or thrombus. So this is a angiojet system. This is a where it is a pharmacomechanical thrombectomy, where we use both alteplase injected at the high speed level, and we will suck out the thrombus through the catheter. This is a indigo cat 8 system, that is a suction thrombectomy. Here there is no use of, advantage is that there is no use of any alteplase here. That means thrombolysis. We can directly suck out the thrombus, do with high pressure, and these also, aspirates also a pharmacomechanical type. So one of the case I did at our Kamakshi, because see, you can see the acute cut of the superficial femoral artery at the adductor level. You can see this it was diagnosed by emergency PG there. We took the patient immediately to the theater, to the cath lab. We took an on-table angiogram. We saw a cut off at the level of SFA. We immediately took patient consent, and we ordered the angiogram. I said no, pharmacomechanical therapy, where we injected a alteplase at high speed level, 300 rotations, 300 to 400 rotations per minute. We inject the alteplase injection, then suck out the thrombus with the. So we can post-operative, you can see the flow established, and patient walked the next day, and he was discharged the third day without any complications. There was no complications to the patient. When he presented, he was presented with paraplegia, so paralysis of that limb, right limb. He was presented with paralysis with no sensation, no movement, and still now he is having some sensory loss, but he is able to walk and all. So open thrombectomy I did recently, where you can see the acute cut off of the popliteal region. This patient, see, thing is that all comes to the cost. We can go for pharmacomechanical therapy here also, but that is very costly procedure. So we took the open thrombectomy. We can see the thrombus. This is a popliteal artery that is thrombosed. So we took the thrombus out, and flow was established, and patient limb is saved. This also picked up at the emergency department. They took immediately CT angio. We took the patient directly to the OT. We took the thrombus out, and patient walked off the 5th day. One more life-threatening condition. This is very much missed, and very much what I am saying, not at all cared about mesenteric ischemia. Every abdominal pain you think of appendicitis or cholecystitis or UTI like that, but this you have to be very careful, because once you miss this, we will lose the patient. That's the main problem in this case of mesenteric ischemia. So what is mesenteric ischemia? Is a sudden abrupt supply of cut off blood supply cut off to the intestine. It is called as abdominal angina. Like that heart, it is called as abdominal angina, and the symptoms are very vague. That is why we miss out this entity, because patient presents with abdominal pain, and there will be nothing in the any of the what do you say, radiological, initial radiological. Only when you go for CCT abdomen, you pick up the mesenteric ischemia. So patient presents with diffuse abdominal pain, nausea, vomiting, melena. Melena is one of the history that gives you this signs, because any abdominal pain, put your finger in the PR, go for PR. If you find any melena, go for CCT abdomen and look for mesenteric ischemia. So signs of peritonitis develops late, only when the systemic sepsis comes. That is the biggest drawback in this mesenteric ischemia, because patient presents even after 5th day of mesenteric ischemia with peritonitis. We will lose then we will go for resection of the bowel and short bowel syndrome, or patient go for electrolytic imbalance, sepsis and death. So when you find it initially, we can easily treat off with saving the bowel. I found 2 conditions that is very much dangerous in my career, in my so far vascular career. One is chronic kidney disease, because the patient will be alive and he keeps on going for dialysis, multiple complications. He will be alive, but it will be a very much pathetic. When you ask a CKD patient, he will tell their lifestyle. If you ask his lifestyle, very much difficult. And one more condition is this: with patient with short bowel syndrome, very much pathetic. He will keep on, even if he walk for 10 steps, he will lie down, because very much electrolyte imbalance. So these 2 conditions are very much, even though patient is alive, it's like a very much morbid. So you can see the acute cutoff of the mesentery system. You see, there are three vessels that supplies the entire bowel and abdomen. One is celiac, SMA, and IMA. If the entire collateral system, say we have multiple collaterals among these three, the entire collateral system is good, the patient will survive. If the collateral system is also damaged, and he will go for any of the major. So at least what the book says that at least two arteries, celiac or SMA or IMA should be patent, but that and all gone. All three should be patent. All three should, because any collateral gone, then that limb, that part of the supply will be gone. So all three should be patent. So again coming to the basics. So algorithm. So when you suspect bowel ischemia or a mesenteric ischemia, go for a CT angio, then immediately call for help. So what we do is that if there is no signs of bowel ischemia in angiography, then we'll go for any revascularization of abdomen, of the abdomen vessels, and salvage the bowel. Here comes the again compartment syndrome due to reperfusion of bowel. Bowel reperfusion injury is very much dangerous. So what I suggest that when you see a patient with mesenteric ischemia, give him adequate hydration, prepare him mentally, and both those things you will be doing very good. But give him adequate hydration and give him allopurinol tablet to prevent the reperfusion injury in future. So when you go for revascularization, the result of reperfusion, impact of reperfusion will be very less. Okay, hydration is must in case. So what we do again, I said no CDT, catheter directed thrombolysis, or we go for SMA thrombectomy, where we open the SMA and remove the thrombus out. So again we can go for other modalities of treatment such as SMA bypass, where if the thrombus is very much adherent, we can go remove with embolus. We can go for distal SMA bypass or SMA stenting, or we can go for open endarterectomy, where we can reperfuse both celiac and SMA at the same level. So this is one of the case that we operated. Patient present very late. We took a CT angiogram. We can see the thrombus from IMA. See, you can see the IMA occluded, SMA also occluded, and celiac also occluded. So entire bowel was gone. Patient came with only short bowel syndrome. Still very much difficult for him to survive. So it's an era of interventions. Nothing. Complications also is becoming very high due to interventions. So the potential is during cardiac and neuro and peripheral interventions. Most common site is femoral, and second is brachial. So femoral access, because femoral, the exact location, puncture sites, everything matters. So what are the complications that we face with access site complications? It hematoma, pseudoaneurysm, bleeding, AV fistula, and thrombosis. So these are the complications, and each have its own symptoms and signs. So in case of hematoma, in here, what the procedure you do is that you go for central line lines, either jugular or femoral, right? So you should be very careful. Always use ultrasound while puncture. Don't puncture without ultrasound. The guidelines have been changed completely. So don't puncture an artery or vein without ultrasound, only under ultrasound guidance. And always take care, after puncture, your guide wire passes freely. Otherwise, stop it and get back it. Okay, don't meddle your guide wire. It should pass freely. Okay, otherwise don't meddle with the guide wires, because you go for dissection, thrombosis, and bleeding, right? So next is, what is the exact site of femoral puncture is that you should go for this medial 1/3 of the femoral head, where the artery lies over it, because this we can compress the artery. Always the artery should be compressed against a bone, then only the bleeding stops, otherwise it won't stop. Artery has got its own mechanism of stopping and thrombosis. So if you do it correctly, the bleeding will stop, otherwise the bleeding will come, it won't stop at all. If you go for here, it's a high puncture, you will get retroperitoneal hemorrhage. If you go down, you will get pseudoaneurysm or bleeding. So should puncture exactly in this. You have a 3 centimeter radius, you can puncture anywhere here, but it should be against a bone. The same thing happens in the brachial, the same thing happens in the carotid, same thing happens in all the arteries. You should puncture against a, you should have a base of bone for compression, otherwise don't puncture. Again, you see whether a guide wire passes freely or not. If it doesn't pass freely, just pull out, give compression for 5 minutes, then again you try. Nothing wrong on it, but don't meddle your guide wires into the. So these are some of the complications that we face. This is the major complication because patient goes for collapse, and we can't, very difficult to survive the patient because there will be a issue. The retroperitoneal hemorrhage, what is the difficulty is that the abdominal decision comes last after the, because it seeps the entire retroperitoneum, then only it comes to the preperitoneum level. So you will find it very late. If you don't have a BP cuff or recording normally, only after a patient collapses, you find that the patient have developed retroperitoneal hemorrhage. So very much always pre and post procedure, look for a manual BP or have a good BP monitor there. So when even if you suspect for retroperitoneal hemorrhage, so if a patient is hemodynamically stable, we can give conservative management. But hemodynamically unstable, nothing can be done. You have to take it emergency to the OT and treat it. So what all we do? These are some of the procedures that we do for our access site complications. So first is any bleeding, we go for coil embolization. Any pseudoaneurysm, can direct, first option we can give a direct US compression, because compressing the neck itself thromboses the pseudoaneurysm sac. Or we can go for glue thrombin injection. We have a compression sac and give the thrombin injection, and we can place a covered stent, or we go for open repair. Open repair is very last resort. Nowadays we are not doing it for any access site complications, all endovasculars only. So here we can see one of the complications that we face. So you can see the leak here. So this is the artery, and puncture was a little bit lateral, and there was an extensive leak, and there was a huge hematoma in the groin. And what we did, it was on late midnight around 1 o'clock. We was fortunate that we put a covered stent, available covered stent, because we didn't get a thrombin, we didn't get any coil or there. So we are able to get a covered stent available at that time. Then we put a covered stent across it, and after covered stent, you can see that the leak is very much reduced and the patient is saved. This patient, the hemoglobin suddenly dropped to 4, and hypertension, he went to around 60 systolic, and after this patient recovered very well. But putting a cover stent across a joint, we don't prefer, because these are joint where the cover stent breaks and again goes for thrombosis. So across the groin, we always prefer go for any coiling or glue thrombin injection. Cover stent, we have to avoid it. But if in case of emergency, life is more important than limbs, so we have placed it. And this one most common, this is the most common vascular emergency that will be dealing with vascular trauma. When you identify the patient, when you act smart, we can save the patient and that's all the limb. Okay. So what are the types that you see? Either contusion or puncture or laceration or complete transaction. Here and there will be a heavy bleed and all. So these are the types of vessel injury that occurs. So the outcome, or what is the outcome of vascular? Because this is the most dreaded trauma that we face, and because the time of onset and surgery, very important. Why? Again, goes back to reperfusion injury. Reperfusion injury kills the patient post-operatively. Next is initial resuscitation strategies, very important. You have to hydrate, keep the blood products ready, management of reperfusion injury, and extent of other associated injuries, blood loss, ischemia time, other comorbidities, and patient physiology. So the only trauma where patient physiology matters is here. So what is the pre-op condition of the patient is very important. Vascular trauma, to save the patient and also to save the limb. This is very important, that as a emergency physician, you should know what is the hard sign of a vascular trauma and soft sign of a vascular trauma. So hard signs. So absent pulse, act immediately. Ischemia limb, all 6 P's, act immediately. Pulsatile bleeding, you have to act immediately. Expanding hematoma. When he comes to ER, the hematoma will be 2 centimeter. When you receive the patient, it goes to 4 or 5. You have to be very careful because next is rupture. Then shock with ongoing bleeding and palpable thrill or audible bruit. These hard signs you have to be very much careful, and you should be stick it in your ER room. And soft signs where you can act not slowly, you can go for stage by stage procedures. One is that history of active bleeding, ear history, not active bleeding, ear pulsated bleeding. So decreased pulse, even pulse will be there, but it will be decreased. Non-expanding hematoma, injury to adjacent nerves, and penetrating close to the major vessels, not a major vessel injury, but close to the vessel injury. So here you can go for imaging and then proceed. Where hard signs, you have to take the patient directly to the theatre and operate. Again, the same thing, algorithm. So hard signs, you have to take the patient directly to the theatre, or in case of soft signs, you can image and then reassure and then you can treat. So what to do in case of emergency bleeding? So these are some of the things that we have. Either go for manual compression and keep compressing with the staff nurse and shift the patient directly to the OT. Keep packing. All packing should be ready, because if you are a huge volume trauma center, you should have all types of packings for any bleeding to control. Then tourniquets. Tourniquets should be there at your ER level, because life is more important than the limb. Even tourniquet application, even if it exceeds the tourniquet time, doesn't matter. You can save the patient, even if not the limb, because bleeding will kill the patient, not the limb ischemia will not kill the patient. Okay. Then hemostatic dressings, many huge dressings have come off, the hemostatic dressings that that should be known to you, and you should be prepared with the hemostatic dressings. And you should have your arteries and all instruments ready in your ER in case of emergency bleeding, where you can clamp the artery. You don't worry, we'll take care. You clamp the artery and send the patient to the OT. Don't worry about clamp no, don't worry. You clamp the artery, because life is more important. Bleeding kills, not the ischemia. So what we do? Well, we can go for endovascular balloon occlusion. This is the latest technique, where we can have a balloon at 3 levels. See, pelvic injuries with iliac injury, with massive hemorrhage and all, we can't wait for any imaging and all. That time we take the patient directly to the theatre, cath lab. We have this Ribova balloon, resuscitated balloon of aorta, where we can keep the balloon here or here or here, any level, and occlude the entire aorta till we take the control of the artery. Then angioembolization. So this is so they are savior of our country, and so they face many vascular injuries. And see what type of tourniquets that they have is that, see, this is like a Ribova. Ribova is a modified manual Ribova, where the pressure can be controlled manually. We can increase the pressure to extent that it compresses the aorta. So if the patient, if the victim have any bleeding vessel like that, they will use this, clamp the entire aorta externally and shift the patient to OT. And this is for femoral compression, tourniquet. And the vascular shunt placement. So these are come in ER also, in Armed Force Medical College and all. They do this in the ER itself. What they do, see, if they find any artery being torn, so they connect the artery proximally distally with the rumal tourniquet, so that limb perfusion goes on, and there will be a reduced reperfusion injury till the definitive vascular repair has been done. So the vascular shunt placement is very important to reduce reperfusion and salvage the limb. So these are some of the cases that we handle at Kamakshi. We can see this trauma with both all arteries being cut, and we can see the vein repair done, vessel artery repair done with veins, and post-operative now the patient is walking also. And this is the tourniquet application that they did in ER. They did an excellent job, because what they did is that patient came with profuse bleeding. His BP was 30. The ER people, they immediately took a BP apparatus. They increased the BP above 200. They blocked the then immediately perfused with O negative blood groups to on table. On the ER itself they perfused. Immediately they called me for help. Then I went and in ER itself I clamped these things, and we took the patient to the OT, and patient was salvaged, and limb also was salvaged, because acting fast is very important in case of vascular emergency. And this is a pregnant lady. She went with in a bike with her husband, and she is a 3 months old, 3-month amenorrhea, and she developed this. See, this is a non-expanding hematoma. Should be very careful. If you dislodge this, the bleeding will, there will be heavy bleeding, and you will lose the patient there. So in case of such non-expanding hematoma, keep the patient safe. Don't mobilize the limb excessively. Apply a bandage and shift the patient to the OT immediately. Okay. And one of the common problem that we face is that DVT, right? Even formation of blood clots in deep veins, it's called as DVT, and patient presents swelling and red discoloration. So what are the two major conditions that DVT is? That phlegmatious cerebellar dolens and phlegmia alba dolens, where the arterial compromise occurs due to the heavy swelling. So management, most of this treated with anticoagulation. Only in those two conditions where I saw alba dolens and cerebellar dolens, we go for emergency suction thrombectomy or endovascular thrombectomy. What we do is that either go for venous thrombectomy, open venous thrombectomy, that is very much outdated, because we never do venous open procedures. We go for either catheter erythrolysis, as I mentioned, and endovascular thrombectomy, right? And my last topic of the today is my pulmonary embolism. So blockage of pulmonary artery due to the clot that discharges from the DVT, right? So what are the symptoms? Patient presents with sudden onset of dyspnea, chest pain, rapid heart rate, syncope, and hemoptysis. These are common symptoms. So what you have to do in emergency is that you should categorize strategize the patient into either stable or unstable patient. Stable patient you can treat with medications. Unstable patient you have to take it emergency to the cath lab and go for suction thrombectomy or open thrombectomy, right? So this is a modified score that we internationally used, pulmonary embolism risk satisfaction index, that should be you should categorize the patient based on this PESI score. So again, the protocol, when the patient is hemodynamically unstable, you should go for open or endovascular procedures, or if the patient is stable, you can go for medical management, which lysis or so. So either go for open thrombectomy or endovascular thrombectomy. And this is one of the case that we did at our Kamakshi, where we can see the IVC being occluded with thrombus. And this I said no, that endovascular suction thrombectomy, where we don't use any lysis here, we can suck the thrombus out with this suction thrombus. So what is the take home is, time is organ, limb, life. So delay kills, early awareness saves. Aortic catastrophes, acute limb ischemia, mesenteric ischemia are time dependent killers. Act smart and early. Always look for pulse in symptoms related to limbs. Early anticoagulation is a bridge to survival. Disproportionate abdominal pain, always suspect mesenteric ischemia. Iatrogenic are very common. Don't worry, early recognition prevents catastrophe events, and call for help. Hope it was very good. Thank you for patient listening. Thank you very much.
Thank you so much, sir, for the wonderful presentation. Now I welcome Dr. Vijay Karthikeyan, sir, to felicitate Dr. Venkateshwar Ravi, sir.
Thank you. Thank you. Thank you, sir. Morning, ma'am.
பார்த்து மேடம், கீழே காஃபி எடுத்துருங்க. ரெண்டு பேர்
A very good afternoon, one and all. I am Dr. Kamakshi. It gives me immense pleasure and pride to welcome you all to KEMCON 2026. Every great journey begins with a small step, and KEMCON too began as a humble spark, a small CME started nearly 4 years ago by a team of highly passionate and dedicated emergency physicians with a vision to create a platform that is clinically relevant, academically enriching, and truly impactful to patient care. What started as a modest initiative driven by purpose and passion has today grown into something far greater. With the blessings of Dr. Kamakshi Amma and the constant encouragement and support of Dr. T.J. Govindarajan sir, Dr. T.J. Shivaranjani ma'am, Jayanti ma'am, Professor Dr. Radhakrishnan sir, Dr. Rajeshwari ma'am, Leo sir and the admin team, and our ER team, the small spark has now evolved into a radiant flame. From KEMCON 2023, we have grown into KEMCON 2026, a conference that is not only nationally recognized in its presence, but steadily progressing towards international standards and global collaboration. With this brief introduction, let us begin this auspicious occasion. We start with Tamil Taiwad. I request everyone to kindly rise.
நீராறும் கடலொடுத்த நிலமடந்து கெழிலொழுகும் சீராறும் பதனமென திகழ்வர கண்டமும் அதிசிறந்த திராவிடனல் திருநாடும் தக்க சிறு பிறை முதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுக எத்திசையும் புகழ் மணக்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியாது செயல் மறந்து வாழ்த்துதுமே வாழ்த்துதுமே வாழ்த்துதுமே.
Thank you. Please be seated. We shall now proceed to the ceremonial lighting of the Kuthuvilakku, symbolizing the dispelling of darkness and the spread of knowledge and wisdom. May I request our esteemed dignitaries to kindly come forward for the lamp lighting ceremony. Radhakrishnan sir, sir, please. Thank you so much. May I now kindly invite our esteemed dignitaries to the dais. Dr. T.G. Govindarajan sir, Dr. T.G. Shivaranjani ma'am, Dr. Saujanya Pratibala ma'am, Dr. Hariharan sir, Dr. Ramohan sir, Dr. Sai Surendra sir. We shall now move on to the welcome address. It gives me immense pleasure to welcome Dr. T.G. Shivaranjani ma'am, Director, Finance and Operations, Dr. Kamakshi Memorial Hospital, the most charismatic and ever supportive personality, our very own Shivaranjani ma'am, a woman of quality, a dynamic leader, whose dedication and constant guidance have been instrumental in shaping our ER team and organizing KEMCON 2026. Ma'am, may I request you to kindly deliver the welcome address. Good morning. Good morning. So some events we mark in the calendar, and some events progressively are events to be expected. We expect for it to occur. And slowly, over time, those events become our culture and identity. One such event is KEMCON for Dr. Kamakshi Memorial Hospital. I'm just back from a conference organized by the Indian Society for Colposcopy and Cervical Pathology. It was all about cervical cancer, and we know cervical cancer is the second most common cancer in the world. And I saw a big audience of pathologists, gynecologists, and other community interested physicians there gather. And there is a constant yearning among medical professionals to upskill themselves, to know about keep update about the recent advancements, to share evidence-based protocols, and to network. And as we gather today, for the 4th consecutive year, it gives us immense pride and satisfaction to see KEMCON having grown into a meaningful academic platform, one that brings years of experience of specialists, practical learning points, take-home message, and a group of people with shared interest in improving emergency care outcome. On behalf of Dr. Kamakshi Memorial Hospital, the leadership team, I warmly welcome all of you for KEMCON 2026. A special welcome to our chief guest, Dr. Saujanya Street, the head of the Emergency Medicine, Apollo Hospitals, Hyderabad, and National President of Society for Emergency Medicine, India. With all her schedule, she is here with us today, and we are extremely privileged, and her presence demonstrates the commitment she has for such academic enrichment programs and validates our KEMCON. I extend our warm welcome to Dr. Hariharan, our chairman, Indian Medical Association, Junior Doctor Network, who is more or less a part, an extended family of Dr. Kamakshi Memorial Hospital. Thank you so much for joining us, sir. A very warm welcome to our visionary leader, our chairman, Dr. Govindarajan sir, who is a pillar of support in all our endeavors. He always sees ahead of time, and with his blessings, KEMCON is there for the 4th year consecutively. A warm welcome to Dr. Ramohan sir here. A special mention
about Dr. Sai Surender. I think he needs no introduction. The moment he joined us in Kamakshi, I think 4.5 years back, son. 4.5 years back, yes. I think the year he joined, he brought in Masters in Emergency Medicine for Kamakshi in our premise. And he launched this KEMCON, which was in the first year more or less like a CME. He has an innate art, he has that inbuilt art of interacting with people, having a network built, is capable of organizing such programs with ease, and he has also built in a structure for in all our ER departments where we have almost 4 or 5 branches, including the one in Port Blair. So he is such a person with a charisma, and I am thankful for him to be a part of our team here. Emergency medicine is a unique specialty that demands all of you in a high alert state of mind throughout 24 hours. You have an adrenaline rush every moment, every patient you see, not knowing what's going to happen the next moment to that patient. So you need fast thinking, sharp decisions, and what all, seamless teamwork. That's why such conferences, which are not just about presentations, but about meaningful conversations which you have with mentors and faculties here, that sharpen our practice and ultimately improve patient care. To all our speakers, organizers, participants, thank you so much for giving KEMCON the grandeur of not just being an event, but a growing academic tradition. With that, I extend a very warm welcome to each one of you. Thank you, and wishing you all a great learning ahead. Thank you.
Thank you, ma'am, for that warm welcome. It's now my honor and privilege to invite our beloved chairman, Dr. T.G. Govindarajan sir, chairman and managing director, Dr. Kamakshi Memorial Hospital, as ma'am told, our visionary leader, the architect of our entire ecosystem, whose guidelines and foresight have shaped the growth and excellence of the situation. Sir, may I request you to kindly deliver the presidential address.
Good morning to everybody. Respected dignitaries, the chief guest, Dr. Soujanya Sri, Dr. Hariharan, Chairman of Indian Medical Association and Junior Doctor Network, Dr. Ram Mohan, Tamilnadu President for the SEMI, and Director, dignitaries on the dais and off the dais. As you all know, today is the 4th conference that's being conducted by Dr. Kamakshi Memorial Hospital on emergency medicine. See, emergency medicine is the heart of any institution. It not only helps the hospital, it also helps the society. See, about 30-40 years back, we never had emergency medicine. Like we used to call that place as casualty. You know the meaning of a casualty. So, later it's changed to emergency medicine. There was no qualified persons those days. Basically, there only undergraduates used to sit in the casualty in the government hospital as well in the private sectors. And undergraduate training never had any of the skill sets of emergency medicine specialists today, like intubation, central line access, and to act on the patient with the ventilator and other things were not taught those days. So now with the development of technologies, development of emergencies, I'll say with the modern days, you get a lot of trauma, cardiac emergency, neurological emergency, and technological advancements on the gadgetry to find out all the emergencies immediately. The triage was not there those days. In the casualty, we used to receive both cold cases as well as emergencies. So the emergency will wait outside, the cold case will be inside. That was the state. My mentor, Professor Raghavel, is sitting here, who taught me, how to intubate and other things those days when he was a professor of anesthesia at Stanley Medical College. It was all not taught during the curriculum of undergraduation those days. I'm talking about 40 to 50 years back, I should say. So the importance of emergency medicine has started coming to the, it is the lifeline of all the hospitals. You are the entry point of any institution you take up. And as our director said, I should make a special mention about our Dr. Sai Surender. I'll say he's the founder of emergency medicine at Dr.Kamakshi Memorial Hospital. So every moment of his, as he acts, that is, compassion meets urgency. See, you have to be compassionate as well as you have to make decisions immediately in the emergency room. You have the triage happens today everywhere. He immediately, as soon as the patient comes, he gets into action and he puts all his subordinates as well as the students into action. He has trained most of the nurses of our hospital to handle any emergency. And emergency does not stop with the emergency room. See, we are actually in the panel of, Airport Authority of India to handle air crash emergencies, where you have no time to think. You have to find out who will survive, who will not survive. So accordingly, you have to act, triage outside the emergency room. Those kind of things also, he had gone many times to the airport and, he has made protocols there and he has helped them to categorize the patients when there is such emergencies. So we are really gifted to have Dr. Sai Surender with us. And, I just want to add that, it's just not the skill sets you should develop, you should also have the knowledge of medicine when you do emergency medicine. Because in our country only, we doctors go and intubate, we doctors go and put the central line, whereas abroad it's all done by technicians. All the paramedical works they do that job. So it's that you have to decide when to intubate, when not to, when to initiate, say suppose you get a burns case, when to initiate things, you should be able to direct and get the work done by the paramedical workers. So it's equally important, not only you acquire knowledge, you should also train the paramedical workers. So all this, I wish you all the best, and all of you should, you are actually helping the society. It's just not the hospitals that needs you, it's the society needs emergency medicine physician everywhere. And Sai Surender has taken the initiative to train even the public on BLS and ACLS. And we have taken up as a corporate responsibility with the help of our Vice President. He goes and meets all the corporates and train all the employees also. Like that, if everybody can join together, I think the emergency outcomes will be very good. Thank you so much.
Thank you, sir, for those inspiring words. Your leadership and commitment continue to guide us and set us the benchmark for excellence. It's now my distinct honor to invite our esteemed chief guest, Dr. Saujanya Sri Patibandla ma'am, Honorable President, Society for Emergency Medicine, India, and the Head of Department of Emergency Medicine, Apollo Hospitals, Jubilee Hills, Hyderabad. An inspiring leader, a strategic thinker, and a true pioneer in emergency medicine who has consistently demonstrated excellence, dedication, and impactful leadership throughout her career. Her journey stands an inspiration to many, reflecting what passion and vision can achieve. Ma'am, may I request you to kindly deliver the Chief Guest address.
Good morning, respected dignitaries on the stage, colleagues, and my dear emergency physicians. You have been hearing about emergency medicine, evolution of emergency medicine so far. Let us take a step back and see our regular scenario. At 2:30 a.m. in the night, we have received a 21-year-old with a severe head injury, wheeled into our emergency departments. What happens inside emergency medicine, our emergency department, we all are aware what we do and all. But what about the family that is outside? They will be waiting with so much of a tension and a chaos, hoping that there is somebody who can handle that emergency and take right decisions for the patient when it is very much needed, very much in the middle of the night. So in that moment, the hospital is not defined by the buildings that it has been built, but it is defined by the emergency department that has been set. For that, we need the leadership to think ahead and define the scope of emergency medicine, and it is very important as well. And that is why, for me, being at KEMCON is very, very special, because the institutions like Kamakshi Memorial Hospital understand something very important. Emergency medicine is not just another specialty. It is the front line of trust that gives to the society when it is most needed. The fact that Kamakshi Memorial Hospital supported emergency medicine, through their speeches we have been hearing how much importance emergency medicine has got at Kamakshi Memorial Hospital, is not just clinically. Academically, we look at Kamakshi Memorial Hospital for conducting our semi-examinations every year, year on year, with more transparency and vision. So this talks about their vision, and again, it takes leadership to invest in such an amount of departments in the hospital, where people have to work in chaos. That's what emergency medicine defines. And decisions has to be taken in minutes, and most of the time the stakes are very highest responsibility. The one decision that we take wrong in one shift will cause so much of a chaos across the hospital. One wrong decision in emergency department is felt across the hospital. So that leadership is very, very important. And you have been hearing about Dr. Sai. I have been associated with Dr. Sai Surinder for more than a decade now. And he is one leader in the emergency department at Kamakshi Memorial Hospital. That wrong decisions are minimized with his leadership and vision. And for more than a decade, he has been associated with Society for Emergency Medicine India, and he has been holding responsible national board positions. Right now, he is a national treasurer for Society for Emergency Medicine India. He is a person who does not wait for opportunities. He creates opportunities. Whether it is GAMET in 2014, that is Global Academic Emergency Medicine Meet, involving the national and international delegates. He did it for the first time in Pondicherry. And then when we were thinking about the CCTEM course, he has come up with an idea, why don't we create a rapid revision course for emergency medicine postgraduates? There is nothing before that. And he's the founder for SEMICON, which started in 2017, and we have been cherishing it. Apart from this, he always looks ahead of what is required. And that's one of his strengths was involvement in geriatric emergency medicine. He has been associated with the International Federation of Emergency Medicine India, Emergency Medicine, and is trying to bring a fellowship in geriatric emergency medicine in India. And I think Kamakshi hospitals will be the first to host fellowship in geriatric emergency medicine as well. So leaders like Dr. Sai Surinder are the pillars for Society for Emergency Medicine India, where we are building our systems, protocols, and foundations well ahead of time as well. Coming to Society for Emergency Medicine India, it is a 27-year-old largest organization of emergency physicians in India, founded in 1999 in Hyderabad. and we are built on 3 pillars. One is academics, research, and service. So this has been found when the concept of emergency medicine does not exist in the country. This is the first time people have come forward to build a society for emergency medicine in India and to bring a specialty into the country. For the first 25 years, we have struggled to build the departments, get recognition. The next 25 years, the present time we are ahead, is all going to be about systems, policies, and foundations, and global collaboration. So at present, we collaborate with multiple national and international organizations to integrate and work. Emergency department is not work for one department. We are the people who interact right from the security of the hospital to the CEO of the hospital, and everyone in between has to be, interacted with us. That's the specialty that we are in, and that's the reason why we collaborate with cardiology, neurology. Every society is collaborated with us to build a comprehensive specialty for emergency medicine in India. And the recent work we have done, we have collaborated with TNMGR University to build life support courses for both postgraduates and super specialty graduates of the university. Through 7 nodal centers, we have trained more than 3,500 postgraduates in Tamilnadu. And similarly, we are taking up the same project in West Bengal as well. And even other states we are working on, because life support courses are very, very important, and it will help us to know what is to be done at the right moment, and that defines whether the life or death for the patient. So that has to be an essential skill for every medical graduate, and that's what we have been taking. And we have recently conducted a space medicine conference, so we are thinking ahead, not just here, what happens in a space medicine. Very important, with lot of space events, spacecrafts that are being sent to space. The medicine behind it, the physiology behind it is important, and we being emergency physicians should be at the forefront. So recently we have conducted a space medicine conference as well. And coming to the fellowships, as I mentioned, geriatric emergency fellowship will be launched in ISEM 2026 in Germany, and Dr. Sai will be the one who will be hosting it and will be bringing to India as well. Apart from that, we are also coming across with fellowships in ECMO, fellowship in infectious diseases in emergency medicine. All these things are subspecialty development is our focus in the next 25 years as well. So with this, coming back to the same case, what we have seen, they don't know about our conferences, our academics or anything, but they will definitely know whether our systems will work or not. So for that systems to be working hard, we have to be with both. We have to be having good knowledge, good skill, what to do and what not to do, and we have to work with the wisdom to save every life that walks into our emergency medicine. So with this, all of the Society for Emergency Medicine India's concept is to give every patient a good right for emergency care across the country, whether they are in urban or rural as well. So our knowledge should spread across, and we should be able to save more lives. With this, the future is more about building the systems, not about reacting to the systems when there is an emergency. We have to be more prepared rather than reacting to the crisis, and that's where the emergency medicine should go forward. And with this, wish you all the best. Thank you.
Thank you, ma'am. We are honored to have with us Dr. Ram Mohan, President, Tamilnadu State Chapter, Society of Emergency Medicine India, whose contributions and guidance have inspired many in this field. I request Sir to speak a few words.
Good afternoon to one and all. I think we are nearing the lunch break, and I should really appreciate the Kamakshi leadership team with Govindaraj sir and Sai is being a great pillar for them, and he has done many things like what many speakers have spoken about emergency. I don't want to repeat the same. Yes, it's not a department, it has grown as an important role in the hospital of the verse and on the verse. Okay, with that, I wish Sai a great success on this conference and many more to go. Thank you.
Thank you so much, sir. KEMCON 2026 is proudly conducted by Dr. Kamakshi Memorial Hospital in association with Society for Emergency Medicine India and the IMA Palikarne branch, reflecting a strong collaboration towards advancing academic and clinical excellence. We shall now move to the IMA address. It's my pleasure to invite Dr. Hariharan, President, IMA Junior Doctors Network, a dynamic and energetic leader representing the voice of young doctors and actively contributing to the growth, learning, and future of the medical fraternity. Sir, please.
Good afternoon. Respected Govindarajan sir, I have great admirations for him. I think someone of his stature who now duty doctor, I think I have told this earlier as well. I worked in a hospital in Tambaram, but then in those days itself, to get an ABG done, we had to send samples to the Lakshmi Nursing Home. So, I mean, he thought ahead of times, he thought ahead of what was required by, in those days in Tambaram, those facilities were not there. So, thank you, sir, for being a great leader in and around our suburbs and creating this wonderful masterpiece of Kamakshi Memorial Hospital. Then Shivaranjani ma'am, I think the current changes that are happening are because of what she's infused into this. Greetings to you, ma'am, as well. My friend, Dr. Ram Mohan, Dr. Saujanya, and my brother Sai, I think great respects to you as well. So, as we go on through the day learning what emergency medicine is, I think it is very important for us to understand there are various aspects of the role as an emergency physician that we play every day. We need to learn academics because it's going to be an adrenaline rush. We have quick decisions to make. We have to stick to protocols. We may have deviations. We need to know how to identify what someone has in an emergency. We need to react accordingly because every action of ours, every decision of ours, a life matters. So I think that is there as an emergency physician. Along with that, I think we do need to inculcate in us the empathy. I think this, as doctors, it is very, very important for us to inculcate empathy in the way we look at our patients. Because, I mean, people in the most distressful situations come to you as patients, and that too to the emergency. So it is very important to have empathy towards the patient, towards the family, learn the communication skill. I think it is very, very important to learn to communicate to your co-workers, your staffs around you, to the family, to the patient, and to your administration. So I think as emergency medicine physicians, I think it's very important to learn how to communicate. And last but not the least, I think you need to have a legal filter to everything that you do. So learn to do it with that in mind. Learn all what is about medical law says what in the room, because we are in a very, very troubled situation. Challenging situation. I think the medicine is going through a very challenging situation where we have a lot of consumer cases coming, and I think in the emergency, I think we should not leave any loopholes. I think we need to document whatever we say. We need to communicate clearly and with empathy. I think that is very, very important. And it's a privilege to stand here in front of you as Chairman, Junior Doctor Network, and Secretary of IMA Tambaram. This is a century-old organization that caters to every need of every other doctor that is here. It helps your building up academics. There are a lot of academic programs, CMEs, your skill workshops that go on as the Junior Doctor Network does and IMA does as such. It also handholds you during the greatest trouble. So when you have litigations done, you have a scheme called PPLS that defends you, and the IMA is a team that defends you over there. Then we have a great scheme called where we support the family. That's called the Family Security Scheme. So this is one of the glorious schemes of IMA Tamilnadu. I think Raghavel sir, who's here, is one of the pioneers who started this scheme, and this scheme is to support a doctor family in the most difficult time. Can anyone say where is the most difficult time for a family of doctors? It's when a death happens, right? So when you are no more, the first few days is where the family searches for help, and the biggest help that someone can have is having money at that time to settle whatever has happened over there. So IMA has created this glorious scheme of family security scheme that can help every doctor, and I think every doctor should join the Indian Medical Association. We have a membership drive going on right now. It's going to start on April 1st. Please join this glorious organization. Let us stand together, work together, and create a great community for us together. Thank you so much for the opportunity.
Thank you so much, sir. And now, we come to someone who truly needs no introduction, the driving force behind SEMI for the past 14 years, and KEMCON, the brain and strength behind all these efforts. It's my honor to invite Professor Dr. Sai Surendra sir, Head of Department of Emergency Medicine, Dr.Kamakshi Memorial Hospital, and National Treasurer, Society for Emergency Medicine, India.
So I'm here, I have an interesting little poem in Tamil. So because since I came here, many legends like, I should mention Leo sir, RKR sir, who has inspired us all to speak in Tamil. Because basically my second language is Hindi and French. I didn't have the privilege of studying Tamil but after seeing Leo sir and other Tamil laureates, I'm very sure that there is no other language in the world can beautify any concept or thing than Tamil. Hope you all will agree. So, என்னால முடிஞ்சது ஒரு கவிதை எழுதியிருக்கேன் சார். KEMCON உயிர்களின் காவியம். அவசர சிகிச்சையின் அந்த நொடியில் அதிரும் உயிரின் சத்தத்தில் அந்த மெல்லிய மூச்சை மீண்டும் இசையாக்கும் கைகள் நாங்கள். இதயம் நின்றாலும் நம்பிக்கை நின்றதில்லை. இருள் சூழ்ந்தாலும் உயிர் அணையவில்லை. ஒரு ஒளி போல் ஓடி வரும் அவசர சிகிச்சையின் வீரர்கள் நாங்கள். KEMCON என்றாலே கல்வியின் தீபம், சேவையின் சின்னம். ஒவ்வொரு ஆண்டும் உயரம் தொட்ட காமாட்சி மருத்துவமனையின் பெருமை குரல். ஆர்டிபிஷியல் இன்டெலிஜென்ஸ் இணைந்து மருத்துவம் புதிய பாதை சென்றது. ரோபோட்டிக் சர்ஜரி கையில் கொண்டு அசாத்தியத்தை சாத்தியமாக்கியது. சமூகத்தின் நலனுக்காக முகாம்கள் நடத்தினோம் பல. ஒவ்வொரு உயிருக்கும் ஒளி தர இன்று 4வது ஆண்டு நம் எழுதிய வரலாறு பேசுகிறது. எங்கள் கனவின் சாட்சியாக நிற்கிறது KEMCON. உயிர் காக்கும் உறுதி எங்கள் வழி, சேவை செய்வதே எங்கள் மொழி. KEMCON 2026 என்றும் பெருமையுடன். So I'm here to present this vote of thanks. First of all, thanks to all the dignitaries on the stage. First, our chairman, Professor Govindarajan sir. He has been a very, very big example and epitome of support. Whatever emergency has asked ma'am and sir, they have never said no. Thank you, ma'am. Thank you, sir, for always encouraging us and supporting us. There are very few chairmen who support emergency medicine. I'm lucky to have one of them. with us. Thanks to our semi-national president, Dr. Saujanya. She's like a sister to me. We both grew together in semi, and I'm happy to see her as doing wonderful job as a semi-national president. And next is semi-Tamilnadu president, Dr. Ram Mohan. Sir and myself also work together in global hospitals. We conducted a conference like this called Gamma 2014. Thank you, sir, for that day he has given me that opportunity. Today I am here. Thank you, sir. And thanks to our professor of head of academics, Radhakrishnan sir, without whom this KEMCON will be a dream. And thanks to our chairman sir, TGS madam, Leo sir, our VP, Ramya madam, staffs and doctors of all branches, my own ER team who are all here from Siriseri, main Pallikarnai, Siriseri, all consultants. Dr. Ram Kumar, are you here? Yes, Dr. Ram Kumar, please give him a big applause. Dr. Sita Raman. See, from the first year, what I have been doing, these people have replicated it now. They have had sleepless nights. Every member of the ER team has worked. From Ram Kumar, Sita Raman, Feroz, can you please get up? Dr. Roop Charan. Dr. Roop Charan, yes. Dr. Roop Charan. And other, our Mano brother, Nitya sister and team. And my dearest PGs, Aravind, Joe, Bhumika, Niveta. Can you all please stand up, please? I don't think there is a better platform to congratulate all the hard work behind this. Because I am just a face. The work and hard work of them is what all you see. Definitely it is not alone my only job or my only work. So please congratulate them. And Monisha PRO, ambulance teams. And I would like to thank our sponsors, G Square, AU Small Finance Bank, Fresenius Kabi, Pfizer, Laptop, Sun Pharma and BD Company. And all who are responsible. Pardon me if I have forgotten anyone. Thank you one and all. Thank you once again.
Thank you so much, sir. Now, as a token of our heartfelt gratitude and appreciation, we now move on to the presentation of mementos. The memento we present today is an iconic Mahabalipuram sculpture inspired by the exquisite artistry of the Pallava dynasty, renowned for its intricate stone architectural brilliance. The sculpture symbolizes the strength, heritage, and enduring excellence, values that resonates with the spirit of Dr.Kamakshi Memorial Hospital and this conference, KEMCON 2026, and the contributions of our esteemed dignitaries. We now proceed with the... May I request Dr. T.G. Govindarajan sir to please kindly present the memento to Dr. Saujanya Patibandla ma'am. Next, I invite Dr. T.G. Shivaranjani ma'am to kindly present the memento to Dr. Hariharan sir. And ma'am, to please kindly present the memento to Ram Mohan sir. And I request Dr. Sai Surinder sir to kindly present the memento to Govindarajan sir. And I request Dr. Ram Kumar sir to kindly present the memento to Dr. Shivaranjani ma'am. So as we come to the end of this inaugural session, I take this opportunity to express our sincere gratitude to all our esteemed dignitaries for gracing this occasion and sharing their valuable insights. Now we'll move to national anthem.
अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We'll break for lunch. No, we'll break.
Now we'll move on to our scientific sessions. All of you please be seated.
and when to order. What's the most appropriate investigation and how to save time and how to arrive at the diagnosis at the earliest possible, because time does matter in the ER. And then how to read, right? Even though the majority of the reading is done by the radiologist and you convey with the radiology resident or the consultant on duty, but I think you should have a fair, good knowledge of what to interpret the most critical findings by the bed, which is by the bedside, which is either done by you or in which you are able to understand and communicate with the radiologist and the patient. And finally, I just add some caveats where there are some false positives or some false negatives which you should look for in the ER. So table of contents, I'm just highlight within 20 minutes the most common cases in the system-wise fashion, right? So coming to CNS, the trauma. See, trauma is the most common thing you guys will encounter. And in trauma, you have these fractures and hemorrhages. So fractures, as we all know, is it easy to interpret in CT than X-ray. So CT is always better. But just one thing, take a look at this. When you see the CT images in PACS, never ever judge to fractures, especially in pediatric patients, right? See, on the left, you can see this looks like a fracture, but actually it's not a fracture. It is an accessory parietal suture. You can see it comes here, ends up at the right side of the lambdoid suture. And here you can see this is definitely a fracture which crosses the free suture and extends all the way into the occipital bone from the right parietal bone. And again, here you can see this is a suture, the small arrows are sutures, and this is a fracture. So how do you differentiate? So you can see at the 3D reconstruction image above that, the fracture is just like a sharp cut, how you draw with a pencil or you cut with a knife, right? Whereas you just look at the suture here, see it has that zigzag ragged margins with interdigitations, and always the advantage of CT is that you always have an adjacent structure to compare, right? So always just compare your whatever fracture or suture line, especially in pediatric cases, see to the adjacent suture line. So because I know we face, you call the patient, you tell them, yeah, there is a fracture. Yeah, see for them it's a grievous injury, right? Then again, you go back, talk to the radiologist, and the radiologist comes back, no, there is no fracture. Then you are the one who will be facing the heat when you convey the, even though it's undisplaced fracture which doesn't have any neurosurgical emergency, but when you are conveying the patient that there is a fracture and there is not a fracture, that means really a lot to the patient. And coming to, non-traumatic hemorrhages, again CT is better, and again for stroke, MRI is always better than CT, as you all know. So hemorrhage, so what is the term we use? It's about extraaxial and intraaxial. So what is extraaxial? It's SDH, ADH, and SAH, you know the expansions. And intraaxial, it's the parenchymal hemorrhage and contusions. And finally, what you have to look for, what the neurosurgeon expects they will always ask you, is there really any mass effect, or is there really any transtentorial herniation, whether it could be central or lateral. So it's very simple. You can see the lemon on one side and the banana on the other side. So this is the EDH. The lemon is the EDH and the banana is the subdural. So it's a biconvex. EDH is a biconvex figure. So why? Because the EDH is outside the dura, right? So the hemorrhage is limited by the sutures, where there are the dural attachments. So dural attachments and the sutures, they limit the spread of. So always it's a good habit. I think you know aware about the two windows, right? The brain window and the bone window to look for the fracture. So always trace the sutures. And one important tip, the EDH is otherwise called as fracture hematoma, right? Almost always, say for example, more than 95% of the EDH, they are almost always associated with the fracture. So even though there will be some discrepancies, there are some exceptions, but if you have a fracture and if you are in doubt whether it could be EDH or SDH, always go for EDH. And still, if you have doubt, always call a radiologist. So it's a fracture hematoma, and this is a concavo-convex hemorrhage, right? Because it is occurring below the dura. So right, so there are no limitations by the dural attachments to the sutures. So it just spreads across the sutures. So SDH, take home point, crosses the sutures, right? And EDH does not cross the sutures. And EDH is also called as fracture hematoma, which almost always, almost more than 90%, even 100% associated with an overlying calcareal fracture, right? So quickly, so epidural hemorrhage above the dura, below the dura, and subarachnoid hemorrhage occurs within the subdura. And subarachnoid hemorrhage, obviously you can see, right, it just extends into the sulcal spaces, right? There are some instances where the initial radiology resident will be telling there is an ADH, thin SDH along the interhemispheric fissure, but when the consultant comes and no, it's not SDH, it is subarachnoid hemorrhage, right? So it's all about how you look at. See, you can see the subdural hemorrhage never extends into the sulcal spaces. That is the subarachnoid spaces. Whereas here you can see it clearly extends into the sulcal spaces, right? So always look for 4. Whenever there is a huge SDH or EDH or extensive subarachnoid hemorrhage or even some large parenchymal hemorrhages or contusions, always look at these 4 points, right? Because what the mind doesn't know, the eyes doesn't see. Say, always look for the subfalcine herniation, the central herniation, uncal herniation, and the tonsillar herniation. So these are just 2 typical examples. You can see here is a coronal CT. You can see the fats. You can see here it's curved. This is a subfalcine herniation, right? And this mass effect, all you know. And always better look at the 3D images in your back screen. You can see this is a cerebellar image. This is the upper margin, and this is the lower margin. You can see this is the foramen magnum, right? This is the clivus. You can see the margin, and this is the margin foramen magnum. You can see this tonsillar peg is seen descending into the uppermost cervical canal. And always look for uncal herniation. This is the tentorium, right? Left side left leaf, right side leaf. So always look for herniations. This is a tentorial herniation. See, you can just like everted lip, right? It's just protruding across the tentorial leaf. So always look for what is, because what the mind doesn't know, the eyes doesn't see. So subarachnoid hemorrhage, non-traumatic, most common cause is going to be aneurysmal bleed. And parenchymal, it's going to be either hypertension, underlying bleeding disorders or tendency, and amyloid. So aneurysmal bleed, can you suspect aneurysmal bleed in just a plain CT? Sometimes, yeah, you can. If it's completely atraumatic, the history is clear, and you see here, this is a subarachnoid hemorrhage, right? Yeah, it is seen in the basal systems here, but you can see what we call the sentinel clot here. The majority of the subarachnoid hemorrhage is pooled around the right sylvian fissure, right? Seen in the both axial and the coronal section. So this non-traumatic hemorrhage could possibly be due to a aneurysmal rupture, especially in the right sylvian fissure region, possibly from the right MCA. So it's just and this is a typical hypertensive hemorrhage in the thalamo-capsuloganglionic region with intraventricular extension. So always look for intraventricular extension. Stroke, so what to order? Always go for MRI, right? Because nowadays, unless the patient is very uncooperative or has absolute contraindications, like cardiac pacemaker, which cannot be seasoned by, but even with pacemakers, we can do MRI nowadays. But in some aneurysm clips, always go for MRI, because with ultra-fast MRI systems and stroke protocol, we can do the scans in less than 5 minutes. So what are the sequences we do? We just do 3 sequences, which is enough for all the neuro intervention, right? We do a diffusion combined with flare and a gradient. So we look for diffusion flare mismatch, and the GRE is nothing but a gradient sequence to rule out hemorrhagic transformation or a primary parenchymal hemorrhage. So this is an example where you can see the diffusion, and this is called the ADZ map. So you can see it's clearly, so there is an infarct, right? Fine. But when you see at the flare images, you can see it's highly disproportionate, right? But whereas you can compare from the left and right side of the cerebral hemisphere, yeah, there is some effacement. I agree with that. But still, it's clearly disproportionate to the extent of the abnormality seen in the diffusion image. So this is what we call diffusion flare mismatch. And this is one of the most important criteria used by the neurologist to decide the type of management, whether they have to actively intervene, they will go for thrombolysis or not. And again, trauma for face and neck, CT is the modality of choice. Yeah, sometimes for blowout fractures, it can be visible in X-rays. Fine, you can see this arrow mark here, a small blowout, a bulbous density protruding into the right maxillary sinus. But always, whenever possible, please go for a CT neck or CT facial skeleton, right? Because even small fractures can be missed in the X-rays. And one more, we can clearly assess what's the content of the blowout fracture. And most important, if there is a clinical-radiological disparity, you can see whether the inferior rectus is really entrapped or not, which is very important for the facial-maxillary surgery, right? So spine, so fracture, whenever you suspect a high-velocity trauma, you suspect a spinal fracture, there is literally no point in going for an X-ray, right? Whenever a CT is available, please go for CT. Why? Because the CT clearly demarcates the spinal injuries into stable and unstable injuries, which is very important for the spine surgeons, because the management is completely different for stable and unstable emergencies, unstable fractures. And you can go to MRI when there is a clinically there is a neuro deficit. So spine injury with a neuro deficit, okay, definitely you have to go for MRI, because you have to look for cord laceration, contusion, or hematoma. Or clinically there is no signs of cord injury, you go for a CT, you see a fracture. That fracture is seen encroaching into the spinal canal, or it is seen indenting the cord. Then definitely you have to assess the extent of cord damage with MR. So this is how you decide on whether what investigation to go based on this thing. So this is an unstable fracture, right? The type 2 orontoid fracture is definitely an unstable fracture, which is very difficult sometimes in the ER room with the bedside X-rays to clearly demonstrate with such details. And on the right, you can see there is a cord injury. You can see that arrow, that's a cord hematoma, right? Axial images. So whenever there is clinical history of neuro deficit, examination neuro deficit, always go for MRI. See, there is no significant dislocation or fracture here in the vertebra, but still you can see an extensive cord hematoma here. So you have a neuro deficit, go for MR. You don't have a neuro deficit, you have an unstable fracture or fracture indenting into the spinal canal, please go for an MR. So chest trauma, okay, X-ray is fine, it's the first line, but always go for CT if it warrants. So what are you going to see? Are the flail chest, the pneumohemothorax, pneumomediastinum, contusion, and diaphragm rupture. So always look for flail. So there are multiple lip fractures. So first report will be multiple rib fractures, but always do look for a flail chest, right? When there are multiple rib fractures, always ask your radiology resident or the consultant, sir, is there any flail chest? Suppose even if you have a clinical suspicion, because you know flail chest, more than 3 rib fractures at 2 consecutive points in the same ribs, you can have an unstable segment, right? So multiple rib fractures, just ask a question, right? Is there a flail chest, right? And this 3D recon is very easy. You don't need a radiologist to read it, right? It's very clear. And this is the most thing I just want to stress, especially subtle pneumothorax, right? Where you don't have the radiologist all the time by the side. Either you or the anesthetist will be the one seeing the X-rays. And this is a case in which the patient, the X-rays are taken as a part of pre-op investigation. For example, if the patient is going for fracture of femur or whatever, she's going for nailing or some kind of other orthopedic procedures, just a routine evaluation. And just a quick inspection, you can see it's completely normal, right? Fine, but always, whenever in polytrauma cases, even though you don't have chest fractures or whatever it is, when the patient is especially going in for preoperative assessment, right, always zoom in for the apex, right? Why? Because small pneumothorax, see, you can see this is a lung line, right? This is a lung line, this is the chest wall, and you can see this lucent area. How do you tell it's a lung or not? Lung, you have these vascular markings. Whereas this lucent area, you don't have vascular markings, it's just air. Because why I'm stressing so much on simple chest X-ray? Because this patient, for example, comes with a femoral fracture, and you see the X-ray, and sometimes even the anesthetist missed the small pneumothorax, he goes for the OT. Then once you give GA, right, this positive pressure ventilation, this nitrous oxide, and it's going to be a hell, because the pneumothorax is going to aggravate, and you're going to lose the patient on the table. So always, whatever it is, in erect chest X-ray, trauma patient, you inculcate this in a habit, right? So a polytrauma case, pre-op evaluation chest X-ray, the orthopedician anesthetist, they are ready. Please take a second look at the hidden area, lung apex. Just rule out that there's no small pneumothorax, which will complicate the general anesthesia. And this is very obvious. You can't miss. You can see the tension pneumothorax. You just have to look at the signs. Trachea to the right, right cardiac bottle to the right. I can see this left hemidiaphragm. You can compare to the right, it's completely fattened, and this collapsed lung pushed. So this is a case of that's not just pneumothorax, it's a tension pneumothorax. Please call your thoracic surgeon for an urgent ICD. And pneumomediastinum, yeah, it's very easy to pick it up. In CT, you can see this air density, right? Similar to the atmospheric air outside the chest. Yeah. See, outlining the aorta, whatever, but always in chest. Look, not only at the apex, look at the mediastinal contour also. So you can see these linear streaks of hypodensities, right? I mean, lucent areas. These are all mediastinal air, and you can track it around the cardiac bottom. So always look for lucencies in a case of trauma, even though there is no direct history. And contusion is very obvious on the X-ray. You can see it's okay. If you have trauma, it's going to be a contusion. But there are some instances where whether it could be aspiration pneumonitis or contusion or pulmonary edema. Please don't be shy to ask for a CT, because most of the cases CT we could be able to differentiate between a pulmonary edema, a contusion, or aspiration pneumonitis. And rarely blunt trauma with no obvious external signs of fracture. You could see just bulbous density here protruding out. This could be a diaphragmatic rupture. And again, please don't be shy to ask for a CT. And foreign body, which is one you commonly encounter, especially in choking or acutely dyspneic children. Always ask for two views, right? The two views is to exactly locate where is the, so the frontal X-ray knows the horizontal level of the foreign body, and the lateral projection shows you whether it's in the anterior aspect of the chest or in the posterior aspect of the chest. But still, if you have doubts, for example, large foreign bodies like coins, yeah, they'll be easily seen in X-ray. You don't need a CT at all. But for example, very common, small fish bone, after small chicken bone, but the patient clearly tells after ingesting the fish, I got a trickling sensation in throat, but you are not able to see in X-ray, then you ask for CT. So on the left, you have the ingested foreign body. The upper one is located at the level of cricopharynx, and the below it's located at the level of thoracic esophagus. See how beautifully. So this is a horizontal level in AP projection, and in the lateral you can see it's just anterior to the spine where the esophagus will be. And again on the right, it could be even aspirated. You can see this clip. See, it is in the right bronchus, right here, along the orientation of the bronchus. So once you rule out myocardial infarction with your enzymes and ECG or whatever clinical guidelines, so still the patient has acute pain, tearing pain or dyspnea, go for a CT chest, and if possible always with an angio. Why? Because for edema, X-ray, yeah, is really the first choice. Most of the time for acute pulmonary edema, you don't need a CT, but in CT also you can see a bat wing appearance. So this is called a bat wing appearance, right? Where you have the central opacity and you can see the peripheries of the lungs are preserved. This is called a bat wing appearance, and this is a replica seen in the CT coronal sections. So pulmonary embolism, yeah, obviously you know CTPA, CT pulmonary angiogram is the modality of choice. Always look for, this is the main front, right, left and right branch. You can see this is called the saddle embolus, right? And always, it may not be the only saddle embolus. Also, you have to ask for whether there are thrombus seen in the periphery. So always when there is a suspicion of pulmonary embolism, please ask for CT pulmonary angiogram. And these cases of pericardial tamponade, right? Most of the times in the bedside you do a fast, right? You could easily pick up the effusion, pericardial effusion. Or sometimes he comes for a CT for other cases. You could see this is a large pericardial tamponade compressing the heart. And you can even see the contrast reflexing into the IVC, which is a sign of significant compression of the pericardial fluid. And rarely, sometimes, please always, it need not be only fluid or blood, it could be air also. See, this is a case of pneumopericardium, right? This is a pericardium, you can see this thin line. You can also get a pneumopericardium. So always look for the lines in X-rays. Look for the lines which are standing out apart. And aortic dissection, you can see it's very easy to pick it up. See, what's the advantage of CT angio? See, this is the entry point, right? This is a dissection flap. So it's from the true lumen, the contrast enters into the false lumen, and you can trace as far as distally and proximally also, even into the aortic branches here, and you can clearly see the extent and type the aortic dissection. And always look for contrast within the vessel and outside the vessel. Whenever you see a contrast CT, always have the habit of looking the contrast, because normally injected contrast should be within the blood vessels, right? Limits of. So whenever you see this, you know it's very simple. It's a very big aortic aneurysm. But see, the contrast is seen puddling up here, outside the margin of the aortic wall. So this is a ruptured or leaking aortic aneurysm. This is a large hematoma around it, and it's even seen entering into the pleural space. So always in contrast CT, please look for contrast outside the lumen, which is a very grave sign. You can even see the defect here, right? So peripheral vascular, so it could be either ischemia or a DVT. So Doppler is the first modality of that. Most of the times you will be able to pick it up in Doppler, except in some very obese cases or with cases with morbid edema, and that limitation will be informed to you by the radiologist. So here you can see the occlusion with the color Doppler beautifully. where there's an abrupt cutoff, there is no color flow here, right? And this is a Doppler, and this is a grayscale. See, this is the normal vessel, which is clear, black. We call it as anechoic. And you can see the thrombus here, it's some gray echoes within the lumen. This is a hypoechoic. So this is normal, and this is thrombus. This is the corresponding CT angiogram vessel. And sometimes if you don't have Doppler machine, please don't be shy, because compression, there's a test called compression, you know that. Compression USG is equally good as Doppler, or sometimes even better than Doppler. Why? Because, see, this is a normal patient, right? This is the normal vein, femoral vein, before compression, see after compression. So normal vein collapses with the pro-pressure compression, right? And sometimes it's very obvious, see, you can see a clot within the femoral vein. So you don't need a compression or a Doppler or whatever. It just stares at you, the diagnosis. But there are some times where, see, this is the popliteal vein. See, I told it's quite dark, right? There is no echoes like thrombus here. It's quite dark. So you just can't brush it off. See, just do a compression on the bedside. See, this popliteal vein looks normal, but see, with compression, no, it's not compressing, which means something is filling in the lumens. Because acute thrombus, you may miss with routine grayscale or even with Doppler. So always do a simple compression test at every inch of the vessel. You will be able to make out most of the deep vein thrombosis on your bedside. So abdomen, you know, the first line of imaging will be ultrasound in trauma, but if there is pneumo or hemoperitoneum or strong organ injury suspicion, you are going to look at it. So in fast, yeah, you could have an ascites. So how would you tell it's an hemoperitoneum? So a traumatic patient comes to you, we do a fast, there's a moderate ascites, but if the ascites is not clear, you can see here, ascites not, see, it's turbid, right? So this is blood. See, what all looks turbid in ultrasound? In clear ascites, it will be just dark, pitch black. But whereas it appears something like this, you get appearance only in 3. It should be particular. So it should be either blood or pus, or it should be cellular ascites, like malignant ascites, right? Anyway, acute trauma, you are not going to see malignant ascites. Or so either you are going to deal with either pyoperitoneum or hemoperitoneum. That easily your clinical examination will lead to you. So always look for turbid echogenic ascites. It's going to be either pus or blood or particulate ascites. And in acute situation, it's going to be just hemoperitoneum. Please order for a CT. So what happens in CT? You can see this all these dark areas are liver lacerations, spleen lacerations, and always look for the perfusion. Why? Because it's a normal perfused left kidney, and you can see there is no enhancement at all. There is no contrast. So there is no blood entering the right kidney. So obviously it should be either a type 4 or class 4 or class 5 AST injury, right? With or without this thing. So always look for this grave signs and ask your radiologist for these signs, which you need to act immediately. And bladder rupture, it could be either extraperitoneal or intraperitoneal. CT cystogram, yes, is the modality of choice, but it's okay. Even X-ray cystogram can have your diagnosis. And here you can see this is the extraperitoneal rupture. See, this is the peritoneal cavity. There is no contrast entering from the bladder. It is seen in the pre and paravascular space, and this is called the molar tooth sign, right? This is a tooth, and this is the molar tooth sign. This is typically you get it in extraperitoneal rupture, and this is a typical intraperitoneal rupture. So once the bladder, you can see this contrast is seen outlining the peritoneal lining and the bowel loops. So it's clearly easily differentiates between intra and extraperitoneal. And abdomen non-traumatic emergencies. How long do you have? 5 minutes. So all these things, I think most of the times the ultrasound will pick it up. I think this most of the job is done by the radiologist. Just I want to stress one practical point. Sometimes you will be irritated by the radiologist, right? You write an ultrasound abdomen, the radiologist sees ultrasound. There is hydronephrosis, ureter obscured by bowel gas, there is no suggested CT. Okay. Then again, you suspect pancreatitis, typical alcoholic guy comes with upper abdomen pain, recent bout of binge of alcohol. Radiologist tells all the other organs are normal, pancreas is obscured by bowel gas, you get irritated, right? I understand. But okay, but what happens? But in the normal mass child checkup, routine cases, you never see a case, never see a report which tells that pancreas is obscured or ureter is obscured. Why? Because actually it's a true concern. Why? Because you have ileus, right? There's an entity called focal ileus. Even whatever it is, be it appendicitis, be it cholecystitis, be it pancreatitis, or even a urinary colic. What happens whenever there is focal, paralytic ileus is what we get it in a surgical abdomen, right? So the entire bowel just bloats up with gas. But what, there is an entity called focal ileus. So what happens when there is a particular area of inflammation, say for example, if it is pancreatitis, right? So what happens because of the focal inflammation, so what is the bowel adjacent to it? We have this transverse colon loop going on, right? It just bloats up with air. Because of the focal inflammation, the bowel stunts, but not the rest of the organs. And again, if there is a uretary calculus, what happens? The bowel loops in that area, it stunts and distance with air. So it's a very common issue that you may get irritated with the radiologist response to go for a CT abdomen, but that's understandable. So whenever the radiologist is not able to pick it up, but there's a strong clinical suspicion, please go for CT, right? So these are just an examples. So this is the most practical point I just want to stress you, but what happens really in the emergency room, right? So appendicitis, again, if there is focal ileus, the most RIF, probe tenderness present. Please correlate clinically and CT, okay, right? Fine. Whenever they write, please correlate clinically, but there is clinical rebound tenderness, please go for CT, right? And this is appendicitis. You can see the appendicolith, and our CT obviously beautifully shows up the appendix with the appendicoliths. And cholecystitis, you don't really have that problem, right? Because it is guarded by the liver. So you always have the liver as a window, so you never have this problem with cholecystitis. But still, you have to ask for a CT. For example, if in case of gangrenous cholecystitis and suspected emphysematous cholecystitis. What happens sometimes, gas is the worst enemy of ultrasound. If there is gas like this, actually in ultrasound we cannot see anything. The bowel, gas, everything looks the same. So clinical suspicion of cholecystitis, the radiologist not able to see the gallbladder, please order for a CT, right? Because emphysematous cholecystitis and gangrenous cholecystitis, because what happens in gangrene, you don't see perfusion in ultrasound, right? Not with Doppler, there is limited assessment of perfusion. So always go for a contrast CT. So if the wall enhances, yes, the wall is viable. Or if not, then the wall is going for gangrene. And for pancreatitis is a corresponding picture. Sometimes, see, this is a normal pancreas. Just quick, when you do a quick fast, see, this is a normal pancreas. You don't have any fluid sleeves anterior and posterior to the pancreas, right? This is a case of pancreatitis. See, this is a normal pancreas. You can see this is swollen. This is more bright compared to the normal one. And you can see a thin fluids right here, right? This dark line is a fluid sleeve, both anterior and posterior to the pancreas. This is a corresponding CT image. So what happens? Always look for the size of the pancreas and look for sleeves around the pancreas first. And obviously calculus, as I mentioned you, so you go for a CT when the ureter is not traceable. Please don't be shy, and please don't blame the radiologist always, right? And this is a case of pyelonephritis. Just do a quick fast. It's difficult to pick in ultrasound, but when it's so obvious, see, whenever you have two paired structures, always go for comparison. That's very easy, right? See, you see the right kidney, put a split screen, look at the left kidney. See, it's so obvious. This is a normal kidney, this is a left kidney. And obviously, CT is going to pick it up. This is a normal kidney, and you can see this all dark, enlarged kidney with dark areas. So always, when you're looking at the paired organs, please go for a comparison. And it's an intestinal obstruction, again, X-ray. If it is gas filled, go for air fluid levels. And it's fluid filled, go for ultrasound. And the problems are, as a rule of thumb, have this 3-6-9 rule, right? This is a dimension for 3 centimeter, an arbitrary cutoff to assess obstruction. 3 centimeter for small bowel, 6 centimeter for large bowel, and 9 centimeter for cecum. But this is not applicable in all the cases, but most of the cases, right, in ER. And again, for pneumoperitoneum, X-ray chest, it's not X-ray abdomen. Please have it in mind. For pneumoperitoneum, you have to order X-ray chest and erect view. Right? Even the patient's X-ray chest, it's not X-ray abdomen, and it's not a supine or a cross table view or nothing. In X-ray chest, erect view, because of the tangential beam of the X-ray. This is the physics, strikes over the subphrenic area where the chance of visualization, you can see in abdomen also, but the chance of visualization of small pneumoperitoneum is more with chest X-ray, erect view. But you may go for CT in case sometimes, but not always. It could pick up the site of perforation. This is a case of duodenal perforation. You can see here, right? This is the air, marked areas. This is the air. This is the air. You can see this is the site of defect of duodenal perforation, but not always you'll be able to see, but most 50% of the times you'll be able to pick up the. And there is one area where you don't need CT, you don't need MR, and actually which doesn't have any advantage. Male urogenital emergency is very simple. You just have to ask the ultrasound of the scrotum. unless it is something related to your lower abdomen or water. So testicular trauma, torsion, or orchitis, just go for ultrasound. Ultrasound is the best and only modality for trauma. You can see this hematoma, can easily see the laceration and the blood oozing into the tunical cavity with the hemorrhage, right? And again for torsion, you can see, always compare. It's very easy. See, it's the left testicle, normal size. See, it's enlarged. See, it's smooth, grainy appearance. See, this is very heterogeneous, angry looking. And with color Doppler, you may not be able to see adequate vascular. See, sorry. And this is the torsion. This is the torsion knot. You can see this like a knot. So it's very easy. Put the Doppler, you can see the vessels circling around, right, at the root of scrotum. And with orchitis, it's going to be the exact opposite, right? Because of inflammation, you are going to have increased vascularity. So this is a normal testis, and this is going to be an abnormal testis, orchitis. Because whenever there is inflammation, you can see the red and blue dots sparkling more here when compared to the upper slide, right? So always ask for a ultrasound scrotum with Doppler in testicular emergencies. And female pelvic, again, ovarian torsion. This is what the more, again, always compare. See, just take a look. This is a normal ovary, right? Normal ovary, enlarged abnormal ovary. You could see vascularity, right? Vascularity is preserved within the ovary. But whereas here, you could, even with color Doppler, there is no flow inside. You can see flow outside the ovary, but it's not inside. And again, you can see this pedicle, right? The starched pedicle, this rounded structure. And in case, again, if the radiologist is not able to pick it up, ask for a transvaginal scan, right? Most of the times, ovarian torsion can be picked up with either TAS or TVS, but there are some times where the patient is not willing for a transvaginal scan, or is an unmarried virgin patient, where you have all those ethical issues. Go for an MR. MR is very clearly, you'll be able to see the enlarged ovary. It's a normal ovary. You can see the stroma, right, looking bright and white. It's an edematous stroma. And rupture ectopic, obviously we'll be having, just go for or fetal cord. Most of the time, what you will see, the positive UPD, but when you are able to see a large jelly-like hematoma like this in the pelvis, is always going to be a rupture ectopic pregnancy. So always ask for an ultrasound with TVS, right? And finally, placental abruption. So what happens is very easy in ultrasound. So this is the uterine contour, right? This is the uterus one. This is the placenta. So what happens? This is the posterior margin of placenta, anteriorly and filled with a large retroplacental hematoma. Again, this is the fetal head, placental margin, uterine margin. I can see a beautiful clot sitting right behind the placenta. So finally, my last two slides. So common pediatric emergencies, what I'm going to see is interception and outside, bowel loop inside, and the trapped mesentery. And this is a cut section view, this is a long axis view. You could see the bowel outside and this loop herniating inside. And finally, this is a midgut volvulus, sometimes recurrent abdomen pain, ultrasounds being normal. Always in pediatric cases, you ask your radiologist to look for SMA, SMV axis. That's what. In pediatric recurrent abdomen pain cases, just take this point home. Recurrent abdomen cases, abdomen pain, appendix normal, no calculus, nothing, no ascites, nothing. Always ask your radiologist for SMA, SMV axis. Why? Because even up to adults, this malrotation goes unrecognized, and sometimes it presents with acute midgut volvulus, and especially in infants when it is bloated with gas. You can go for upper GI barium series. You can see stomach, duodenum. So where is the normal DJ flexure? It will be to the left of the spine, right? The DJ flexure normally comes here, and there here comes the jejunum. So what happens in malrotation? This is the duodenum. The DJ flexure is to the right of the spine, and you can see this corkscrew pattern, right? So the jejunum is seen in the right side of the abdomen with the twisted axis. So take home message, just know what and when to order, and don't be shy to ask your radiologist what you really want to know. Thank you.
Thank you so much, sir, for the wonderful talk. Now, let me welcome Dr. Ram Kumar, sir, to felicitate Dr. Vijay Karthikeyan, sir. Lunch break now. after 20 minutes.
No.
and at the right price. This is a broad take through onto the brand, how we started and how it has been going up and evolving. As said, 2012, we had aggregated land for JK Tires for almost 112 acres, and it moved to India Bulls for 70 acres, and it moved to TVS Emerald. The journey had been like kept on moving, and we kept moving ourselves, and we kept growing ourselves. And we like as a Chennai brand, we started to expand in Coimbatore by 2020, and by 2021, MS Dhoni had been signed as a brand ambassador. And in 2022, we expanded our market into Hyderabad and also in Karnataka. By 2023, almost 50 million square feet has been delivered, and we have 10,000 plus happy customers. And by 2024, we have delivered almost 4,000 plus acres. And right now, we have 15,000 plus happy customers, and the journey is moving on. See, this is a small point of being like from land aggregation, we jumped ourselves to get a complete real estate brand. How it has been happened. See, post COVID, it's been found there was an increase in demand for individual houses in the market.
pediatrician to deliver a speech as Tiny Hearts, Big Challenges, Pediatric and Neonatal Code Blue. We welcome you, ma'am.
இது பாயிண்ட் ஆன் இல்ல இது பாயிண்ட் அப்புறம் இதுக்கு இது ஸ்லைட் சேஞ்ச் மட்டும் இதுவா இது பாயிண்டரா Good afternoon, one and all. Hopefully this is the post-lunch first scientific session. Hopefully I'm not very boring. So I am Dr. Prahada. I'm Senior Consultant Pediatrician in Dr.Kamakshi Memorial Hospitals. And today the topic given to me was Pediatric and Neonatal Code Blue. It is named as Tiny Hearts, Big Challenges. So let's go dive into the topic. So the overview of today's topic will be what are the key clinical differences between adult code and a pediatric code, and 2025 PALS update, AHA update, the pediatric code blue, the neonatal resuscitation, and the conclusion. So coming to the key clinical differences or challenges which are very specific for pediatrics is, first, it's a respiratory first approach. Unlike adults, where most of the causes of the cardiorespiratory arrest is due to cardiac causes. So ours is mostly a respiratory first approach. So early ventilation, good ventilation strategies, and early airway management really helps. Second, the physiological vulnerability of children. Like they have higher metabolic rates, their higher oxygen consumption, but they have very low functional residual capacity. So again, good ventilation, early airway management, good ventilation strategies work. Third is children's medication or epinephrine or atropine or anything which you use during a code, and the defibrillator dose is weight-based. Weight-based precision, that's how I've named it, because it's very, very difficult to maintain it because of the high stress event during a code. So there is increased chance of risk of error during a resuscitation. Then obviously anatomical differences, they have larger tongues, they have shorter necks, they have narrower airways, so their intubation is technically difficult. And very specific to neonatal code, neonatal cardiac output is very dependent on the heart rate because they have a very limited stroke volume reserve. And a pediatric code or a neonatal code is very uniquely distressing because it involves children. So there is a lot of emotional and ethical strain. And the post-resuscitation care, one thing is to prevent long-term neurological injury because they have their life ahead, and targeted temperature management and neuromonitoring. So the latest update of AHA resuscitation guidelines was in 2025. One very nice thing about the AHA's chain of survival this time is there were 4 separate chains before this. There was an out-of-hospital chain, there was an in-hospital chain, there was an adult chain, there was a pediatric chain. Now all of that have been abolished, and there is presently only a 6-in-1 link chain. Very important is, John, pointer. Okay. Is this sign, the high quality CPR? Because here, before this, the second link, which is the high quality CPR, only had the sign of 2 hands giving CPR. But now they've included lungs, because now emphasizing that breaths are very critical for pediatric arrests, unlike only the CPR. And a substantial minority of adult cases also, your ventilation strategies are very important, like in drowning and opioid overdose. And the 6-in-1 link has recognition and emergency activation, high quality CPR, defibrillation, advanced resuscitation, post-cardiac arrest, care and recovery and survivorship. So coming to pediatric BLS algorithm, single rescuer, is it visible? It's very like adult code, except that very small differences here and there. So to be very clear, the first one is infant and child have different strategies. Infant is 1 until 1 year of age. child is defined as one from 1 year to puberty. Yes. So puberty is also defined as, for AHA, in girls it is development of breast buds, and for boys it is armpit hair. Yes, until that if you have doubt, you can use the, that is exactly what is 1 year to puberty. After that it is adult. So you verify scene safety first, then you check for responsiveness, you shout for nearby help, you activate the emergency response system. All this is right. So then you look for breathing, you look for pulse, not more than 10 seconds as usual. So there is breathing is present, pulse is felt, very good. You can wait and monitor until the advanced care arrives. Otherwise, if there is a good pulse felt more than 60 and abnormal breathing only is present, then you can support ventilation by giving positive pressure ventilation if possible. Otherwise, open the airway and provide rescue breaths. Rescue breaths at the rate of 1 breath every 2 to 3 seconds, so that you achieve a higher ventilation rates in children for 20 to 30 breaths per minute. In adults, it is only 1 breath in every 6 to 8 seconds, if I'm sure, if I know. So this applies only if there is a very good pulse more than 60. So after this, you're supporting ventilation, you check for pulse again after 2 minutes. One important update in 2025 is we didn't have clearer guidelines on early naloxone administration for suspected opioid associated emergencies in children, provided it does not delay high quality CPR. Now this has been part of the algorithm. So in support ventilation also they talk about you can give an opioid antagonist like naloxone in case if you are suspecting a opioid associated emergency. Now if the heart rate doesn't increase above 60, or if it is decreasing, or if it is maintaining, very good, you can continue with your ventilation strategies if a good pulse is felt. Heart rate is low, you have signs of poor perfusion, altered mental status, then you go into the BLS algorithm, where there are two things. You witness a collapse in a child, you don't witness a collapse in a child. You're entering the room, you have seen the child standing or breathing, or you're very sure the child has collapsed in front of you. Then you can go ahead to go and get you can activate the emergency response system. You can take that 30 seconds. I'm just saying for an exaggeration 30 seconds, you can make a call, you can take to 10 seconds because you know the child has collapsed just now. So that doesn't apply if you don't know whether the child has collapsed just now. Yes, if you have witnessed sudden collapse, you can go ahead and activate the emergency response team before attending the child. Otherwise, you start CPR. You start CPR at the rate of compressions 30:2 if you are a single rescuer. If a second rescuer arrives, then you give 50 compressions into 2 breaths. Again, there's a high importance on opioid associated emergencies. Early naloxone administration can be given here also. Now you continue this. After 2 minutes, you have not activated the emergency response system because you have not witnessed the collapse and the child is still not breathing, no pulse is felt. You take your time because 1 round of cycle is gone. So almost 5:30:2 you have given. So you go back and activate your emergency response system at least now. And as soon as possible you get a AED. If you don't get a AED, you continue 30:2 again. Yes. Once you get a AED, there are two things. Either you get help with AED. So in that case, your compressions become 15:2 and also you can attach the AED. You can check for shockable, unshockable rhythms. Shockable rhythms being pulseless ventricular tachycardia and ventricular fibrillation. Unshockable rhythms being asystole and pulseless electrical activity. In first case, you give a shock, 2 joules per kg. You resume CPR. When the AED alerts, you check for a pulse and you go ahead with the same cycle. If there is a pulseless electrical activity or a asystole, you continue CPR. You can wait for an adrenaline dose if it is available for you, or you continue CPR and check for pulse every 2 minutes, and that cycle goes. Yes. So 2 or more rescuers, again, not big difference. Only thing is your compression starts at 15:2. And again here, the suspected opioid overdose, you can try a dose of naloxone. What are the actual differences? As I told you, children age 1 year to puberty is defined as children. Below that is infants less than 1 year, excluding newborns because newborns has a separate algorithm. And you check for responsiveness. You look for a definite pulse within 10 seconds. You look for breathing or gasping. And witness collapse, you follow the steps for adults. Like witness collapse, you go and activate them, because in adults also we give importance to go and activate the emergency response system. Unwitnessed collapse, you give 2 minutes of CPR. After the 2 minutes also, the child is not revived, there is no breathing, there is no pulse. You take your time, go activate the emergency response system, and then come and continue your CPR. Also, one rescuer is 30:2 and 2 or more rescuers is 15:2. And your ventilation rate is always 1 breath every 2 to 3 seconds to achieve a ventilation rate of 20 to 30 breaths per minute. And compression depth, 1/3 of the AP diameter of the chest, approximately 2 centimeters in your child, and infants 1.5 centimeters. One very important update in 2025 is, before this, there was a 2 rescuer team. There's for your hand placement in CPR, there was something called thumb encircling technique, where you use both your hands together, your thumbs meet in the midline just below the nipple line. So that was a technique you use in 2 rescuer process. And in 1 rescuer process, there was something called 2-finger technique, where you use the index and the middle finger to give pressure. So this is actually easier in 1 rescuer, because you cannot encircle the chest, then leave the chest, go back, give ventilation, come back. But if you're waiting on the side of the patient, giving 2-finger technique and then giving a ventilation is very easy. But they have taken the traditional 2-finger method using the index and middle finger is no longer there in 2025 update, because it has been shown that it is not able to achieve enough compression ratio. Yes. So it is either 2-thumb encircling technique, preferably for 2 rescuers. For 1 rescuer, you can either use 2 hands, but it is very difficult to give ventilation. Then you can use the heel of the hand in a very, how much of a pressure you are able to give. So this is no more there. This is the right method, where you give 2, if it is 2 rescuers, one is giving ventilation, the other is giving CPR to 2 thumbs encircling technique. For child, it is either the heel of the hand. If you're not able to give enough compressions through that, you can use both the heel of the hands. Coming to the arrest algorithm, again it is the same as I told you now. You start CPR, you start bag and mask ventilation. If the child has not revived within the first 2 cycles, you get an AED as soon as possible. You look for you attach monitors, you look for the rhythm. If it is VF and VT, yes, you go and give a shock, 2 joules per kg. Second is, there is 2025 update reinforces the early dose of epinephrine as soon as possible for a non-shockable rhythm as soon as possible. This is not a change. This is again a reinforcement only. And in place of an advanced airway, then you need not give, your compressions can continue. You need not wait for 30:2. And you should give 1 breath every 2 to 3 seconds only, even if you have a advanced airway. Other important thing is the reversible causes, very, very specific for children, because how much ever you do CPR, the child might still be, might not recover, might not have a good pulse more than 100. It might be signs of poor perfusion can be there if you have not corrected hypothermia, if you have not corrected your hypoglycemia, if you have not corrected the electrolytes, like most importantly the potassium. And there are 5 T causes, which is tension pneumothorax, cardiac tamponade, toxins. That is the purview of a PALS class, which I'm not talking here. And the next important difference or challenge is that we don't get a AED patch, which is very specific for children. So in that case, you can use a pad in the front and pad in the back. In traditional AEDs, we used to have a pad which is under the adult pad. Nobody looks for it usually. But if it is not given, then you can use the adult pads, one in the front and one in the back, one between the shoulder plates and one between the child's nipples. Only thing is, if it's a bigger child and you want to use the adult pads, yes, you can go ahead. Only thing, they should not touch each other. That is very, very important. And post-cardiac arrest resuscitation care, again, 2025 reinforcement on continuous EEG monitoring, targeted temperature monitoring, prevent hypothermia. And this time I added a note on foreign body for infants and children, because there's a small tweak in 2025. Foreign body in children or in infants is very easy. It's just that whether the child has enough cough to bring out the foreign body. The child doesn't have enough cough to bring out the foreign body, like weak or absent cough, bad color, unable to cry, altered mental status, apnea, activate the emergency response system, go ahead to bring out the foreign body out. If the child coughs good, then very well, you can encourage the child to cough. So we have in infants, it is 5 chest thrusts, 5 back blows followed by 5 chest thrusts until either the object has come down, come out, or the infant becomes unresponsive. So either of this should happen. The child becomes unresponsive anytime you start CPR. In adults, in children, it is 5 back blows followed by 5 abdominal thrusts. Before this, there was more, they gave a lot of importance for chest thrusts again, but in children also you can use abdominal thrusts like you do in adults. A short note on neonatal resuscitation guidelines. The NRP edition is from AAP and AHA 2025, 9th edition presently. This is just for, I'm just touching up certain points. The child cries, has a good tone, and it's a term gestation. You just go for, the child is good. You give skin to skin contact, you give routine care, that's it. None of this is happening. Term gestation, no, not a term gestation, no good cry, no a good tone. You dry, position and stimulate and clear airway. One important point is, all of you rushing to do suction. They have removed suction from initial steps. You can suction only if it is needed, only if there are airway secretions. And still the child is apnea or gasping, you ventilate. There was the ventilation correct again after you start PPV also the child is not improving, still gasping, still heart rate is less than 100. The ventilation corrective steps had a particular sequential order in newborn resuscitation, like you have to check the airway first, you have to clear the secretions first, then you have to position the airway first, third, and then you have to see whether your PPV is right. None of that sequential order is there, no more. You can prioritize steps which might be helpful and not sequential. Very important key messages for NRP is delayed cord clamping from 30 seconds to 60 seconds. Ventilation target 30 to 60 breaths per minute, unlike in children where it is, and infants where it is 20 to 30 per minute. Emphasis on PPV, T-piece is preferred. Supraglottic airway for infants more than 34 weeks and immediate skin to skin contact. How do we navigate these challenges? Because running a pediatric code is very difficult. Even an adult code team gets very, I don't know, very distressed, or they get confused when it comes to a child. So important of pediatric code blue preparedness for PGs. Monthly mock codes, self-directed learning will improve CPR knowledge. Use of cognitive aids to enhance performance like PALS cards. Multidisciplinary simulation training to improve compliance with chest compression rates, ventilation rates and team leadership role. And education for pre-hospital and EMS professionals. Thank you.
Thank you so much, ma'am. Thank you, sir, for sharing your knowledge with us. I request Dr. Deepak to felicitate Dr. Prahita.
Thank you. Thank you, sir. Thank you, sir.
So moving on to next session, I would like to call upon the Neural Network Navigator, Master of Minds, Dr. Anirban Laha, the neurologist, to deliver his talk on updates in acute ischemic stroke management.
Okay, thank you. On இருக்கும் இது பாயிண்ட் பண்ணணும் பாயிண்ட் இது இதில் பாயிண்ட் இல்லை ஸ்லைட் சேஞ்ச் இதில் பாயிண்ட் இருக்கா பாயிண்ட் பண்ணணுமா சரி hello and good afternoon to all my dear colleagues, the organizing team. Thank you for having me here, and my dear juniors. So I am Dr. Anirban. I'm a consultant neurologist at Kamakshi Memorial Hospital. I understand we are halfway in the postprandial surge, glucose surge, and I have been tasked by Dr. Sai to give a very boring talk to you with lots of data, but I'll try to make it keep you awake as much as possible. With that, I'll just start. So I start with a slogan that is time is brain. And I want this message to go into your brain. Time is brain. So as I understand, all of you are the emergency physicians sitting here. This is the soul of the management in acute ischemic stroke that the whole stroke team has to follow. So to begin at the very first, that what is stroke? So long back in 1970, so we are more than 50 years back, rapidly developed stroke was defined as rapidly developing clinical signs of focal or global disturbance of cerebral function, which lasted from more than 24 hours or led to death without an other apparent cause other than vascular origin. And what was a transient ischemic attack? It later ad hoc committee on cerebrovascular disease defined it as episodes of temporary and focal dysfunction of vascular origin, which are variable in duration, commonly lasting from 2 to 15 minutes, but occasionally lasting as long as a day, up to 24 hours, and they leave no persistent neurological deficits. So in the 20th century, we used to talk with these definitions, but we are in the 21st century, and a lot of things have changed, including advancements in neuroimaging, which has given us much more data. So we consider these definitions as not so updated right now. So what was the critique? The modern brain imaging has shown that the 24-hour time window given for the stroke is too long, like permanent damage happens way before that. Also, strokes usually doesn't create a global dysfunction, like all the areas of the brain, frontal, occipital, parietal, temporal, all are getting affected at the same time. No, it doesn't happen. It respects the vascular territory. So it's not always a global cerebral dysfunction. And TIA is an enigma which is yet to be clearly defined by all the stroke bodies who are, all the neurology societies who are at loggerheads. So what is this accepted definitions? I'll come to, sorry. So today we are talking only about the ischemic stroke. So I have restricted the talk because otherwise it is beyond the time limits that they would allow me to speak. So I've restricted the talk to the management and updates in the management of ischemic stroke. We won't be talking about the hemorrhagic or the CVDs and other variants. So an ischemic stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal, or retinal infarction. And so what is an infarction? Infarction was defined as CNS infarction is in brain, spinal cord, or retina cell death attributable to ischemia based on either pathology or imaging or other objective evidence of same, the cerebral, spinal cord, and retinal focal ischemia injury. And number two is clinical evidence of cerebral, spinal cord, and retinal focal ischemic injury based on symptoms persisting more than 24 hours or until death, and other etiologies excluded. So with this definition of infarction, an ischemic stroke is an episode of neurological dysfunction caused by focal, cerebral, spinal, retinal. So even a retinal ischemia infarct is a stroke equivalent that needs to be treated. So without much ado, we come to the management. So in this whole slide, this is the current diagram has been taken from the stroke guidelines in the 2026 publication. Actually, you guys come here at this point. This is where the EMS, the emergency medical services, are contributing. Right from when the first call comes to you from the patient as giving some certain symptoms, where you identify a stroke, followed by the EMS activation of 911 as they tell in US, or 108 as we tell here, whatever. and which is coordinated at the same time by the emergency department, which is already ready to receive the patient by the time patient reaches the hospital door, and from the hospital door, the patient reaches the emergency door, the emergency doctors are ready. We come in here. As soon as you receive the patient, you give a call to us. So we also rush down, and assessment is done. The patient is assessed. Yes, clinically it's a stroke. Second, how bad is it? We assess it, score it, send it for immediate emergency imaging. So that, and after all the assessments done, we take a call. Yes, first it's a ischemic stroke. If it's a ischemic stroke, within the time window, we can lyse it. So we take the decision of thrombolysis. Along with it, one more concern is whether it's only a small vessel stroke or if there is a large vessel component. If it's a large vessel stroke, we urgently push for the angios and activate the intervention team. So this is the whole pathway that happens in the management of acute stroke. So how do we identify a stroke in the first place? So we have to be fast. So that is balance, eyes, face, arm, speech, time. Balance is sudden onset of imbalance. A person develops an acute ataxia. Eyes, loss of vision in one eye, or total blindness, or part of the field is lost. Face, droop of the face, facial weakness, asymmetry. Arms, drift of the arms, speech, slurring of the speech, or language impairment. So if all these red flags are there, think stroke, act in time. So T is time, because time is crucial. Again, time is brain. So what are some additional warning signs? A patient presenting with an acute confusional state. Patient has difficulty in understanding. He is awake, he is looking at you, but he cannot understand what you're telling. He has an acute or a severe headache, worst headache in the life. So these are also stroke. You should think stroke first, rule out stroke first. Along with it, you have to do the pre-hospital assessment tools. There are some more tools which can be used by the emergency medical team. Your paramedic can use it also. So the Cincinnati Stroke Scale, LAPS, RACE score, and also the modified analysis score, which is a more usable version of the detailed analysis. So these are done at here. When we are reaching the patient, we are bringing the patient, these scales can be done. So yes, we have identified by BFAST, it's a stroke, and then how bad is it? So we do the NIHS score. So it is the National Institute of Health Stroke Scale. It is a 11 item. There are 11 items. I think most of you have done the workshop yesterday, so you've got some overall idea. Dr. Vijay would have done it nicely. So as per it, the severity is, if it's a score 0, it is unlikely to be stroke. Score 1 to 4, it's mild. 5 to 15 is moderate. 15 to 20 is moderately severe, and more than 21 to 40, up to 42 is severe stroke. So this is a brief, the chart. I think you would have seen it yesterday. I won't spend time in this. These are the loss of consciousness, level of consciousness, commands, best gaze, visual fields, facial paresis, arm drift, leg drift, ataxia, sensory, best language, dysarthria, extinction, the main headings. So what do we do with an NIHSS scoring? So we have come to know that yes, whether it's a mild stroke, moderate stroke, severe stroke. The next step is imaging. So how do we image? The main thing is a CT. The first and the main step is a CT scan of the brain. You do a CT. You don't bother for MRI. Some centers may not have MRIs. You may only have a CT machine. It's a good, that is enough for stroke management. MRI, if you have the luxury, yes, you can use in certain situations. You leave it to the headache of the neurologist if he wants to deviate to an MRI. Otherwise, it's a CT scan. In a CT, we are concerned with the radiological severity by aspect score, and following which we will decide also about whether the need for a CT angio or a CT perfusion study needs to be done. In pediatric patients, Prahala ma'am was showing about the code blues. In pediatric patients with acute ischemic stroke, brain imaging, here comes the role of MRI and MR angio, which precedes a CT angio. If MRI is not available, then CT can be done for identification of the intracranial or extracranial vascular occlusions. If a patient presents beyond the time window, what do we do? Do we treat that as acute stroke or not? Yes. Now in 2026, the clear-cut guidelines have come out that beyond 4.5 hours, we image it, see for the diffusion flare, the salvageable tissue by the diffusion flare mismatch or the perfusion diffusion mismatch. If that is present, we will treat it with our updated treatments. So that is now called an extended window in intravenous thrombolysis. More or less the same thing. I will just skip this slide. So we come to, in the CT scan, we are looking at the aspect score. That is the Alberta Stroke Program early CT score. So the aspects has certain, I'll just come to it. It's basically, it was based on the MCA territory strokes initially when it was developed. It is a 10-point, we assess 10 regions in the brain, and for each region, 1 point is deducted from the score of 10. So if you have a hypodensity in the particular region, you deduct -1 from 10. And ultimately, you come to a total score. After the initial, after few over the years, we have modified the aspects to suffice for the posterior circulation strokes, which is called the posterior aspects or PC aspects. It is also a 10-point score, but here the scoring will be a bit different. I'll show you in the next slide. So yes, here and I need one volunteer. One volunteer. Anyone? Raise of hand. One volunteer. You are emergency physicians. The reflexes should be fast. Yes, we'll pick up. Sorry. Okay, whom do we pick up? Blue shirt in the middle. Your name, please. I would like to know your name. I don't want. Good. Your name, identify yourself. Dr. Okay. Have you done an aspect score previously? Have you not? No. Can you identify the brain areas shown here without reading the, without reading? Okay, can I have a pointer? Pointer. No. Okay, I'll show it here. Where am I pointing to? Huh? No. What is this gray? This gray? No. Okay. This is? No. Okay. Put your mic on. So this is the internal capsule as I'm tracing the internal capsule, right? What is this? This is the head of the cord. This is the head of the chordate. This is the internal capsule which I'm tracing. This is the lentiform nucleus, okay, which contains the globus pallidus and the putamen and the globus pallidus. This stretch is called the insula and the insular cortex. This is the frontal lobe, okay. This is the part, this is the occipital lobe. This is the upper part of the temporal lobe you can see here, okay. So this area is called the frontal operculum. This is the temporal operculum. Within this space is called the Sylvian fissure. Although everything is written here, I just wanted to highlight it so that you get the perspective of what we are talking about. So it is here that the MCA courses and the MCA branches. So when the MCA branches, it goes to the super. You can go. Thank you. Hold on. So it is within the Sylvan fissure that the MCA divides into the anterior division, posterior division. So, and this all areas are the MC areas which has been demonstrated over here. These areas, which is the internal capsule, the lentiform nucleus, chordate, these are supplied by the lenticular striate branches which arise initial part of the MCA. So these are the deeper branches, these will be supplied by the more later branches. So when you have a proximal MCA stroke, this entire area is going to go. So when we are doing a CT scan and you see a hypodensity involving this whole region, you understand it is a proximal MCA occlusion because the deeper branches are also gone, the more superficial branch, the later branches are also gone. So for each region, you see the letter, I don't know whether you can appreciate from the back, there is a -1 written here. So if you have a hypodensity here, -1 from 10, -1 from 10, -1 from 10, -1 from 10, like that. Okay? So the total score will come to this plus this. So this is at what level? This is at the level of the capsule, internal capsule or basal ganglia level. So next cut comes as the corona radiator level, which is higher than the basal ganglia internal capsule level. So at the corona radiator, there are 3 regions: anterior, lateral, posterior, the MCA territories. These are all parts of the frontal lobe. This is your central sulcus. So this is the small part is the parietal lobe. So when you have lesions here, you will -1 from here. Now coming to this, the lower panel is the posterior aspects. So again here, just to understand, this blue, which is, and these are the thalamus. This green is the occipital lobe. This is the midbrain. This is the pons. This is the cerebellum. So for each areas, you will subtract -1. This is supplied by the posterior cerebral artery. This will be supplied by the vertebral arteries, the pons and the cerebellum, the superior and inferior cerebellar arteries. Okay. So the standard of care for acute ischemic stroke is revascularization therapy within the window. The agents we use is alteplase, tenecteplase for intravenous thrombolysis. Dose of alteplase is 0.9 milligram per kilogram total dose with a maximum of 90 milligram. So a 100 kg person, you give 90 milligram. 120 kg person, you still give 90 milligram. You don't just multiply by 0.9. So 10% of the dose is given as a bolus, followed by the rest of the 90% is given as an infusion over 60 minutes. Tenecteplase is the dose is 0.25 milligram per kilogram, a maximum of 25 milligram given as a bolus over 5 seconds. Cardiologists use tenecteplase more. They use it at a higher dose, 0.4 milligram per kilogram, I think. But we are using at this dose. This has been approved. So the AHA primary goal recommendations, the standard time metrics that the emergency team along with the stroke team has to comply to. So the door to the healthcare provider or the ER should be within 10 minutes. The neurologist should come within 15 minutes of the patient's arrival. Earlier the better always. CT completion should be done within 20 minutes. The interpretation within 45 minutes. And the door to thrombolysis should be within 60 minutes. The puncture time, that is if you are going for thrombectomy, 90 minutes and the recanalization 120 minutes. So what are the recommendations? So a patient with acute ischemic stroke with disabling deficits, regardless of the NICU score, so NICU score of 1 or 2, but a patient is having loss of vision, you thrombolize. A singer has come with a mild slurring of speech, no limb weakness, you thrombolize. Okay? So it is to be done. The angios are to be done. So these are the recommendations. I'll just skip it for the sake of time. So what are the contraindications? There is a large area of hypodensity, and those are the absolute contraindications. The 1/3 MCA territory, intracranial bleed, traumatic brain injury, neurosurgery less than 14 days, acute spinal cord injury within 3 months, intraaxial neoplasms, infective endocarditis, severe coagulopathy, aortic arch dissection, any amyloid related imaging abnormalities. Relatives ones are the NOACs or DOACs. If ischemic stroke within the 3 months, prior ICH, recent non-major CNS trauma. So these are the list of the relative contraindications. The relative contraindications means you can, on a basis, take a call, and if the patient benefits, you feel the patient benefits more from thrombolysis, you go ahead with thrombolysis. So if it's a dural puncture less than 7 days, any arterial puncture which is non-compressible, so like a subclavian puncture less than 7 days, moderate to severe traumatic brain injury within greater than 14 days to 3 months, neurosurgery greater than 14 days to 3 months are all relative contraindications. Post-thrombolysis symptomatic ICH is the main risk, and the management includes you have to stop the thrombolysis, get the blood work done, get a CT, non-enhanced CT to see for the bleed volume and all, give cryoprecipitate. The thumb rule is 10 unit over 10 minutes. And tranexamic acid can be used 1000 milligram over 10 minutes. The hematology and neurosurgery consultations, supportive therapy to be done. BP has to be managed to reduce the bleed volume. Endovascular thrombectomy, large vessel occlusions of the ICA or the proximal MCM1 are taken up for endovascular thrombectomy. Within 6 hours is the golden time for thrombectomy, where patients with NIHs of greater than 6 and with an aspects of 3 to 10, or with a 6 to 24 hours period, if the aspects is 6 to 10, that means within 0 to 6 hours you can still thrombolyze a more severe stroke, but if it is 6 to 24 hours, aspects 6 to 10 means a less severe stroke, you can go ahead with the thrombectomies. It improves functional outcome and reduces mortality in patients who are less than 80 years. In pediatric patients more than 6 years, endovascular thrombectomy can be effective. It has to be done by an experienced interventionist, and especially those experienced with pediatric interventions. What is the gold standard treatment? The antiplatelet therapy, aspirin. Ticagrelor is not recommended over aspirin in minor strokes and all. No role for any triple antiplatelet therapy. In atrial fibrillation and stroke, you anticoagulate. You don't add aspirin because that increases the risk of bleed. There is a role of the dual antiplatelet therapy followed by single antiplatelet therapy is what we practice, but the dual antiplatelet therapy is up to 90 days. We don't extend the dual antiplatelets beyond 90 days. So nowadays this gene test is quite easily available, the CYP2C19 for clopidogrel loss of function. So in case it is there, the dual antiplatelet, the ticagrelor with aspirin combination is given for 21 days. After that, you shift to ticagrelor. The general supportive care, I think I'll just skip this part for the want of time. So conclusion, in the acute ischemic stroke is a significant mortality and morbidity is there. The 2026 guidelines has expanded the gambit of patients, they extended the window. So we are now treating more patients. The synchronization of the departments is important. So the neurons saved in minutes is brain saved. Again, time is brain. Thank you.
Thank you so much for the wonderful presentation. Now I call upon Dr. Mahendra Varman to felicitate Dr. Anirban sir. Thank you, sir. Next, I call upon the uterus boss, hormone hacker, ovary operator, Dr. Monica Ogician to give a talk on Beyond the ER, Inside the Robotic OR.
A very good afternoon to everyone. It's a postprandial session, as everyone was saying. So slightly, I would like to transport you all into the robotic OR. I'm Monica. I'm a gyneco surgeon, a robotic gyneco surgeon, and senior consultant at Kamakshi Hospital. So we all know the traditional method of doing surgery is open surgery, and which entails need for like we do abdominal surgery. So it entails a lot of large incisions and the hospital stay, prolonged hospital stay, and with prolonged hospital stay, there are a lot of complications. And intra-op, you have blood loss, which is increased, and in pelvic surgeries like our gynec surgeries and onco surgeries, the visualization becomes difficult, and the whole procedure is a bit complicated in deep pelvis, and obesity increases the complication in patients also. And the large incision, again, there is wound related complications, and the dreadful of all is DVT and thromboembolism, which we encounter very frequently these days. So to counteract all these things came laparoscopic surgery, and now we have robotic surgery. So we know laparoscopic benefits. So most of the patients now undergo laparoscopic surgery. They moved on from the era of open surgery. Whenever possible, people undergo laparoscopic surgery instead of open surgery. But what does the robot specifically give? Like, what is the benefit compared to laparoscopy? So you can see that, like, in laparoscopy it's a 2D vision, but in robotic surgery we have a 3D vision, which helps the surgeon see things in detail, in depth, and do precise surgery. Apart from that, the instrument dexterity, so you have like 7 degrees of motion, which is very helpful for the surgeon. And the movement also, it's like it replicates your hand movements. In laparoscopy it's counterintuitive, in robotic it is intuitive. Apart from that, there is no tremors, and surgeon fatigue is very much decreased, and the ergonomics is very good in robotic surgery, and the learning curve is definitely smaller. You can transition easily from an open to robotic surgeon. So moving ahead, again, I would just insist on the benefits of robotic surgery. The main thing being decreased blood loss. Like, we operate at a blood loss of less than 50 ml. Like, it's just because you see the vessels very up close, and you catch hold of every tiny capillaries, and the blood loss is very low. Apart from that, excision of the disease can be done very easily. Like, you see up close, you remove the endometriotic spots or the tumor nodules very easily by seeing it close, and the energy sources are also very precise. And you have endorist motion, as I told you, like it's like your hand is inside the tummy and it's like operating very up close, and 3D vision. And I had told you about the deep pelvic spaces, which can be accessed very easily. Some surgeries are even very difficult with open surgeries, which are very easily done with robotic, especially endometriosis surgeries. And you have excellent nerve sparing capabilities, which is very essential for preserving the bladder, bowel, and sexual functions in case of pelvic surgeries. And suturing, again, I don't know, maybe your surgeon friends would have told lap suturing is a nightmare for anyone. So robotic suturing is like, it's one of the easiest things that can be done. And the most of all, which is helpful for us, is the reduced surgeon fatigue. So I'll just show you a short video. I hope people understand Tamil here. It's like a short video just transporting you into a robotic OR to see how things are here. So this
Kamakshi Hospital இருக்க robotic system பத்தி தான் இன்னைக்கு பார்க்க போறோம். இது வந்து DaVinci X சொல்லிட்டு world's one of the best advanced robotic system தான் நம்மகிட்ட இருக்கு. And it actually consists of 3 parts. So என்னென்ன பாத்தீங்கன்னா, இது surgeon console னு சொல்லுவோம். அத பத்தி நான் first explain பண்றேன். Surgeon console, the surgeon will be sitting here and operating. It is almost like driving a car, and your precision should also be similar to that. பாத்தீங்கன்னா நம்மளோட ரெண்டு ஹேண்ட்ஸ், சர்ஜனோட ரெண்டு ஹேண்ட்ஸும் இங்க இருக்கும், and both the legs will be operating from down. So all the 4 limbs of the surgeon will be acting in coordination, and the surgery வந்து இன்னும் precise-ஆ பண்றதுக்கு help பண்ணும். It's like இப்போ ரெண்டு கை வச்சு சர்ஜரி பண்றதுக்கு பதிலா 4 கை வச்சு சர்ஜரி பண்ற மாதிரின்னு கூட நம்ம வச்சுக்கலாம். robotic system பொறுத்த வரைக்கும் இதுதான் ரொம்ப இம்பார்ட்டன்ட்டான காம்பனன்ட். ஸோ 3 காம்பனன்ட்ஸ் இருக்கு. இது வந்து பேஷண்ட் கார்டுன்னு சொல்லுவோம். 4 instruments இருக்கும் ஜெனரலா. ஸோ இந்த இன்ஸ்ட்ருமெண்ட் வந்து கேமரான்னு சொல்லுவோம். இது வழியா தான் உங்க வயிறுக்குள்ள என்ன இருக்குன்றத நமக்கு விஷன் கார்டுன்னு ஒரு இதுல ப்ரொஜெக்ட் ஆகும். சரிங்களா? அதுக்கப்புறம் 2 இன்ஸ்ட்ருமெண்ட்ஸ் ஒரு சைட்ல, 1 இன்ஸ்ட்ருமெண்ட் இன்னொரு சைட்ல இருக்கும். டிபெண்டிங் ஆன் த டைப் ஆஃப் சர்ஜரி நம்ம வந்து என்ன இன்ஸ்ட்ருமெண்ட்ஸ் சேஞ்ச் பண்ணணும் பண்ணிக்கலாம். ஸோ ஒரு 5 ஹோல்ஸ் மேக் பண்ணுவோம். எல்லாமே வந்து உங்க தொப்புளுக்கு மேல இருக்கும். எல்லாமே 1 சென்டிமீட்டருக்கும் கம்மியான ஹோல்ஸ். அது கூட வந்து இந்த போர்ட்ஸ்ன்னு சொல்லுவோம். இதெல்லாம் அட்டாச் பண்ணியிருக்கோம். இதுதான் இன்ஸ்ட்ருமெண்ட்னு சொல்லுவோம். ஸோ ஜஸ்ட் டு ஷோ யூ, பேஷண்ட் பக்கத்துல எப்பவுமே ஒரு அசிஸ்டன்ட் சர்ஜன் ரெடியா இருப்பாங்க டு கிவ் வாட் எவர் இஸ் நீடட். ஃபார் எக்ஸாம்பிள் ஒரு நீடில் தேவைப்படுதோ இல்லைன்னா ஒரு பாஸ் பீஸ் தேவைப்படுதோ அதுக்கு வந்து இங்க இருந்து ஒரு அசிஸ்டன்ட் சர்ஜன் எப்பவுமே ஹெல்ப் பண்ணிட்டு இருப்பாங்க. அந்த நர்சிங் டீம் will also be standing here and giving the necessary things. இது இன்னொரு காம்பனன்ட் ஆஃப் தி டாவின்சி robotic system. என்னன்னு பாத்தீங்கன்னா விஷன் பேட்டர்ன் சொல்லுவோம். ஸோ எப்படி வந்து நம்ம ஆப்ரேட் பண்றது சர்ஜன் கன்சோல்ல தெரியுதோ அதே மாதிரி அவுட் சைட் த சர்ஜன் கன்சோல் இருக்கிறவங்க, தியேட்டருக்குள்ள இருக்கிற அசிஸ்டன்ட் சர்ஜன் அண்ட் நர்சஸ், அனஸ்தீசியா டீம் மெம்பர்ஸ் இல்ல யாராவது அப்சர்வ் பண்ண வந்திருக்காங்க அவங்க எல்லாருமே பார்க்கணும்னா இந்த விஷன் கார்ட்ல அது ப்ரொஜெக்ட் ஆகும். அண்ட் இட் வில் பி வெரி கிளியர். இது அதுக்காக யூஸ் ஆகும். அப்பார்ட் ஃப்ரம் தட் இந்த விஷன் கார்ட்ல நம்மளோட எனர்ஜி சோர்சஸ்க்கான ஸ்டாக்ஸ் இருக்கும். தென் கேமரா கனெக்ஷன் இருக்கும். அண்ட் we can also have all the gas and other tubings that can be set up here. So இதுதான் விஷன் கார்டோட purpose.
That was just a short demo to tell about the components of the robotic surgery system. So I'll just tell you what benefits it has added to surgery as such. I know in emergency, like we heavily rely on our emergency medicine team when we do surgeries. Like you people let us sleep peacefully at home, and you would have seen most of our complications, and lot of the complications you would have seen, like starting from open surgery to laparoscopic surgery. So with robotic surgery, I would just highlight on some complications which can specifically happen in patients who have underwent robotic surgery. Before that, telling the benefits. So with robotic surgery, we are able to send the patient home within 24 hours. Again, though everything is safe and the patient has recovered extremely well, we have to be aware of the complications, and we keep our minds trusted on our acute emergency medicine team to resuscitate the patient whenever they come in with any kind of complication. So what is prehabilitation? I hope you would have heard about prehabilitation. Prehabilitation is a thing that is being followed these days. It is something you offer to the patients before surgery to make them physically more fit for the surgery. So right from the start of diagnosis till the date of surgery, you optimize the patient to undergo anesthesia and undergo the surgery. That's called as prehabilitation. It has 3 main components. One is respiratory, one is nutritional, other is the physical. So for respiratory, we advise incentive spirometry as a baseline for all patients. And if you feel the respiratory reserve of the patient is low, we refer them to pulmonologist, assess, and then give add-on therapies if needed to optimize the patient. And hemoglobin needs to be optimized, nutritional, the albumin level needs to be seen, and it should be optimized. Apart from that, we practice something called as enhanced recovery after surgery. I think you would have heard about ERAS. These 2 terms are the things in surgery, any surgical field these days. Both rehabilitation and ERAS are what are making patients go home early and recover early. So ERAS is a system where we do not keep prolonged fasting, even preoperative fasting and postoperative fasting. So preoperative fasting is only like 2 hours of preoperative fasting we give of liquids, solids about 6 hours, and then postoperatively, like we try and feed the patient within 4 hours and give them soft diet within 6 hours if there's no vomiting. So, and no catheterization or tubes are connected. So drain tubes have become null and void these days, and like we do not put the catheter, we remove the catheter at the end of the surgery and send the patient to the recovery. And as I told you, we discharge the patient within 24 hours of surgery. So, and they are able to resume their work within like 2 weeks to 3 weeks of a major surgery. Give them 10 days and they'll be at least able to do their routine work at home. And with work from home, the people are resuming work as early as 7 days. So, yeah, what procedures can be done by robotic surgery is another thing. Believe me, patients have asked me whether you do LSCS using the robot. Unfortunately, we do not have the technology now, maybe someday. So apart from that, almost everything benign and malignant is being done by the robot in gynec at least. And it has taken up in all surgical fields. I think you would have heard some other beautiful talks also. So like the commonest procedure which we do is hysterectomy.
Dear delegates, please do not leave with so much of pain and so much of difficulty. We have arranged very, very busy faculties like these. It is very much a lot of disrespect is happening because people are just leaving, coming and asking certificates. Please note that people who leave will not get even a single CME credit. Please try to understand. Please don't come and ask the certificates. Just we have 3 more talks and a panel and we are leaving. Okay? Hope you understand. Thank you.
So the commonest one is hysterectomy followed by myomectomy, and robotic surgery is a boon for endometriosis resections, and you can do all other urogynecological procedures also. For malignancy, for endometrial cancer, the standard of care is using robotic surgery. Cervical cancer, if the tumor is small, you can go with robot. And ovarian cancer, still it's under trial. For some patients for whom the disease load is low, we can offer them robotic surgery. And for vulval cancer also, for inguinal lymph node dissections, we use the robot. So these are some of the basic procedures that we perform using the robot. And so there are some videos I would have liked to show you. Maybe I'll show you a single video alone. So I'll just show you a lymph node dissection. For want of time, I'm not showing much of videos. So this is basically pelvic sentinel lymph node dissection. So you can see how beautifully the vision is using the robot. You can see how tiny capillaries are seen very easily. And this is like a scissor, and this is like a forceps. You have energy source connected to it. This is like something like a monopolar cautery, and this is like a bipolar cautery. So this robotic system has something called as a firefly technology, which is being used for a lot of things. Like you can see that it helps us identify the first lymph node. I think everyone will be aware of something called a sentinel lymph node dissection, basically started with breast malignancies. Now this is the standard of care for all our endometrial cancers. So we inject the dye in the cervix, and we track it, and we identify the sentinel lymph nodes and remove them. So you can see the vessels here. I don't want to bore you all with anatomy. So it's just I wanted to show you how nice the picture is and how with how much precision we are able to do the surgery with this system. I'm trying to develop the spaces here, and this is the ovary, this is the tube. Sorry for not giving that context in the beginning. And this is your side wall structures, right side wall structures, pelvic side wall. So this is the beautiful node which you can see here. And we'll be able to, so it doesn't mean that it has cancer, it just identifies which is the first draining lymph node. And you can also see the ureter nicely. So I end up removing the lymph node with the help of the firefly technologies just to do the exact dissection that is needed. It helps me. So this is about lymph node dissection surgery. And radical hysterectomies can be done using the robot, and I'll just show you few bits and pieces so that you can see, like all the tiny capillaries can be seen without much of bleeding you can do. Generally radical hysterectomy takes hours together, and there is bleeding. The surgical time is comparatively reduced, but bleeding is significantly reduced in the robotic surgery. So this is the left pelvic side wall, and you can see the bowel here. This is the uterus, and this is the round ligament, and I'm just making some spaces, and I'll be able to go and make like ureteric dissection I'll be doing after this. So I don't want to bore you with all these. I'll go for other thing, like you will be able to see like nerve very clearly with the help of this much vision. So when we are doing radical surgeries in the pelvis, we have to be very careful about something called as the hypogastric nerves. So that is one thing that we should preserve during these surgeries. So this is the hypogastric nerve. We can easily cut it off or include it in ureter. We are very careful and we are able to see it, but nerve structures are very thin and it's very difficult to see it without having magnifying eyes. So in this system you can see nicely the hypogastric nerve is demonstrated with its branches, with its thin branches. So this is like after hysterectomy, this is like the vault area. You can see the ureter moving nicely in this thing. Here the ureter was here. So yeah, this is about surgery. Now coming to benefits and what do you need to know, like when you're in the ER, what do you need to know about the robotic surgery? So the benefits are, I have spoken more about it, 24-hour discharge, minimal blood loss and early return to daily activity, and no wound related complications. In malignancies, we have minimal delay in giving the adjuvant radiation and chemotherapy, like that's very important while you're treating malignancy patients. So what can happen? Post-operative emergencies, what can be there? So early complications, obviously any kind of surgery has the risk of hemorrhage, though everything has been done perfectly, people can make mistakes. So when a patient comes, like the only point that I want to convey to you today is a patient who underwent robotic surgery, when they come to your ER, may seem very well because they don't have this big scar that is there, which generally gives them the sickly look. They appear very well, they appear very well preserved, but underlying there could be a major complication. So you should always have that in mind when you are receiving such patients, because we are so used to seeing patients who have had open surgery or laparoscopic surgery who just give some kind of a post-operative sick vibe. But for these patients, it's like they come in very, very smoothly. They just come, maybe I had a mild pain or something. So always make it a point that there could be something underlying. Just highlight it to the surgeon and try and find out the reasons. So early complications, what we are expecting are hemorrhage, urinary tract injury, bowel injury, vaginal cuff bleeding, and the chances of ureteric injury has strongly decreased with the use of robotic system and ICG, the Firefly technology, but still there can be errors and you have to look for it. Delayed complications, there can be pelvic abscess or thermal injuries and vaginal cuff dehiscence, which again should be looked up. The one more thing is, which I wanted to tell you is there can be some complications that are distant to the site of surgery. Again, these can happen later on, like once the patient is well, we discharge them and they go home well. Like 99% of the time they don't come back with any issues, but the 1% of the time we should be able to diagnose them with all the troubles. So what happens in robotic surgery, we give them Trendelenburg. So we give them a comparatively steeper Trendelenburg compared to laparoscopic surgeries. It's around like the maximum we can go is anywhere up to 25 degree. But even with that, we have to be careful, and the Trendelenburg can cause some complications that is unique to robotic surgery. So you can see this is something called as a shoulder strap. So this kind of a shoulder thing is kept when we are giving Trendelenburg for patients. So this can cause injury to the brachial plexus and it puts pressure on the acromioclavicular joint. So we have to be very careful, and they can present with ulnar nerve, brachial plexus or median nerve injuries. So there are a lot of intraoperative anesthetic like preventive measures that we do, like we keep a lot of gel foams, positioning, we do everything, but still things can happen and we need to pick it up. And lower extremity nerve injuries can also happen. So the patient, especially in pelvic surgeries, urological and gynec surgeries, they are in a lithotomy position. So the legs can be on a stirrup for quite some time. So it can cause compression injury of nerves like peroneal nerves, lateral cutaneous nerves, and obturator genitofemoral nerves can happen. So moving on, other complications is there can be cerebral edema secondary to the Trendelenburg. So we have, when they come with signs of headache, vomiting, drowsiness, you have to have that in mind. Apart from that, we make it as a practice to see whether these patients pre-operatively, whether they don't have any history of glaucoma or increased intraoperative pressure. Again, that is because of the increased Trendelenburg position. They can cause a bit of increased intraocular pressure. which can later on present as ischemic optic neuropathy, corneal abrasion, or sometimes they can have retinal tear or retinal detachment. Again, these are all like rare complications which we have not encountered in our clinical practice, but still we as treating doctors and our emergency team, we would like you all to know that, because the era has changed and it's mostly robotic surgeries these days. So wherever you work, you will have patients coming in who have undergone robotic surgery. Just keep a few points in mind, and that might help you somewhere. Thank you.
Thank you so much, ma'am, for the wonderful informative presentation. Next, I call upon Dr. Sayer from SIMS Hospital to felicitate Dr. Monica, ma'am. Next, I call upon the renal protector, kidney care champion, Dr. Mahendra Varman, nephrologist, to deliver a speech on renal rescue.
Good afternoon. I would like to thank Dr. Sai Surendra sir and his team for giving me this opportunity. So the topic given to me was renal rescue, comparing the effects of SLED versus CKRT. So as you know, SLED is sustained low efficiency dialysis, and the common term was CRRT, and as you know, the renal societies, they keep on changing the name. So during my UG days it was CRF and ARF, and now it is AK and CKD, and now CRRT has been converted to CKRT, that is continuous kidney replacement therapy. This is because even common people should be aware what we are doing to them. So that's why you see renal is an alien term. So kidney is known to all, even our village people know what is kidney. So continuous kidney replacement therapy gives a very good definition of the procedure we are doing. So these are all the topics which we will be seeing: basics, diffusion and convection, 8th standard physics, kidney replacement therapy in acute kidney injury, and CKRT basics and the comparison and few cases. So the molecules in our body can be divided into three parts: small molecules, middle molecules and large molecules. This is for the usage in dialysis. So small molecules, their molecular weight is less than 500. Middle molecule, some people say it is between 500 to 15,000, and other people say it is 500 to 50,000 kilodaltons. And large molecule, it is above 15,000 or 50,000 kilodaltons. So these are the two common molecules which we see daily in our routine clinical practice. This is urea and creatinine. So the urea's molecular weight is 60 and creatinine's molecular weight is 113. And this is albumin, the most common protein which is present in our body and which is very important for maintaining the oncotic pressure. And this is a single chain polypeptide, and its molecular weight is 66,000. So the molecular weight is very important because the dialysis and CRRT, they are going to remove these molecules, and it depends upon their size particularly. So this is a summary of the molecules. So urea and creatinine are small molecule, albumin is a large molecule, and beta 2 microglobulin is a representative of middle molecule. So its molecular weight is 11,800, and other kappa and lambda light chain which we find in multiple myeloma, their molecular weight is 25,000. So these two important terms are going to recur again and again in my talk. That is diffusion and convection. Diffusion is, as you know, it is the movement of a solute from its region of higher concentration to lower concentration. So this circle is our blood which passes through the dialysis filter, and that blue color is the dialysis solution. So in diffusion, as you see, the blue molecules, urea and creatinine, comes out very easily, but the red molecule, that is the beta 2 microglobulin, is not able to pass through it. And in hemodiafiltration, that is convection plus diffusion, you see all the three molecules can come out very easily. So diffusion mainly deals with dialysis or a SLED, and convection plus diffusion is used in CRRT. So this is again the same thing. I don't want to go through it. And as you know, CKD has 3 stages. Similarly, you should know that CKD has 5 stages, And acute kidney injury also has stages, that is stage 1, 2 and 3. So this can be seen in every books and net, so you can go through it. So AK particularly has stage 3 stages, and stage 3 we usually do dialysis. So this is the first dialysis machine which was successfully used to treat acute kidney injury in 1946. That is, we have been doing dialysis for 8 years, but the first dialysis was used for an acute kidney injury patient by Wilhelm Kolf, and the patient was successfully treated and she survived. So main problem in acute kidney injury, in CKD we definitely know when to do dialysis, but acute kidney injury we are not sure when to start dialysis, what modality to use, and what is the dose that should be used. So this has been a big confusion all through these years, and it still persists. But anyway, I do not want to go into the when and the dose of dialysis. Our only option and topic given here is modality of dialysis. So, but here these are the absolute indication for starting dialysis in acute kidney injury, and this you should be aware of, because when the patient first presents to the ER with acute kidney injury, if you see any of these problem, you can definitely start dialysis. No one is going to question you why you have started dialysis. So these are all the absolute indications. Severe hyperkalemia, which is not amenable to treatment with medicines, that is potassium binders, salbutamol nebulization, insulin dextrose, and all those things. And most of the people give calcium gluconate, but calcium gluconate is not going to decrease the level of potassium. It is only a stabilizing factor in the heart. And severe metabolic acidosis, not refractable to medical therapy, refractable to medical therapy, and resistant fluid overload, not treatable by diuretics. Uremic complications like uremic encephalopathy, uremic pericarditis, and altered sensorium, and all these complications, and severe oliguria or anuria, which is not responding to diuretics. If these problems are present, you can absolutely start dialysis in acute kidney injury. So to our main point of discussion, comparing CKRT and SLED. So what is SLED? SLED is sustained low efficiency dialysis. Usually, you know, in CKD we do dialysis for 4 hours or 5 hours, 3 times a week. But SLED is usually preferred in acute kidney injury patients. So what is the difference between intermittent hemodialysis and SLED? In SLED, you are going to do dialysis very slowly for a prolonged period of time. So there is no major BP or hemodynamic instability, and there is no major electrolyte shift in the duration of dialysis, and you remove the fluid, ultrafiltration, very slowly. So this convection removal is very low in SLED. So that is, you only remove either 2 to 3 liters per day over 8 to 10 hours. So this is the routine dialysis machine which we use for regular CKD patient, and this is the same machine is going to be used for SLED also in acute kidney injury. It has only a single pump and a normal filter which will be used. So the cost of SLED is very, very cheaper compared to CKRT. It is only around 5,000 to 8,000 rupees per day. So this is the solution which we use for dialysis. It contains the important electrolytes: sodium, potassium, chloride, calcium, bicarbonate, and glucose. Some solutions have glucose, some don't have glucose at all. So this is what a typical sustained low efficiency dialysis prescription looks like. You dialyze for 8 hours, and the blood pump rotates and sucks blood at the rate of 150 ml per minute, and the dialysate is a solution which moves opposite direction to the blood flow. It is around twice of the blood flow. So if the blood flow is 150, dialysate flows 300, and most of the patients with acute kidney injury, they have some bleeding complication. So you don't give heparin, you do heparin-free dialysis. And the ultrafiltration usually is around 1.5 to 2 liters depending upon the fluid overload state and what fluid needs to be removed and maintenance fluid you are giving. So the advantage of SLED is that compared to routine dialysis, you maintain the hemodynamics in a better way, and you can do anticoagulation free without heparin, and it allows time for other procedures unlike CRRT. In CRRT, it goes on around for 24 hours to 48 hours. But in SLED, you do only for 8 to 10 hours. So in other time, you can do your interventional procedure, pleural tapping, ascitic tapping. You can shift them for imaging and all those things. And you use the same machine as routine dialysis machine, so the cost is very low. And the disadvantage compared to routine dialysis is that you remove the toxin at a very slow rate. So CKRT, here there are 3 types. It is continuous veno-venous hemofiltration, hemodialysis, and hemodiafiltration. So these are 3 modalities which can be set up in the machine. So in hemofiltration there is only convection, in hemodialysis there is only diffusion, and hemodiafiltration there is convection plus diffusion. And many of the studies have found no difference in these three of the modalities. So you can use anyone which you want. So this is purely theoretical. You can use CVVH or HDF or HD. And the difference is that in CVVHF, there is no dialysate. There is only replacement fluid. So that is in convection, you remove around 1000 ml of fluid per hour and you replace it with good solution. In continuous venovenous hemodialysis, there is no convection, there is only dialysis. In continuous venovenous hemodiafiltration, you do both dialysis and replacement. So this is what a typical CRRT machine looks like. It has multiple pumps, around 4 pumps, and there are 4 bags at the bottom. So one bag is for replacement fluid, one is for dialysate fluid, one is for pre-blood pump, and one is for post-blood pump. So this, you need a separate machine, you need a separate filter which is very costly, and you need clear sterile fluid which is prepared by the company themselves, unlike the routine dialysis machine. So this is a solution which we get in the bags it is present, and the only exception is it contains lactate at 3 millimoles per liter. So this lactate is needed for stabilizing the solution. So in patients with hyperlactatemia, sometimes lactate can increase due to CRRT also, unless you treat the original cause. So this is very important. In a patient with intracerebral hemorrhage or liver failure, you have cerebral edema. And another thing is that in patient with uremia, you have a high urea both inside the brain and in the blood. So when you remove the urea rapidly with dialysis, what happens is the urea in the blood is not removed because it has to cross the blood-brain barrier. So when you remove the urea within the blood, the serum osmolality naturally comes down very fast because the serum osmolality depends upon the blood glucose, urea most importantly, and sodium. So when the urea is removed very rapidly, what happens is there is fall in the serum osmolality. So instead of urea moving from the brain to the blood due to the blood-brain barrier, water moves from the blood into the brain, which causes cerebral edema. This edema occurs in all the tissues, muscle, bones and everything. But why brain is the most important organ is because it is surrounded by skull. So skull does not allow the brain edema to expand. So naturally there can be herniation of brain into the foramen magnum. So that is why even in hyponatremia, when there is cerebral edema, you get predominantly neurological symptom, even when there is swelling of other organs also. So CKRT, what is the advantage? There is continuous removal of solute, and so there is better hemodynamic stability, and there is easy control of fluid balance. This is because in ICU you keep on administering antibiotics, fluid, and in emergency also you can be giving more fluid. So since CRRT runs for continuously for 24 hours, 48 hours, you can remove the fluid which you are giving continuously, unlike the intermittent therapies. And you can give continuous nutrition also through the CRRT. The disadvantage is that you need either citrate anticoagulation or heparin anticoagulation. Otherwise, the filter will get clotted and you need to replace the filters again and again, which is going to be a very costly affair. And you need separate filters and sterile bags, and the patient is going to be immobilized for prolonged time, which can cause DVT, and it is very, very costly, this procedure. So since CRRT is prolonged, there can be hypokalemia and hypophosphatemia. I don't want to go into detailed thing. So there are specific indications where CKRT is beneficial compared to SLED. So this you have to remember. This is particularly with raised intracranial tension, cerebral edema, liver failure, severe hypo or hypernatremias. Because if you correct hyponatremia very fastly, you can get osmotic demyelination syndrome. If you correct hypernatremia very fastly, you can get cerebral edema. So CKRT can be beneficial because it corrects very slowly. And if the patient has severe cardiorespiratory arrest and you need ECMO, you can combine it with CRRT. So this is how a typical CRRT prescription looks like. And the main difference compared to SLED and CRRT is that in the dialysate column, you see SLED is around 300 ml per minute. In CRRT, it is only 1000 ml per hour. So it translates to 60 ml per minute. So it is a very slow form of therapy. And there is convection which is present in CRRT, but there is no convection in SLED. So middle molecules and inflammatory cytokines can be theoretically removed. Still, we do not find any practical application in many studies. And you can remove around 36 liters of fluid per day in CRRT and supplement it with 36 liters of fluid. So what are all the studies we have got? There was one randomized controlled trial by Schwenger. He compared 232 patients, and finally he did not find any difference in 90 days mortality, ICU stay, hemodynamic instability, and cost was lower in SLED. And another trial, it was non-randomized, and again there was no difference in the 30 days mortality. So theoretically, when you look at it, CRRT will be very good. There will be less hemodynamic stability, but practically we have not found any difference until now. And there was one meta-analysis also which found that there was no difference in the time to renal recovery or mortality. So this is the cost benefit analysis. CRRT is very costly, it goes through the roof, and SLED is very cheap, and benefit is with CRRT it is very minimal compared to SLED. So what do guidelines say? Guidelines say, KDIGO says with acute brain injury or raised intracranial pressure you do CRRT. In severe hemodynamic instability you do CRRT. So I'll go through only one case. So there is one patient with end-stage kidney disease with severe obesity and height of 194 centimeter. He had a AV fistula, he had a myocardial infarction, and he developed cardiogenic shock, and he has refractory shock, and he is needing multiple inotropes, and his AV fistula is not functioning properly with severe uremia. So what do? If he comes to the emergency, so you can't do a dialysis because he has severe hemodynamic instability, and whether you can use the AV fistula for needling for CRRT, you can't, because he has severe hemodynamic instability and fistula can fail at any point of time. And will you put his right IJV is thrombosed in the case, so will you put a left IJV or femoral? Actually, there is no difference in the infection rate in femoral catheterization and left IJV, so you can use both. But in this case, since he is massively obese, it is difficult to cannulate the femoral catheter in massive obesity, and there is also slightly high infection rate in the obese patient. So it is better to put a long catheter, that is 24 centimeter catheter in the left IJV. So this is how you do CRRT. If the patient has indication for renal replacement therapy, and if he has cerebral edema, you do CRRT. And if there is no cerebral edema, you can, and if he has multiple inotropes, you can do CRRT. If there is no multiple inotropes needed, you can do SLED. If there is no indication for renal therapy, there is no confusion. So take home message is that SLED is non-inferior to CRRT, and usage depends upon experience, availability, and the financial condition. And if there is specific indication for CRRT like hemorrhage and cerebral edema and liver failure, you can use CRRT. Thank you.
Thank you so much, sir, for the wonderful presentation. I request Dr. Karthikeyan Perumal, sir, to felicitate Dr. Mahendra Varman, sir.
Thank you, sir. Thank you. Thank you.
Next item, tumor targeting title, Mass of Healing Rays. Dr. Karthikeyan Perumal, oncologist, to deliver a speech on tumor trouble and overview of oncological emergencies.
Thank you. Thanks, Sai sir, for giving me this opportunity, and thanking Kamakshi Memorial Hospital. So, I'm a clinical oncologist at Dr. Kamakshi Memorial Hospital. So, in view of time, let me go through brush through the slides. The slides, number of slides are more. So, I'll be spending only little time. And any doubts, I'll be happy to answer. So, what is an oncological emergency? An oncological emergency is an acute life-threatening condition in a cancer patient that has developed directly or indirectly as a result of malignant condition. Okay? It should be related in some way. So usually it's surgical or medical. Surgical is usually obstructive or perforation. Yeah, close. Okay. So, so it can also be classified as a metabolic or structural. So the subclassifications are non-structural emergencies are metabolic, neurologic, cardiovascular, hematologic, or infectious. So the same thing. So what are the metabolic emergencies? Most common is hypercalcemia, tumor lysis syndrome, or SIADH, syndrome of inappropriate antidiuretic syndrome. Neurologic, it can be spinal cord compression or brain metastasis or raised ICT, intracranial pressure. The cardiovascular can be malignant pericardial effusion or superior vena cava syndrome. The hematology can be hyperviscosity due to dysproteinemia, hyperleukocytosis or DIC, disseminated intravascular coagulation. Infectious, it can be due to neutropenia, neutropenic fever or septic shock. So a patient usually visits the ER for symptoms caused by the malignant disease, or the symptoms or complications caused by the cancer treatment, or sometimes unrelated to the malignant disease or treatment. Usually what happens is, the patient if a cancer patient visits the ER, usually they are in advanced stage of the disease, or the patient in advanced or terminal stage of the disease, that frequency of ER visits keeps increasing. So the emergencies in cancer patients usually, once again, it's structural, metabolic, or secondary to complications related to the treatment. So basic questions: what oncology emergency is characterized by hyperuricemia, hyperkalemia, hypocalcemia, renal failure? Any guess? Yeah, very good. So the same thing, 50-year-old metastatic CA breast with onset of acute back pain, motor weakness, decreased gluteal sensation. So we think we consider spinal cord compression. So we give DEXA, should be followed by what? Radiation oncology, neurosurgery, both, or wait for the MRI. We'll find out. So the same thing, stones, bones, groans, thrones, well known. Yeah, very good. So let's go to the surgical emergencies. The cancer patients can experience symptoms of obstruction of different structures. Number of obstruction are benign in nature, not caused by the tumor mass. Perforation, regardless of the treatment, perforation of a GAT with concomitant infectious complication is a serious life-threatening emergency with 100% mortality if unintervened. There is a high risk of spread of tumor cells into the peritoneal cavity as well. So the other surgical emergencies, it can be bleeding or pathological fractures. Bleeding can present as hematemesis, hemoptysis, hematochezia, melena, hematuria, vaginal bleeding, ecchymosis, petechiae, epistaxis, or ulcerated skin lesions. Pathological fractures usually caused in primary bone tumor or metastasis. Metastasis of bone usually occurs in most malignancies, solid tumors, like lung, prostate, breast, kidney, thyroid, or even hematological malignancies, especially multiple myeloma, or treatment, prostate treatment, androgen deprivation therapy can cause osteoporosis. So the initial approach to any acutely ill cancer patients, in general, cancer patients presenting with acute emergencies should be approached in the same way as those without cancer. The structural and obstructive oncological emergencies, once again, SVC syndrome, spinal cord compression, pericardial tamponade, airway obstruction, ICT, urinary obstruction, or hemoptysis. So once again, the metabolic emergencies or treatment-related emergencies we'll see in detail in other slides. So the first assessment should be quick and must include the main complaint or leading symptom, focus history, baseline vital signs, and rapid overall physical examination. Comprehensive assessment, it depends on the clinical picture. The acute event may be due to tumor itself, treatment given, or it may be related to new or pre-existing condition, which is unrelated to the tumor. So these three things should be kept in mind. Oncological emergencies need not be due to tumor alone, it can be due to the treatment as well. So going to the individual emergency, structural or obstructive oncological emergencies, it's a SVC syndrome. Once again, it's a long list. Let me go to the slides. So First obstructive symptom, SVC syndrome. It results from partial or complete obstruction of the blood flow through the superior vena cava to the right atrium, causing severe reduction in venous return from the head, neck and upper extremities. The obstruction may be due to compression, invasion, thrombosis or fibrosis of the vessel. The syndrome, it was classically considered as an emergency, but due to various understanding, we have come to a conclusion it's not life-threatening. We can wait for the pathology to arrive, then intervene. Till then, we can manage medically. So the SVC syndrome, it is caused usually by malignant tumors such as lung cancer, lymphoma, and metastasis to mediastinal metastasis in more than 90% of the SVC syndromes. Lung cancer, particularly small cell and non-small cell, especially non-small cell squamous cell, account for 85% of the cases. Malignant lymphomas, mainly non-Hodgkin's lymphomas, are the next cause other than lung cancers. The Hodgkin's disease usually involve mediastinum, but they rarely cause this syndrome. So usually it's a non-Hodgkin's lymphoma. Other primary mediastinal tumors like a thymoma, germ cell tumors account for less than 2% of the SVC syndrome. Non-malignant causes are rare, including retrosternal goiter, sarcoidosis, tuberculosis, mediastinal radiation, idiopathic fibrosis. Another increasing cause is frequent long-term central venous catheter in a patient with cancer. The sudden obstruction, although very uncommon, is a real emergency. SVC syndrome developing over time is not an emergency or not an acute emergency because the patient would have developed the bypass vessels. The sudden obstruction may include rapid increase in intracranial pressure leading to brain edema. However, SVC syndrome most often develop insidiously over weeks. So let me go to the next slide. The signs and symptoms we all know. Neck and facial swelling, particularly around the eyes, dyspnea and cough. Head fullness, pressure sensation are common. Hoarseness, headache, nasal congestion, epistaxis, hemoptysis, dizziness, dysphagia and syncope can also be seen. Symptoms may get worse if the patient bends forward, stoops or lies down. Typical symptoms include venous distension in the neck and thoracic walls, facial edema and plethora, proptosis, stridor and arm edema. So the diagnosis of SVC is mainly clinical. CT scan is most useful radiological study. The empirical treatment with radiation before a tissue diagnosis has been can be done, but it was once upon a time it was routine practice, but now it is not being practiced. We wait for the tissue diagnosis. So superior vena cava syndrome. The initial measures include supplemental oxygen, diuretics, head and elevation, corticosteroids, avoiding IV catheters in upper limbs. Then chemotherapy is usually preferred in malignant lymphoma or small cell cancer. Radiation is considered to give a rapid response, but no more. With a lot of researchers, chemotherapy and radiation, they are considered to give equal result. So the most patients will experience significant response with the disappearance of all clinical manifestations within 1 or 2 weeks. Even today, radiotherapy remains the main option, but not for chemo-insensitive tumors. So these are all basic anatomy. I am not going to go through in view of time. So I am rushing through the slides. So the baseline is the treatment options are radiation or chemotherapy depending on the tumor pathology. The steroids, intravascular stents in case of fibrosis or thrombus and thrombolysis. So the pericardial tamponade, it occurs by two mechanisms: obstruction of the lymphatic drainage or excess fluid secretion from the tumor nodules on pericardial surfaces. The 2/3 of the patients are asymptomatic. In symptomatic patients, shortness of breath, chest pain, orthopnea can happen. So it's usually life-threatening. Acute pericardial tamponade is life-threatening. The intervention is pericardiocentesis with a sclerosing agent like a bleomycin or tetracycline. Spinal cord compression, it usually happens as a first manifestation in 10% of the patients or in 10% of all cancer patients. The delay in starting treatment can cause irreversible paraplegia or depending on the site of the involvement. So usually they are treated by high doses of corticosteroids or dexamethasone followed by radiation or surgical intervention with the radiation. I am brushing through the slides. So another oncological emergency is intracranial tension. Raised intracranial tension may be caused by brain metastasis, usually associated edema, any primary tumor or metastasis associated edema. The picture may not be different from intratumoral bleeding. Patient with melanoma, choriocarcinoma, clear cell carcinoma of renal origin frequently present with bleeding. These malignancies cause a bleeding brain metastasis or hemorrhagic brain metastasis. So usually MRI is a better technique to visualize the edema on the metastasis or primary tumor, but CT being easily done, it has to be considered as a first choice. So the management of intracranial metastasis, brain metastasis, it has evolved a lot of modalities are available. Though we all know that whole brain radiation is a standard, but now there are several other like radiation with surgery with the radiation or radiation followed by surgery, several different combinations are available. Urinary tract obstruction can be due to gynecological or urological tumors. So the way to find is clinically flank pain with anuria, sometimes alternating with polyuria. Renal ultrasound or percutaneous nephrostomy is an immediate, it gives immediate relief. Hemoptysis, I am brushing through the slides in view of time. Hemoptysis is defined as expectoration of volumes of blood in a single episode of 100 ml or more than 600 ml of blood in 24 to 1 to 2 days. Lung cancer accounts for a large proportion of patients with hemoptysis. So non-malignant conditions that can cause hemoptysis are fungal infection or thrombocytopenia or other coagulation disorders. Thrombocytopenia can be caused by chemotherapy as well. So in case of massive hemoptysis, the airway should be protected and the site of bleeding should be identified. So in case of uncontrolled bleeding, bronchial artery embolization can be done or a bronchoscopy directed treatment can be initiated. So coming to the airway obstruction, it can be associated with the tumors of posterior third tongue, oropharynx, thyroid, trachea, bronchi or lungs. The presentation depends on the severity and location of the lesion. So the diagnosis is number one clinically, ENT examination, chest X-ray, CT scan, pulse oximetry, bronchoscopy. The treatment can be stenting, laser therapy, radiation and or chemotherapy. So let me brush through the slides. So if the airway obstruction is due to upper airway obstruction, we can consider tracheostomy. If it is a lower airway obstruction, we need to take the help of the pulmonologist. The infection in cancer patients frequently, patients with cancer, they often have malnutrition and immune deficiencies due to the disease or the treatment itself. So they are prone for infection. So it has to be managed just like any other infection. It may be difficult to treat it, but we have to actively manage it. Coming to the metabolic emergencies, it can be, most common is hypercalcemia, syndrome of inappropriate ADH secretion. The hypercalcemia is the most often paraneoplastic syndrome and a serious emergency leading to morbidity and mortality. It occurs in 10% of the solid tumors, usually hypercalcemia more than 12. It indicates their lifespan is short, not more than 3 months usually, or maybe 4 months or 5 months, not beyond that. The mechanisms are cancer-related hypercalcemia are produced due to bone metastasis, increased parathyroid hormone-related proteins, and calcitriol secretion. So mostly we take the endocrinologist's opinion to rule out other causes and to ensure it is due to parathyroid hormone related peptides or calcitriol secretion. So they are usually managed with adequate hydration and calcitonin and bisphosphonates. So coming to the syndrome of inappropriate secretions, usually they are asymptomatic. Presence of clinical manifestation is directly related to the hyponatremia. So any hyponatremia in a cancer patient, it has to be investigated properly. Early changes include anorexia, depression, irritability, lethargy, muscle cramps, weakness. If specific therapy is not available, tumor has developed resistance to the chemotherapy, water restriction and demaclocycline should be considered. Hyperviscosity syndrome, usually caused in hematological malignancies, Waldenstrom macroglobulinemia, multiple myeloma. So the treatment is usually plasmapheresis. The other diseases related to hyperviscosity are due to increased leukocyte count, leukemia, myeloproliferative states, leukocytosis. So the symptoms are related to the respiratory tract, CNS and vascular causes or fever. So it is usually treated by hyperviscosity caused by WBCs are treated by induction chemotherapy, leukophoresis or hydroxyurea. Those caused by proteins are treated by plasmapheresis. So the treatment related emergencies, it can be exacerbation of the chemotherapy drug, tumor lysis syndrome, anaphylactic reactions due to chemotherapy or hemorrhagic cystitis. So we should ensure chemotherapy is difficult to administer, in the sense if even a small amount of medicine extravasates, it's a real nightmare for anyone. So the tumor lysis syndrome is caused by destruction of large number of proliferating cells. It is nothing but as multiple electrolyte disorders like hyperuricemia, hyperkalemia, hyperphosphatemia, hypocalcemia, lactic acidosis, all leading to acute renal failure. So the symptoms, of course, you know, it's non-specific. So all the metabolic abnormalities should be managed actively. So it includes, the active management includes adequate hydration and maintaining a good urine output. Management of other like the patient is having acidosis, you give a bicarbonate, and usually xanthine oxidase inhibitor, allopurinol, or recently RAS buricase. They help in preventing or postponing the or reducing the quantity of tumor lysis syndrome. Anaphylactic reactions can happen as with any medicine, can cause angioedema or urticaria. So it has to be managed just like any anaphylaxis reaction of wheezing, GA symptoms or cardiovascular. So the another dreaded complication of chemotherapy is hemorrhagic cystitis, usually by cyclophosphamide or ifosfamide. So we usually prevent it with Mesna. We don't let it happen. If it happens, it has to be managed with adequate hydration, the urology consultation. Usually the cystectomy is rarely required. So in summary, the general principle is a cancer patient presenting with acute emergencies should be approached in a similar way to those without cancer. The structural and obstructive emergencies are SEC syndrome, spinal cord compression, raised ICT, urinary obstruction, pericardial tamponade, acute airway obstruction, massive hemoptysis. Metabolic emergencies are hypercalcemia, SAADH, hyperviscosity syndrome. Treatment-related emergencies are drug extravasation, tumor lysis syndrome, anaphylactic reaction, or hemorrhagic cystitis. So in conclusion, the first assessment should be quick and must include the main complaint or leading symptom, focused history, baseline vital signs, and rapid overall physical examination. Comprehensive assessment depending on the clinical picture, the tumor itself, treatment given, or any other non-existing or newly pre-existing condition unrelated to cancer. So,
excellent talk, big applause. எனக்கு தெரிஞ்சு இந்த உலகத்திலே ஆன்காலஜிக்கல் எமர்ஜென்சிஸ் 20 மினிட்ஸ்ல முடிச்சது சார் தான். He had 50 slides. ஏமா இன்னும் லவுடா தான் அடிக்கலப்பா, சாசா பண்ணா எல்லாம் ஒரு வண்டி எழுந்து உட்கார முடியுமா? பிரியாணி எஃபெக்ட்ல பாதி குறக்கமா கேக்குது அந்த வேலை நடந்து போகும்போது. Thank you sir. Thank you sir.
Thank you so much.
Thank you sir. I would like to call Dr. Sai Surendra to felicitate Dr. Karthikeyan Perumal.
Thank you so much. Thank you. Thank you. No. Thank you, sir. Thank you so much.
So for the next session, I would like to call upon the life flow specialist, the stone breaker, laser legend Dr. Bharat, the urologist to deliver a speech on the red flags below the belt, acute urological emergencies. We welcome you, sir.
ரெண்டே டாப் தான் இருக்கு. கொஞ்சம் ப்ளீஸ் ஹோல்ட் ஆன். We are planning to wrap up before 5 o'clock. So hold பண்ணுங்க. என்ன ஜெட் வேகத்துல போறாரு பாருங்க சார். எல்லாருக்கும் கல்லே வெள்ள வந்துற போகுது.
சார் கிளிக் பண்ணுங்க.
மைக் வேணாமா, இது போதுமா?
லைவ் ஸ்ட்ரீம் மைக்.
Thank you, sir. Very good afternoon to one and all present here. At the outset, I'd like to thank the Department of Emergency Medicine and the management of Kamakshi Memorial Hospital for the opportunity. Why is this talk important? It's because urology is one field where the diagnosis can be made in 90% of cases in the emergency department itself. And when you give the call to the consultant, you will have the diagnosis 90% of the time. So it will save a lot of time for the consultant, and when your call has the particular requirements or the patient details, it is very easy for us to decide on the type of emergency. So the talk is on red flag symptoms. We will start the talk with symptoms, go on to the signs, and regarding the particular patient groups. So when we take a look at the symptoms, the patient would mostly come to you with complaints of fever, pain in 80% of cases. Very rarely you will find symptoms such as anuria, hematuria. Trauma patients have a small fraction. Patients may present to you in the middle of the night with scrotal pain, phimosis, paraphimosis, or very rarely priapism. We'll take a look at each of these diseases in a short while. So what are the signs that you have to look for during examination? So the patient may have fever, may have signs of shock, patient may be in sepsis, patient has tachycardia or an altered mental sign. So we have the QSOFA score or the NEWS2 score, which is a latest score. You can use them to assess the patient and find out the patient is in sepsis. The other symptoms would be when patients with general complaints and also with trauma, patients may have a flank tenderness with guarding, he may have a distended abdomen, the bladder may be full, the patient may have hematuria, the patients may have ecchymosis over the loin, the suprapubic area, and also the perineum in cases of trauma. Patients may have blood at the urethral meatus. They may present to you with a scrotal tenderness, inability to retract the prepuce, or they may even come to you with an erect penis in the middle of the night. So what are the high risk populations? So these are red flag groups, right? Even the smallest of symptoms in these category of patients warrants emergency care. So these are pediatric patients who have undergone trauma. They have a high risk of developing intra-abdominal organ injury. Next is a subset of pregnant patients. Even infections or small stones can cause a lot of symptoms and may be harmful to the fetus. Patients with pelvic fracture, they are more prone to develop bladder and urethral injuries. Patients with a solitary kidney, they have a decreased renal reserve, and even small stones can cause anuria and elevated renal parameters. And finally, a subset of patients who have undergone recent urological surgeries. So you can diagnose a lot of symptoms. This is just a tabular column to show that each organ can present with a multitude of diagnoses in the emergency department. But the most common subsets are infection, stone disease, benign conditions such as polycystic kidney disease or a renal vein thrombosis that can present with pain, malignancies like renal cell carcinoma or a bladder tumor which may present with clot retentions, trauma patients, and very occasionally pheochromocytomas who may present to you with a hypertensive emergency. So ultrasound is rightly called as the stethoscope of urology, and a bedside focus scan would lead to diagnosis in 90% of cases. Just put the ultrasound probe over the kidneys and the bladder, 90% of your diagnosis will be made except for in trauma. So we'll talk about the first subset of patients, which is infection. Most primary infection is the upper tract infection involving the kidneys. There are two diagnoses, emphysematous pyelonephritis and pyelonephritis. So pyelonephritis is a condition where the kidneys are infected, and when this infection is due to a gas-forming organism, it is called as emphysematous pyelonephritis. Emphysematous pyelonephritis is a surgical emergency and has to be immediately dealt with by drainage. Right? So renal abscess can also cause issues. You will need to drain it or put in a DJ stent. So urosepsis recognition here is a very important red flag. Use the QSOFA score or the NEWS2 score. Classify these patients appropriately. Don't term a urosepsis patient as UTI and admit in the ward, or don't admit a UTI patient, term them as urosepsis and admit them in the ICU. Both of them are equally dangerous, right? So we'll move on to the next subset, which is lower tract infections. So the same emphysematous pyelonephritis can happen in the bladder due to gas-forming organisms. This is called emphysematous cystitis, where you will find air inside the urinary bladder. Just put in a catheter and start antibiotics. That will do the trick. Fournius gangrene again is a necrotizing fasciitis involving the genital organs. It's a very rapidly spreading infection, and hence early debridement causes less loss of tissues. Finally, epidermolysis. Though it is an infectious etiology, patients can come to you in the middle of the night. You will not dismiss any case as epidermolysis unless an ultrasound is done and the vascularity of the testis is confirmed. We have three stone-based emergencies. First of them is a solitary kidney with a stone. So he or she has a single kidney which is obstructed by a calculus. Patient may be anuric and in pain. Just don't dismiss those patients as having a simple calculus, because that kidney is the sole urine producer. So you will have to act as emergency as possible. The second one is what is shown in the images here. Bilateral obstruction. One stone may have been stuck for a long time. Patient may develop obstruction on the opposite side. When he lands up, he will have two stones on either side. Again, no urine, anuric with elevated renal function tests. We will have to emergency stent the patient, and that will reverse the urinary issue. Finally, it is a urethral calculus. You can see a CT of the penis with the calculus in the penile urethra. These patients will present with severe dysuria, no urine output. We will not dismiss this as strangury. A simple CT scan will show us a full bladder with a calculus stuck in the prostatic urethra. Adequate lubrication and a gentle attempt at catheterization will usually dislodge the stone back into the bladder. Once the catheter is in, the patient is relieved of pain, and then we can handle him as an elective case the next day and break the stone. If a single attempt at catheterization fails, you are not able to pass in a catheter, do not disturb it anymore, because that can lead to urethral injury. Call in the urologist at any point of time. We'd be happy to come in, put a scope, push the stone into the bladder, break it off and remove it. The third subset of patients are trauma patients. Blunt and penetrating trauma to the abdomen. 10% of these patients may have urological trauma, bladder, kidney and the ureters. The red flag presentations here would be patients who have had a rib fracture, which can be concomitant with a renal injury, a pelvic fracture that can occur along with a bladder or a urethral injury, a microscopic or gross hematuria in these patients. Patients may develop urinary retention or anuria. This history has to be specifically asked if the patient is voided post-trauma. The patients may be in hemodynamic instability. A large retroperitoneal bleed will be a concealed bleed. It will not show up unless a CT scan is done. So the key investigation here would be a contrast enhanced CT. Identify patients in shock, immediately resuscitate them, do an imaging and shift to the OR if needed. So the imaging and trauma assessment in renal trauma, the primary investigation would only be a CT scan with contrast. A large urinoma may sometimes happen because of avulsion of the pelvis or the ureter, where you will have a large urinoma inside the abdomen or into the retroperitoneum. There are two types of bladder injuries, intraperitoneal rupture and extraperitoneal rupture. Intraperitoneal rupture is an emergency which has to be dealt with surgically, while an extraperitoneal injury, only a catheter and antibiotics may do the job. In urethral injuries, patient may present to you with blood at meatus. Whenever you see blood at meatus and you are going to try in a catheter, make sure you are very gentle. And if the catheter passes through in the first attempt and you get urine, be very happy, retain the catheter. You are not able to pass in the catheter, don't worry, call us in, we will try to put an attempt, and even if we cannot, we will put in a suprapubic catheter, wait for 3 weeks, assess how the urethra is, and then proceed with a definitive repair. The next trauma is a penile fracture. Most commonly happens following road traffic accidents or sexual intercourse. Patient may present you in the middle of the night with a swollen penis. This is called as the eggplant deformity. You will find a swollen penis. Now, the differential diagnosis here would be a penile cellulitis. Even patients with scrotal and penile edema, you will have the similar appearance. Even patients with infection, you will have a similar appearance. History would classically let you know what it is, and if the patient has a history of sexual contact along with a sudden detumescence, which is a loss of erection and the swelling, it is classical of a penile fracture. You will do an ultrasound, we localize the area of the fracture, and then once the diagnosis is made, we will take the patient to the OR, repair the defect with a few sutures, and the patient would get back his erection. Patients who have not had this corrected for a very long time will have erectile dysfunction. Next subset of patients who will present in the middle of the night could include frenular tears following forceful sexual acts or masturbation. Their frenulum in the penis may tear. It will cause a lot of bleeding because the frenular artery is highly vascular. Usually gentle compression for 5 to 10 minutes helps. Once it doesn't, then you can call us in, we will come in and coagulate the vessel, that will do the job. Finally, testicular avulsions may happen after road traffic accidents where you will have an exposed testis. We will do an Doppler scan to confirm the vascularity of the testis. If the testis is vascular, we will retain it and just put in sutures. If the testis is not viable, we will go in for a orchiectomy. The next subset would be a set of patients who present to you with anuria, no urine output. Now, the simple way to come to a diagnosis is to use the ultrasound, as we had mentioned. Put in the ultrasound probe over the kidneys and the bladder. In case you find dilatation of the pelvic ileal system or a full bladder, refer it off to urology. You find that the kidney is not dilated, the bladder is empty, call in nephrology. So once you call us in, we will check if the obstruction is in the upper tract or the lower tract. Upper tract would involve the ureters, where you will find hydronephrosis. We might need to take the patient up for stenting or for a percutaneous nephrostomy, depending on the patient conditions. If it's a lower tract, could be probably due to benign prostatic hyperplasia or prostatic issues or strictures. Try passing in a catheter. You're not able to pass in a catheter, put in an SPC and salvage the patient for the time being. The next diagnosis would be testicular torsion. We had initially talked about epidermoorchitis. There are a lot of reasons for scrotal pain. Two of them that present to the emergency would be epidermoorchitis and torsion of the testis, while the other one can be managed with antibiotics. Testicular torsion is a surgical emergency, and 6 hours is the time period that has been set for detorsion, right, to rotate it back to its original position. Usually these patients will present with acute onset of pain. They may have symptoms, and when you examine them, you may find the testis in a bit of a higher position with an absent cremasteric reflex. Whatever your examination findings are or the patient symptoms are, don't bother, ask for an ultrasound Doppler, irrespective of whether these symptoms are not. Ultrasound Doppler is the only accurate test and also needed for medico-legal purposes. Once the testicular vascularity is in any doubt, it is better to go ahead with the surgical exploration and fix both the testes or do an orchidectomy if the testis is unviable. A patient may present in the day or in the middle of the night with an erect, painful penis. So he may complain that he has had an erection for a very, very long period of time and it has got to a point where it is painful. Or the patient may tell he has had an erection for a long time, but then he has no pain. Both of these are called priapisms. We have two types, the ischemic variant and the non-ischemic variant. In the ischemic variant, the patient presents with pain. The thing to be done in the emergency department is to ask for the history, any history of trauma, sickle cell disease, leukemia, use of the vasoactive drugs like phosphodiesterase inhibitors, recent penile Dopplers where the patient has had injection of papaverine. These can lead to priapism. So with the history, you can arrive at a diagnosis here. In the ischemic variant, you can put in a needle into the cavernosa as shown in the picture at around 45 degrees, aspirate the blood. You see dark venous blood, send it for blood gas analysis. The blood gas analysis would reveal very low oxygen pressures and high CO2 pressures, pH less than 7.25, right? So if that is the diagnosis that is made, this is a case of ischemic priapism. You need to aspirate all the blood that is inside the penis to save the corporal tissue from going in for permanent ischemia. Call us in, we will put in a needle, aspirate the blood on both sides and wait until the pain and the symptoms resolve. We may have two prepucial emergencies, one where the patient cannot retract the prepuce and the second where the patient cannot protract it back again. The first one is phimosis. A small dorsal slit and a catheter will do the job. In the second case with paraphimosis, you need to pull it back. There are a few techniques, but the simplest of them is to give a small dorsal slit so that the opening is a bit enlarged and then pull it back. So these diagnoses can come very late in the night after sexual intercourse also. So finally, to the post-operative complications. Post-operative patients may end up with 4 different complaints. First of them is fever. Never dismiss a post-operative urological case that lands up with fever. They are candidates for going in for urosepsis. So always treat them as an emergency, admit them. We are more than happy. Post-operative hematuria. These are usually patients post-PCNL, post-TURP procedures. Patient may have a large bladder clot. Put in the ultrasound probe, check if the bladder is too full and distended with a clot, which may need urgent evacuation. Other conditions such as carcinoma of the bladder, RCCs can also land up with hematuria. Gynecological cases with anuria, very rarely post-pelvic surgeries or gynecological surgeries, patient may have ureteric injuries and the patient may present with anuria. These patients require urgent surgical exploration. Finally, a patient who has had a catheter attempt at an outside center may come to you with a repeat call for catheterization. A gentle attempt can be tried with adequate lubrication. If the catheter doesn't go in, please do call us early. We will try once with a flexible cystoscope or put in a suprapubic catheter. Finally, the other complications are stent migration, stone disease with recurrence. Post-nephrectomy patients can come to you with a slipped clip and a lot of hemorrhage, clot retention in BPH patients, and iatrogenic injuries that may happen following any surgical procedure. So finally, the key takeaways, please get a proper history and an examination and triage these patients, diagnose them properly, get a rapid imaging, ultrasound bedside or a CT scan, control the source of infection when you diagnose infection in these patients, and as always, the emergency department, urology, ICU and the radiology department have to work hand in hand to have better quality for these patients, quality of treatment for these patients. Thank you. Thank you.
Thank you so much, sir, for the informative section.
Thank you, sir.
I would like to call upon Dr. Neeraj to felicitate Dr. Bharat, sir.
Thank you, sir. Thank you, sir. Thank you, sir.
Next, I welcome the family guardian, the heart of community care, jack of all Jews, wellness wizard, Dr. Ramya, family medicine, to deliver his speech on emergency medicine and family medicine, an emerging synergy.
By 15-20 minutes.
Good evening, everyone. First of all, I would like to thank Dr. Sai Surender sir and his ER team and the management of Kamakshi Memorial Hospital for providing me with this opportunity to meet you all young budding emergency physicians this evening and to enlighten you with a few thoughts from my side. So I am here today to tell you about the emerging synergy between emergency medicine and family medicine. So the synergy between family medicine and emergency medicine is bridging between acute care and the continuity of care. These two specialties are two different specialties but one patient journey. Family medicine focuses on holistic, continuous long-term care, while emergency medicine focuses on acute stabilization and life-threatening conditions. So the synergy intersection, what happens is that early recognition of symptoms and signs and timely referral, which reduces mortality and morbidity of the patient, and post-emergency follow-up will be adequate so that complete recovery and not just survival is ensured. So shared responsibility improves patient outcomes, healthcare efficiency, and also patient trust. So primary care is the first line of defense. Primary care is provided by emergency physicians in tertiary care setups, while emergency care and primary care is provided by family physicians in the rural setups. So the most common symptoms usually encountered can be simple chest pain, which includes a possibility of an acute coronary syndrome, sudden neurological deficit, which includes a possible stroke, severe abdominal pain, which includes possible appendicitis and perforation, breathlessness, which includes asthma exacerbation, pulmonary edema, and also altered sensorium, which might be due to sepsis or hypoglycemia. So I give you a scenario. A 52-year-old diabetic patient presents with mild discomfort to the clinic. The GP identifies some atypical symptoms like the pain radiates to the neck or the jaw, alongside risk factors like diabetes and age. Immediately an ECG is done. This is the ECG. So this shows some non-ST elevation MI, and immediately the patient was referred to the tertiary center. So early suspicion prevented delayed diagnosis and severe complications. Early stabilization is just the beginning. True care extends beyond ABCD. It requires identifying the underlying cause, coordinating with the family physician, ensuring proper discharge planning, and arranging follow-up. A young patient treated for acute asthma attack in emergency department, stabilized and discharged. So without follow-up, the patient comes for recurrent attacks and readmission. So when there's a proper family physician involvement, the trigger management is followed up, medication optimization is done, and long-term control is better. So I would like to talk about 4 scenarios in geriatric emergencies. The first one will be falls in the elderly. Falls in the elderly represent a multifactorial web. This causes injury, hospitalization, and even mortality in the elderly. So the causes can be intrinsic causes, extrinsic causes, and medication-related causes. Intrinsic causes are gait and balance-related disorders, muscle weaknesses like sarcopenia, visual impairment including cataracts, glaucoma, cognitive impairment like dementia, delirium, and chronic diseases like Parkinson's and stroke. Whereas extrinsic causes are poor lighting, slippery floors, improper footwear, environmental hazards, and medication-related can be sedatives, antihypertensives, anticholinergics, polypharmacy. All these factors can lead to a fall in elderly. So how the patient presents to you after fall? There can be the red flags are loss of consciousness, sometimes chest pain with palpitation, sudden weakness and dizziness and syncope. Signs can be bruising, fracture, shortened externally rotated limb and neurological deficits. The question you should ask is that was it any mechanical or any medicine induced? And in the emergency department, the investigations to be ordered, vital investigations are to check the vitals, glucose, complete blood count, urine routine, and renal function test. Imagings may be X-ray of the affected part, CT, brain, ECG, and also to check for an orthostatic BP drop. And management, multidisciplinary team management includes multidisciplinary GP follow-up, medication, review, physiotherapy, home safety. This is post-discharge. Immediately fall involves the ortho team or the surgery or neurosurgical team. So case insight, an 80-year-old woman with recurrent falls found to have antihypertensive overuse causing postural hypotension. GP adjusted the medications. What antihypertensive causes postural hypotension most commonly? Most commonly, it is alpha blockers. It is the first dose hypotension adjusted most commonly, and also diuretics cause postural hypotension. So the second scenario which I would like to take is aspiration pneumonitis. Aspiration pneumonitis is a chemical, not infectious injury. It is rapid in onset. It is a rapid onset respiratory compromise caused by chemical injury to the lungs from aspirating gastric acid, vomitus, or oropharyngeal secretions. The key risk factors are altered consciousness due to alcohol intoxication, sedation, anesthesia, seizures, or neurological disorders like stroke or Parkinson's, elderly patients, dysphagia, gastroesophageal reflex, and poor airway protective reflexes. Crucial distinction is that supportive care is the mainstay. Antibiotics are not routinely indicated unless secondary infection is suspected. So managing the acute aspiration event, symptoms typically develop within hours of aspiration event. Within hours, there's sudden cough, breathlessness, wheezing, in severe cases, there will be hypoxia, cyanosis, and altered mental status. The signs will be tachypnea, tachycardia, and also crackles on auscultation. And immediate action to be taken will be to do a pulse oximeter evaluation, ABG to look for hypoxemia, full blood count to look for leukocytosis, and chest X-ray to look for infiltrates in the dependent lung zones, and also a CT chest. Airway protection, including suctioning and intubation, will be necessary. Oxygen therapy, and also to elevate the head end of the bed to 30 to 45 degrees, and assessing swallowing and avoiding over sedation. So case scenario, a post-seizure patient develops sudden hypoxia, likely aspiration during the unconscious state. So managing rapidly with airway protection and oxygen support, and this prevents severe pulmonary complications. The third one will be urosepsis. Urosepsis represents diagnostic trap in the elderly. So sepsis is originating from the urinary tract. The common and serious cause of septic shock is urosepsis. So pathogens commonly involved are E. coli, most common, Klebsiella, and Proteus. Risk factors include advancing age, diabetes mellitus, indwelling catheters, benign prostatic hyperplasia, and also immunosuppression. Usually the typical symptoms will be fever, dysuria, frequency of urine, and flank pain. But in elderly, it's always not like that. It can be altered mental status like confusion or delirium, general weakness, falls, and reduced oral intake. Fever may be initially or entirely absent. So executing sepsis in the golden hour, what we should do? Immediate recognition of septic shock, like what are the signs to be recognized? Altered consciousness, multi-organ dysfunction, oliguria, and hypotension. The investigations to be sent include serum lactate, blood cultures before antibiotics, urine routine and culture, full blood counts, and CRP, and also an ultrasound abdomen to look for obstructive uropathy. And management include within the first 1 hour, you should have started IV fluids, that is crystalloids, broad spectrum IV antibiotics in less than 1 hour, and source control like removing or replacing an already existing catheter or to relieve obstruction, and also to provide oxygen or vasopressors if hypotensive. So an 80-year-old patient presents with confusion and low BP, no fever, but urine shows infection. He's been diagnosed to have urosepsis, managed rapidly with IV fluids, antibiotics, and catheter changed, and the patient improves. So the last one will be talking about delirium, decoding delirium. The features are acute fluctuating disturbance in attention and cognition, develops over hours to days. It is often reversible but can be irreversible also. The causes of delirium include drugs like sedatives, anticholinergics. E is electrolyte imbalance. L is lack of drugs, withdrawal of alcohol and benzodiazepines. I is condition is missed, and the patient can also have a spectrum of both, which is a mixed variety. So how do we approach a patient to delirium? Initially, we have to check the ABCD and glucose immediately. Labs like full blood count, urine examination, ABG, and chest X-ray, ECG are done. CT brain if trauma or stroke is suspected, provide oxygen and IV fluids, treat infections or electrolyte imbalances. Next, the middle layer goes the non-pharmacological management like reorientation, clocks, the family presence, keeping in their own environment with adequate lighting, sleep regulation, ensure hearing or vision aids also. Finally comes the pharmacological, which is the last resort. Low dose antipsychotics or haloperidol is given only if severe agitation is persisting in spite of the base layer and middle layer actions taken. Avoid over sedation. So a case scenario, a 75-year-old admitted with sudden confusion, found to have UTI plus dehydration, treated with antibiotics and fluids, outcome delirium fully resolved after treating the underlying cause. So the geriatric cascade is that an elderly patient experiences a multifactorial fall. Immediately, this is followed by immobility and hospitalization leading to catheterization. The catheter introduces an infection escalating to urosepsis. This urosepsis becomes a systemic infection and metabolic stress triggers acute delirium. And this delirium causes altered consciousness and lethargy, resulting in unprotected airways causing aspiration pneumonitis, which in turn leads to multifactorial fall. So this is the geriatric cascade. So finally, restoring health through continuity. Primary care vigilance is that early recognition of atypical presentation and red flags prevents ED crisis, and targeted acute action. There is a ED stabilization must rapidly address underlying causes without inducing further geriatric complications, example, over-sedation. So when there's a dedicated follow-up, discharge is not the end of the episode. It is the handover back to the family physician to reverse the cascade and restore baseline health. Thank you.
Thank you so much, ma'am. Now I request Dr. Dinesh to felicitate Dr. Ramya, ma'am.
We are in the last 10 minutes, 15 minutes of the program. So in this year's USP is the next session. So how every year we have something new. Thank you, Ramya Madam, for a very wonderful presentation. So this year highlight is the next panel. I welcome our Vice President Leo sir to take up the podium. Just as a panelist, sir, please. So please put your hands for our Vice President, Professor Mr. Leo, who is the Vice President of our hospital, and he's a genius in artificial intelligence. I wanted to add this in the inauguration, but yes, sir, in the center, sir, Nagar. So sir is a very experienced person in digital technology, and sir is the one who discovered this digital nominal. So in Kamakshi, what difference we make is we have a digital nominal system in our ER which tracks all the patients coming from all the branches in our Kamakshi Memorial Hospital, group of hospitals, about 8 branches. And so when I sit in the main ER, I can track and monitor what happens in the system. So just before we start the panel, a brief outline about its how it was all created from sir.
Hello, everybody. So you want to talk about HSER?
Yes, sir. Yes.
Before that, a quick background. I head technology, and I also head operational efficiency, and I look after strategic expansion of Dr.Kamakshi Memorial Hospital. The HSER, since I look after also technology, my experience is originally technology. I worked for IBM 10 years, and then I came here for 13 years. I'm with Kamakshi for the last 13 years, officially. So right from my career, I was into technology. So the HSER, what he speaks, is hub and spoke emergency relation. That's what we call HSER. In Kamakshi Memorial Hospital, we work as a hub and spoke. We are located in Palikarnai, that's 300 bed, and in Siriseri 100 bed. And we have a Medava multi-speciality clinic. Likewise, there's Adayar, Pallavaram, and we are working towards unit in Mapata. So these small units, they work as a spoke to the nearest hub. We have two main hubs. And all these units have emergency 24/7. You see? So what happens is that the spokes establish relationship with the neighborhood and they treat emergency and they forward the emergencies to the hub. So all these were happening manually. So now what we have done is that we have automated it. So these spokes and hubs have something called HSCR where all the data, vitals, conditions are captured digitally. And even before the patient arrives, the hub, they know it already. So they get ready. And we are also working towards automating the transit part as well. For any AI implementation, for any AI use case, the first thing is data. AI is nothing but the software. I see people talk a lot about AI, and there is a big hype that exists about AI, but most of it is only because of ignorance. As of now, AI is just a software which works on the past data, predicts. That's it.
Thank you, sir. Sir. Sorry, sir, I didn't know.
So that's it, and this HSCR has this data captured and also has a dashboard, which gives various analytics, enabling the emergency physicians and the management. Thank you very much.
Thank you, sir. Please occupy the seat, sir. So I would request the first panelist, Dr. Neeraj Mangala. Please give him a big applause. He is the head of emergency medicine at MGM Mallar Hospital. So Dr. Neeraj will be speaking on AI-powered triage, improving emergency care. So next panelist, I would request Dr. Sahithya. She is a senior consultant in Kaveri Vadapalli. Welcome, Dr. Sahithya. Next, I would like to call Dr. Syed Harris, who is a senior consultant in SIMS Hospital Vadapalli, who is speaking on AI-driven diagnostics, enhancing accuracy in emergency settings. And last but not the least, our own consultant on critical care, Dr. Dinesh sir. Welcome, sir. Welcome to the panel. Sir is going to focus on ethics of AI in emergency medicine, balancing innovation, safety, and medico-legal implications. So, why this panel and why about AI? Because AI is the future. As sir says that AI works on the past modes and modules and it generates like an astrologer. Nadi Jyotirar Mari, it generates and gives a prediction. Rather, it doesn't take accountability. Am I right? So, none other than sir will be the best person to assess this discussion. So, in AI powered triage, first to Dr. Neeraj Mangala. So, my question to you will be, how will you improve emergency care through AI, and how it will be allowed to make primary triage decisions in overcrowded emergency departments?
Good evening, everyone. So, thing is like nowadays unprecedented overloads are there in the ER. So, what generally happens is when there is a shortage of staff, due to overload and all, people get tired and they do bias in triages, right? As per the researches, it has been found 20 to 33%. There's a bias in that. So if we implement AI, that will not get tired, the work will become easier. So it's like having both the sides of the coin. It says it's good if we implement, it will help us to over triage or under triage a patient, which will help us to come to a conclusion faster, to avoid the resources getting wasted. So that will be helpful for us.
Okay, anyone wants to add on this?
Can we mics?
So, like Dr. Neeraj mentioned, the fatigue bias, basically when we have overwhelmed, having 20-30 patients waiting outside. So the AI will rightly help us definitely in flagging the acute emergencies which we need to bring. But at times there are negative flaggings also. We can miss certain things. So I think AI triage is still a long way in India, but yeah, it is, I think, helping definitely in the setups where it is overwhelmed. But what do you think, sir, in setups where it is resource limited?
So what happens is, see, I'm not saying it has to replace, it is going to augment it, okay? It is going to add upon to help the people to do the work, but ultimately the human only has to do it. So what happens is, if you go with the legal implication, it's like a legal minefield, where what happens is, by chance, AI has done a triage, a sick patient, because they will not take something called as non-verbal clues, gut feeling of a patient. So those things, if the patient is not able, the AI is not able to recognize, they will do under triage and send the patient to waiting area. Patient dies there. Who will be responsible? The hospital, the software vendor, or the physician who has not even seen the patient, right? So generally what happens is, the physician is only the one, the human, has to take an answer, has to do the trial. It is going to just augment and help them to, utilize the resources. But as in India, we say we have lack of resources and all. We have to work on both the things together. Then only a robust infrastructure is required to have a wonderful AI.
Thank you. Yes, you want to add?
Yeah, I just wanted to add because so I worked in the UK before. So over there, because here we have a system where we can just directly go and see the specialist anytime. If you have a tummy ache, you just go and see the gastro directly. But there you can't actually see a specialist immediately. You'll have to go through a system to get into the system. So you need to check with the GP first. You need to get an appointment with the GP, and then you end up with the district general hospital, and then you end up with a specialist, a tertiary center. So in those areas, I think triaging is quite important, because based on the triage only they send you to where your destiny. So India, maybe it's not still come up, but in resources like in UK and all that, it's still they have a better triaging system.
You want to add anything, sir? How triage?
If I've had all the questions beforehand, I would have prepared. I came here to listen. But anyway, I'm in the panel now. If I have to put it a little sensibly, triaging means what? Triaging is prioritizing the criticality, right? Now, by what you will prioritize? You have to have some input data. The input data is the vitals and the condition of the patient if it's a trauma or something. Now, what are we expecting the software to do? When you feed in the data, it has to say whether he is a critical, a green, or whatever you want to tag, red, or black, blue, blah, blah, blah. So that tagging is rule-based, actually. It doesn't require a model to do that. AI works either with the existing data and it predicts a pattern, or it goes to the LLM models and get the knowledge which is there in that model, and it tries to help you. So which part of AI we're going to use is what we have to understand. In this case, a nurse, let's presume, is triaging. Normally a nurse triages, right? Probably in some point in time, we may have nurse agentic AIs, which means a software program which will independently take the input values from the patient and it will assess and it will give a priority. Unless excluding the trauma patients who are coming already in a very extreme stage. So otherwise, if there are stable patients, probably there will be a counter where it's an agentic counter where they can give you a thing and the vitals can be checked and it will prioritize. The moment it is prioritized, doctors are notified in the year. Maybe something like that may come. See, technology is evolving in a greater phase, but the adoption is much growing in a very slower pace. But let's see, we all have this in our mind. Let's going to work towards and see how it's going to come to us.
Thank you, sir. That was a wonderful explanation. So with this, we go to the second part of the panel, the future of emergency medicine, AI as a team leader. What do I mean by this? So there are emergency physicians in the shift. So one more emergency physician in the shift will be an AI. So I would request Dr. Sahitya to answer this. Will AI become a clinical assistant or eventually replace some of the doctors here?
So I think this has been a fear for for all of us because generally we all think that probably AI can replace humans, but in ER, I don't think it's possible. AI can never replace emergency clinicians because we need to be there present. We need to be present there because we have more empathy, sympathy. We can see what is actually going around in the ER. We have to clinically deal with the patient and also speak to the attenders, family, counsel them and all that. So none of these can be taken over by AI, but some things which can be taken over by ER, I think documentation, all of them, we've got like AI scribes now, so documentation can be taken over. A little bit of triaging can be taken over. And AI, there's lots of apps and tools which can actually deteriorate a clinically sick patient and all that. So all of those bits like diagnostic, it can help you aid with diagnostic. Like there are lots of apps for chest X-rays, CTs and all that. So we can't blindly trust it, but it can just help you a bit more better. So AI can't take over fully. It can be an invisible team member. That's my take on it.
Already in radiology, many AIs, they have not yet replaced, but AI is more than 90% of the radiologist's job has become less because they feed about 10,000 CT scans, 10,000 MRIs into the machine, and based on some, sir will be more specific in handling that. Based on some phenotypes, it predicts many differential diagnoses, and then the radiologist fixes on one, and then they close. Only one thing which is very, very confusing is AI is not liable. You cannot put a computer or an AI into court of law.
So at the same time, there was one study in Ames where they have tested a diagnostic accuracy of the X-ray AI versus doctors, radiology doctors who are probably residents. It showed AI-based the radiology reports are actually better than the residents. I mean, as far as probably the imaging is concerned, probably AI is slightly better as compared to the.
Obviously, I would
even
say.
it can pick up the subtle things which might not get picked by the junior most residents probably.
I would like to also address what the previous question, what she was trying to elaborate. I don't know why we are putting this game against AI and humans. I mean, that's an ignorant mind only can do. It's a software. AI is not going to replace humans. Get it? I mean, as far as my understanding goes, I have 28 years of working experience, parallelly in technology as well. I'm also a management guy. But take it from me very truthfully and fairly, it is not going to replace humans. It is going to replace mundane jobs. It is going to replace clerical jobs. It is going to replace repetitive tasks. You see? And the accuracy of the computer is far, far better than a human. That's the reason the predictions are far better than a human. The number of X-rays that are read through CNN model, that's what you are about to say. The computer vision is part of the artificial intelligence. Computer vision means reading images or anything that is in images. It can be, you can scan a form, it becomes an image, and in an IP form or a doctor note, it's an image and there are writings, right? And likewise, there is a film, so there is an image. So everything is scanned pixel by pixel, and the outcomes are also read. Likewise, 10,000 or 1 million X-rays if read, and if those things are changed into metrics and vectors, which a human cannot do ever. Forget junior person. Any senior person, consultant also cannot do. So the accuracy at which it identifies the past patterns to predict the existing one. Exceptions may happen, but very less. Given the volume of training that was given to the medical models, their predictions are way, way high. But now you should not bring this fairy tale inside. So since its prediction is far high, it is going to replace us. Never. There is something called human in the loop. Right? We are having guardrails and there is government. A machine cannot treat a human at all, and that's not going to happen.
Just adding on to what Sir said, the AI is better in pattern recognition and filtering through the data what it has been fed previously. So I just wanted to add one example if there is time permitting. So there was a patient, a 56-year-old, who slipped and fell, and she used her wrist to balance herself when she fell. So when she presented, she came with bilateral wrist, gross swelling was there. So we did an X-ray, and the X-ray was clinically very normal. So just out of curiosity, I just fed it into an AI to see what is the outcome it gets. So when we fed it with the history, elderly female, slip and fall, balanced on the hand. So X-ray, I want you to predict it out. It gave me a distal radius fracture. But then clinically there was no fracture. The X-ray did not show any fracture. So we had just put it back again. There is no cortical discontinuity that I could see in the X-ray, and clinically also I don't see anything. So can you just reassess this image and get back? So now the AI says, you are right. There is no cortical discontinuity that I see in the X-ray. So based on history that you gave me, the most common is the distal radius fracture. So I correlated the history along with the X-ray and I gave you a diagnosis. So you just cannot be always dependent on the image or the report that has been given by the AI, because the AI model, what you're using and how the data that has been fed to the AI, that matters very much. And as ER physicians, I think we are highly fueled physicians. So I don't think any AI can ever replace that. So it is always contextual based. It's not just a single decision what that comes out of an trained model. So that's it.
Great, that was a very great answer. Moving to the third part of our panel, AI-driven diagnostics, enhancing accuracy in emergency settings. What do you think how AI will outperform emergency physicians in ECG, radiology and imaging interpretation?
So I think we have discussed major part of this already. Yeah, so AI definitely helps us in pattern recognition, early diagnosis of complex cases where we might miss because of a high volume or fatigue. But then it should always be the physician driven, the physician opinion parallel to whatever the AI reporting should always be there. That is what I believe. So the AI can give you a simple diagnosis based on what is the data it has been trained on. So it cannot be completely dependent on. But then where centers where we have such high volumes, there are chances where as physicians we can miss certain things. And I'm sure AI will definitely help us in capturing those small nuances where we could fine tune the department.
Will AI reduce the diagnostic errors in emergency department or create new ones?
It goes both ways. The AI definitely gives us more accurate diagnosis where we could miss at times. But then again, the AI becomes the dependent source where the juniors are not getting more dependent on the AI. So the automation bias, like we say, becomes more evident. So there are chances where the automation bias can give us error. There is chances of a negative flagging, or there are chances where, like I mentioned in a case for an example, the AI tends to hallucinate at times. We still have that in most of the models. So there are chances that a wrong diagnosis is given and it is giving you a supportive, argumentative response also for the whatever the diagnosis that has been given. So I think the final decision should always be the physician's decision rather than total dependency on the AI. But yes, it definitely helps us in making a diagnosis.
Okay, so if this is going to be the case, so I moved on to the fourth part of the panel. If AI makes a mistake, who is legally responsible when AI makes a wrong clinical recommendation or a choice or a diagnosis? And what may be this is the question for you and for Sir, what are the futuristic cyber laws will come which can make AI a prisoner? This is for you. Yes, sir. So first question for you and second.
First question, before answering that question, so first to understand if you are going to implement AI-based algorithm, you have to understand who are all the people who are involved in that. So first is the AI designer. He gets a lot of data from all the databases, and then he creates the design. With that, some algorithm-based model comes, and then with that, it goes to the regulation department, then they get regulated, and then the institutions will try to implement that, and then last comes the clinicians who try to implement whatever the AI-based recommendations are being made. So the clinician are the person who are at the bedside who are going to take a last decision of whatever the AI is going to recommend. Okay, so almost Definitely, the one question is the AI is not human. As you all know, it is no brainer that AI is not going to be legally responsible. But if you see who are all the people involved, there are AI designers, there are institutions who will implement, who are going to implement, and then there are regulators, and then there are clinicians. But if you talk as we stand right now, of course, it is very well known that clinicians are going to be legally responsible for all the mishappenings if at all it is going to happen. But having said that, if we have a thinking that the AI is going to improve the healthcare, it is also our responsibility that the AI, the ethics of the AI is going to improve in some way. So one of the areas where I feel that instead of having a whole responsibility on the clinicians for all the mishappenings, it should be a shared responsibility model. So because if the AI is making some wrong recommendations, it could be due to the AI designers who designed it. It could be due to the data he fed, and then it could be due to the regulatory issues. It can be due to the institutions. Of course, it is again due to the, it can be due to the clinicians also. But going forward, I feel that the shared decision making, the shared responsibility model is a way to go forward. That's what I feel. What do you think?
I think so many things. Yes, sir, you're free to speak. So, in my mind and in my opinion, I think we are talking something which is never going to happen. So I don't know why we are talking about all this, that the AI will come take over us, and why AI, who's responsible? Of course you are responsible. How AI, a software can be responsible? A software can help you. Will you say that the digital pressure device problem, it is not my problem? We cannot say that. To the extent of what you use AI also is there. AI is going to be a tool. It is going to be an assistant. It is going to help you clear the blind spots that you have as a human. That's what AI is going to do. Now, unnecessarily, don't terrify yourself. Don't be so harsh on yourself. Just focus on your core clinical things, and nobody's going to compete you with that. At the end of the day, the connection, what you make with other human is more important, and all these tools are going to help you. If you want to say something, or no?
I just want to ask that, I feel, of course, the clinician is going to be responsible for whatever thing. If you share the responsibility, probably going forward, the things might evolve, and then I strongly believe that the AI is going to change the way we give a healthcare to the patients. And if you share the responsibility, so probably in every area, if they are going to take accountability, probably the healthcare probably might become
share the
better.
responsibility
In the sense that, for example, if everyone knows that if I am going to make a mistake based on the AI-based recommendation, I am going to sue. I will be legally responsible. The clinicians will have that fear. So the same, the commitment, the accountability should be there for the AI designers and the institutions. So what do you think about it?
No, AI. You're going to finish it?
Yeah. So, I just second what sir was saying. The AI is more of a software. So they are creating a product, and they have sold the product to us. So when we use the product, it is our responsibility. We cannot direct the responsibility
My question
otherwise.
is how we are going to make AI better.
That's what we can do is better documentation. What we are seeing is, for example, I see a case, we cannot get consent from each patient if I'm going to be using an AI. So it could be a blanket consent. But then again, the documentation that this case was opinion taken from an AI, the opinion of the AI, opinion of the physician, and maybe we can add the final decision, what was based, pro and con argumentative, why this decision was taken. The shared responsibility here becomes difficult because once the software has been done and handed over to us, I think it's a clinician's, I believe it's my point of view, that clinician's responsibility to validate it before we start trusting it blindly. So that is where the clinical acumen becomes more stronger for us, because we as a physician are the final decision makers. The AI is just to aid whatever the decision that we are taking so that we do not miss on the final details. But when it comes to legal and ethical responsibility, I think it lies with the physician and the hospital where we are practicing.
So nobody is going to call a AI software to the courtroom to give a verdict and you see, send it to prison. So it is always going to be a human. So that's how it's very simple that we have to think very in a simple manner. If at all if there is a threat, let me tell you, friends, there is one thing you have to be afraid of, which is you overusing AI and you losing your intuitive mind. Beware of that. That's very important. You use that as a tool. But at the same time, you don't become a slave to it. Writing letters, nobody, now if you ask anybody to write a letter, I don't think anybody can write a letter without an AI. I mean, you just replace that with the diagnosis of when looking at the X-ray. If you are going to look at the X-ray and you just follow the X-ray, what the outcome or impression the AI is going to tell, then you're going to lose your intuitive power. So, yeah. At this point in time, so that's that. I wanted to talk about this hallucination thing, which sir was saying. Any models will try to pretend like a human. Okay, there is also some marketing involved in these models. As far as AI is concerned, you have to understand there are models which are built by the big companies. And there is a provision that you can also build your own models. When you are building your own models, you have to be very, ethical, and you have to create an AI which is explainable and all that stuff. And you have to, have AI engineering, and data have to be very, very accurate. Data is very important. Else, your prediction of AI with your data, if the data is biased, then all your decisions will be also biased. So I don't think any small company would be able to create models like OpenAI, Grok, or Microsoft's Copilot. I don't think Gemini, only big people would be able to do that. And also you cannot check generally an X-ray, go to the OpenAI and ask to predict. It's not an AI made for that. You see, so there are a lot of models which are getting fine-tuned currently. Microsoft Azure is building a model. Gemini is for a long time building a model. They're all just reached 85% accuracy. 15% is too much. We cannot go into practice with 15% gap. For us, the failures are more important, not the successes, right? So it's still in the play. I'm working in a few AI projects, if you have time and your questions are there, where there are certain, I'm trying to write a solution to create discharge summaries. So the discharge summaries will be created reading the scanned case sheets. The time it takes to create a discharge summary, it's too long, and it really impacts the patient experience. So we are trying to read the scan sheets, and first the OCR, the optical character recognition, takes all the characters into the digital format. The moment that is done, then there is something called named entity recognition. So that NER is one model. There is a medical NER called MedSpacey, which we are using. What it does is it go read all the digital text, and it clubs like diagnosis items, complaint items, investigation items, drugs. So it classifies it, labels all that. And then I take that and I create a knowledge map and give it to the LLM. Second, I give it to the LLM to summarize sensibly, and I put a guardrail saying that confine it within this, should not go beyond that. So we have to put guardrails for hallucination. Even in your prompt writing, you have to have that very clearly. So yes, hallucinations are there, but the models are getting built. But to make use of the existing models, you also know how to do that, to avoid hallucination and appropriately use them.
So thank you, sir. We have come to the end of the panel. Just one take-home message from all the panelists, or one prediction of how AI is going to influence emergency medicine in the future, and the last message, from Leo sir.
I would like to say we can definitely use AI as an aid, not as a decision making, right? Because as what sir and all other panelists has told, it can never be legally held responsible, right? It's only you. It's like, you know, the man is one person who can save himself, right? So that was the last message from me. Thank you.
I just wanted to add with regards to the legal aspect there. So rather than using AI for a diagnosis, you can use it as a differential. Like for example, if you're using it as a diagnosis, then you go to court, yeah. But if you use it as a differential, for example, there are some apps which can tell you, like, if you put in the signs and symptoms, obviously you'll have to have your own set of differentials in your mind. And then when you put these signs and symptoms, it can give you some more differentials. It's just an eye-opener to think, oh, I didn't think of this really, should I actually look for other signs and symptoms? So you use it as an aid in your diagnosis, or even in your scans, like as sir said, there are I think the app was called QE AI. That's the chest X-ray app which was done in AIMS. So that, yeah, so if you use AI for diagnosis, then yes, it can go wrong if CTs and all are uploaded. But there is an app in the UK, so we use it in the UK. So hospitals, whoever is on call, the neurologist and all that, they'll have a separate phone for it. So here, when you do a CT, when you're doing for a cold stroke and all that, you'll have to ring the radiologist, ask them for a report, then ring the neurologist, get the report, ask for orders for lysis and all that. But there, what happens is normally this CT, when it's done, it gets uploaded into the phone automatically. Yeah, it goes into the app directly, and then your phone whoever has that phone, it starts ringing. So you can't just ignore their phone call. You literally have to attend the phone call. So the radiologist, the call goes to them automatically, and then the neurologist call goes to them automatically, and by the time you will get the reports in the phone. So what I want to say is, the humans are still involved in it. The AI just helps it move faster. So legally, you will not get caught if you do it in a, if you use the correct tool. If you use the wrong tool for diagnosis, then probably, yeah. So AI can never replace humans. It's just an aid, and because AI is more AI plus human, so you will have to have an augmented intelligence in ER, because you can never leave ER with just machines in it. Thank you.
So to coming to the $1,000,000 question that you asked us, will AI replace the doctors? So I was part of this trial called Rapid AI trial. I'm not sure how many of you have heard about it. It was something for the ER and the neurologist together. When a patient presents outside the window period, we do a perfusion study. The images are uploaded into the cloud. It goes directly to a California-based system where the AI diagnoses it, and we get the report back within 5 minutes. How much of the brain is salvageable and how much of the brain is not salvageable. Based on that, we used to decide about thrombectomy, mechanical thrombectomy. So when we started, obviously the radiologists were not very happy about it. So they did not want us to take it up, but then it was more of an academic work trial. We wanted to see how much it helps us in our daily practice. So we did this almost 3-4 years back when AI was still not that big on the social media hype and all that. So what we learned from the trial was, whatever the AI might give, but still it's always the physician's decision. After 4 years, it does not replace the radiologist, it does not replace the emergency physicians. It's I who see the patient, I put on the table, I run the image. Yes, the AI gives us a quick, faster resolution, but then again, we sit and discuss with the radiologist to see if it is 100% right. Is it worth going safely for the mechanical thrombectomy without a complication? So it is always the physician's decision, which is last. The AI is going to help you make your things better. The AI is not going to replace you when you know it to use it in the right way. That's my take.
I feel that the success of the healthcare depends upon the trust between the patient and doctor. Okay, so whenever you are going to use AI for whatever matter, please explain to the patient that what exactly you are going to do, that what information you are going to feed it in the AI, the first thing, and then what is the exact role of the AI in that patient, how the AI is going to help that, and what are the limitations of the AI, how we are going to address them. Please explain that and get a concern and then use AI, because whether the success of the AI in healthcare depends also on the trust of the patient. If the patient starts trusting the AI, if they feel that the AI is going to give a good health and then they are going to reduce the waiting time, so probably they will support. If they feel that if there is some trust issue for whatever matter, the AI is not going to develop in a healthcare. I always feel that the trust from the patient is also important for the development of the AI in healthcare. So as a clinician, it is also our responsibility to use the AI in a way that it should maintain the trust. And then because the most of the care of the patient is deeply personal. AI cannot go and give empathy, and then the AI cannot go and talk with the patient like a human. So you have to be in a situation that where you can use AI appropriately so that the patient gains trust. If that is going to happen, probably the future, probably 5 to 10 years, the AI is going to improve the healthcare. So the responsibility will, it is upon us to make sure that the patient will trust AI. That's what I feel.
Thank you all panelists. So final quick sum up by Leo sir, and we close the panel. Yes sir.
There is no end for human fear. That's all I can say about the fear that we have towards AI. AI will pose some problems, but AI is not a threat. It is a software created by us. Say it. If it's so bothering, say it 10 times a day. Affirm yourself as just a software created by us. It's not going to take over anything. It's going to assist us. I'll tell you where the problem might happen. There is something called agentic AIs. The AIs that you use are tools. They don't take decisions, but they assist you to take decisions. But there is something already has come, which is agentic AIs, where with the given data they would be able to take decisions. Correct? And it does that job. As of now, we have to see what kind of a problem this agentic AI is going to create. Forget medicine, it's not going to happen, there's going to be a lot of regulations. But for small talks, the tasks, definitely they're going to be agentic AIs. For example, let me tell you one problem which anybody can understand. You guys know programming languages, right? You all heard of Python, right? Correct? Python is one of the languages which is used for machine learning, and it contributed a lot for AI development. Fine. Now let's assume that we have created 10 agentic AIs. And all are designed to solve a problem. They are capable even to write a language, any language, because all trained. Now these 10 agentic AIs are working together, let's say, to solve a problem. And they find it difficult to solve that problem. Let's assume that one of the agentic AIs to the rest of the agentic AIs instruct. Probably we may need to create a new programming language. Correct? And if they design, and if they are capable to create a new programming language which we have never ever heard. There is something called, let's say, Cobra. I don't know whether there is a program. They create something and name it as Cobra. And if they solve a problem with that Cobra language, now how will you go and find how it's solved? It will create another problem to you. So this black box thing is going to be a challenge. So, but experts are working towards setting guardrails to limit the working of agentic AIs. But also it's not a software, you also have something in your mind. If you go plug the electricity, it's done, it's off, man. that's AI for you, as far as I am concerned. See, we have to adapt. AI is not coming, AI is already here. Doctors, consultants, everybody, every human being have to adapt to it. I would say this and close. This was said by Alvin Toffler a long time ago, and I was very impressed about it. He said this: the ignorant person in 21st century is not the one who doesn't know to read, write, or speak. It is the one who was enabled to learn, unlearn, and relearn. So this is going to be there forever. Learn, be aware of what is coming, and try to adapt. I mean, Charles Darwin said this. A lot of people quote Darwin wrongly, but Charles Darwin said this. it's not the strongest one which is going to survive. It is the one who is able to adapt going to survive. Charles Darwin. For that, I give it to you, sir.
Thank you, everybody. We have come to the end of the panel. Now we will be rotating a mic for your feedback about KEMCON. Sitaraman, thank you all panelists.
Thank you very much.
Can we have the trophies, please?
So nice sharing this discussion with you, sir. Ma'am, sir. Thank you, sir.
Now Leo sir will award a trophy to Dr. Neeraj Mangala. To Dr. Dinesh. To Dr. Sahitya. To Dr. Harris.
Yes, that trial was interesting. I have finished. Get it from me. Really?
And I would like to felicitate Dr. Leo sir by Dr. Sai Suresh.
Yeah. Thank you.
Thank you, dear delegates. Just we will have a quick feedback and we have 2 messages, and after that we'll end this session. We have tea outside. Introduce yourself and what do you feel about KEMCON and how do you feel about KEMCON?
Good evening, everyone. I am Dr. Vaishali, PNP Family Medicine trainee from Kamakshi Memorial Hospital. KEMCON was very useful for us. The workshops were excellent. We got hands-on training and all the procedures that generally we are supposed to be competent in. So that was very nice. The sessions were all very informative and useful to us. So as a family physician to be, these are all the things that we will be seeing in a primary setup. So as our HOD Ramya ma'am had said, this is a synergy between family medicine and emergency medicine. So we will be seeing all the emergency cases in the first hand and we will be the referral unit. So this was extremely useful for all of us. Thank you.
Yes. Next, anybody?
Hello everyone, I am Dr. Jansi. I am working in CMC Vellore as a non-PG registrar in surgical ICU. And about KEMCON, it was overall a wonderful session and it is very useful for all of us. And at last, the AI thing was the most admiring one.
Thank you, doctor. Anybody else from Chennai? One from Kamakshi we have got, one from CMC Vellore, one. Yes, yourself. Please introduce yourself.
Hi, I'm Dr. Jyotsna. I am in the process of approbation for Germany. I came to KEMCON because emergency medicine is a backbone of medicine and for my process as well, for my further studies, it's very important. And KEMCON consisted of all the key elements that we need to know in emergency medicine. Although I'm not yet in the process of emergency medicine or already a resident of emergency medicine, I could get a very good idea of almost all the key aspects of emergency medicine. It was very compact for the 2 days and it was perfectly done. I thank all the faculties and all the department members who have organized this. I know that it would have taken at least months or maybe some weeks, but you have put your all inside. All the best and congratulations and
Thank you very much. Thank you very much. Anybody else? Anybody else from not from Chennai or not from Kamakshi? You want different feedbacks from different strata? Please be frank. If we have done any mistakes or any shortcomings, sir, yourself, sir. Sir, yourself. Yourself, sir. To sir.
Hello, myself Dr. Murali Krishnan. I'm basically an anesthetist now working in ICU setup. Yeah, things are good. Last year also I attended. This year, yesterday, all the workstations they was conducted well. They were easily approachable, explaining things well, and they took time to impart the knowledge. Today also the topics, many, and I even was telling my colleagues that many of, not all the people who spoke today, they were all knowledgeable. They knew what they were doing, and as Dr. Sai was once telling, they could take the topic even for half a day. The neurology, ischemic stroke, or the nephro-urology person, and then the pediatric madam. So all were good, and they were able to compact and give it in a presentable manner in some 20 to 30 minutes. So overall, the show was good. Again, as my colleague, the junior girl, she told them, it took a lot of effort by the faculty, the team members, the junior doctors, the venue in Kamakshi and venue here. And venue here, even last year I attended, it was again spacious, it's good. And even the persons, the hotel persons are all friendly people. So overall, it was a successful run of the show. We want or we wish this sort of training to be done to doctors in the next many years.
Thank you, sir. Thank you. Fantastic. So, sir clearly explained the fabric of KEMCON. The basic idea of KEMCON is how minimally we can cost a conference, how maximally we can give benefits to every delegate who's attending it. That was our basic goal. Not to make any profit. It's a not-for-profit conference. Of course, we do get the registration fee, but it is whatever the cost per person, what we spend or we try to make it, it is just into 5 times what we spend per candidate, including from the mannequins you get, the faculties you get, the quality content, your CME credit, making all our teams work for it. Some things don't have any, cannot equate money with the effort. So our mission is to give the best with the facilities we had. Hope we have done some justice. Anybody else wants to speak or want any points to ponder or for the next KEMCON? So if it is done, please come to the stage. We'll have a group photograph and we'll exit. Please come. Tea is served outside. You can have the tea and you can take the certificates. Yes. Before that, I wanted to play a video. As I told you, we have MEM program running, and this is Dr. Sandeep Gore. This is Dr. Sandeep Gore, and he is the National Joint Secretary of SEMI. And we also welcome you to next year KEMCON 2027, and this is MCON 2026 in Mumbai. Yes.
Firstly, I congratulate Sai Surinder and Team Kamakshi Memorial Hospital for organizing the beautiful conference in emergency medicine called as KEMCON 2026. I am sure delegates, participants and faculties who were taking part in this academic event will have grand academic fest. I also take an opportunity to invite you all to Mumbai to participate in 20th National Conference of Emergency Medicine, MCON 2026. This will be the biggest ever academic event happening in India in specialty of emergency medicine. See you all there.
Thank you. Thank you. Please come to the stage. He is actually a mountaineer, so he has taken the flag somewhere high. Please come to the stage. We'll all have a group pic and we can leave. I invite all the faculty. Sahitya also, you can also please join us. Prashant, Harris, Vanga. Next 10 minutes, all disperse. அப்பதான் வேலை சரி டிராஃபிக்ல இருந்து தப்பிக்க முடியும். சீக்கிரம் வாங்க. Come up. One row up and one row down. One row at the front, one row at the back. Please come. Arun, please. Sir, please. I think everybody has to stand like that. எல்லாரும் போகும்போது ஒரு பூ எடுத்துக்கணும். காதுல வச்சுட்டு
Wait. Wait, sir.
ஏன் ஒயர் எடுக்கலையா?
ஒயர் எடுக்கலையா? நல்லா நேராக போய் முன்னாடி நின்று ஒயர் எடுக்கல எனக்கு. ஒயர் வரல, ஒயரெல்லாம் எடுத்தாச்சு. ஒயர் எங்கே இருக்குது? அப்படியே வெயிட் பண்ணுங்க. அதில் தம்ஸ் அப் பண்ண சொல்கிறீங்களா? இரு.
ஓகேவா?
ஓகே.
தேங்க்ஸ் சார்.
Thank you very much. எல்லாம் போட்டுக்கலாமா? Ready?